clot into the catheter. And guess what? So the incorporation of the thrombus is incomplete. And when you don't cork the thrombus and you just let the intermediate catheter, the chance of not ingesting the clot fully, and you have a part of the clot coming, but you see you can, no, okay, sorry, this one was the corking technique, okay? You see, was pinching the clot and removing everything. And I think it's the other one is, yes, and you see this is typically for me the technique. As soon as you feel the occlusion in the catheter, you let the stent out and you remove everything. This is the maximalist approach technique. And just a picture of it was the Solumra one. I wanted to show you that when you don't perform this, and this is making the Solumra technique now, do the same, but he will this time not, he will let the catheter in position, and you see when you let the catheter in position, you are losing a fragment. So very importantly, of course, when you are pinching the clot and you feel the stop of aspiration, you remove the entire system, letting the stent out of the system, so the best way, clearly, to perform the maximalist approach. Another demonstration is for the, and I think it's a video that illustrates how important the size should be. You see a distal M2 clot. You see this is a thrombus this is a catheter that is 033. So he's trying to get the thrombus and to aspire the thrombus here. And you see that despite the aspiration, it's blocking a little bit the thrombus here, but it's not big enough. So when the lumen of the aspiration is not big enough, you cannot remove properly a clot in aspiration. So the size is extremely important to get an efficient aspiration. Now, we will remove this catheter and push a larger catheter, 062, in this M2 artery. And you will see that it is exactly the same force of aspiration that will be applied. So we remove this 43 catheter from penumbra here. And just due to the size, because the technology is exactly the same, you will see that under aspiration now, just increasing the diameter here, now you are corking the entire system, and now you can remove things. So it's sure that the size plays a role. You can not put a 088 there, of course, but you need to think what is the size of the vessel in order to adapt the catheter if you want to have a better result with aspiration. So this is just to set the debate and to have this graph about the technique in aspiration and in stent reverb. And what we wanted to discuss it is what is the faculty strategy. In case you fail first time, what do you do next? That was the first point.
So no, I think that was nice. You gave us the overview of the two techniques and how you go around it. So I think we can carry on and go over to refractory clot section, and then we can have question answers. And I think Matthew and Atula, you were. Okay. So you come in here. All right. Oh, carry. So you can carry on with the second talk of yours.
No problem.
The refractory clot. Yeah. So.
Yes, so the question of refractory clot, it is a little bit that. So what happens when you are failing? So refractory clot can be in a different fashion, different types. And the example we decided to show you was a case of calcified emboli. I will show you this calcified emboli. That is always for us a challenge, but typically there is different way of solving difficult clot. One of the most difficult clots to solve is the calcified emboli. The calcified emboli is 1 to 3% of it's 1 to 3% of the presentation. So we'll show you something on that. On the calcified clot, yes, it is another drawing. No, doesn't. Sorry. Calcified clot. Calcified clot, yes. Okay. Calcified clot. Yes. This is another drawing regarding extremely refractory clot like the calcified clot. So the calcified clot strategy is not the same than the first drawing I show you, because you know that when you arrive into the angio suites, there is something special in this patient. Most of you, they are screening the stroke patient with a CT. So when it is a calcified clot, you just see it before you enter the angio suite. So you will not come with the same algorithm that to aspiration first line if it failed, to maximalist if it failed, do wide stenting if it's failing, test bypass, then coronary stent. But what you saw in the previous things is that our incremental strategy is always ending par intracranial stenting. I never go out of the angio suite with a failure without intracranial stenting. So if I fail, it's because the intracranial thing just failed. Okay, it's very interesting. It has been demonstrated in the literature that rescue stenting is much more efficient than just a failed thrombectomy, because you can get in a part of the patient a flow restoration. So here it's something different, because you arrive and you see the CT. We're just showing the CT, and you see that when you see the CT, you know it will not be a piece of cake. When you come to the angio suite, you know this will not be one aspiration that we just saw, and it's impossible. It will not work like that. So it is difficult. And we thought a lot with the faculty of the slides last time, so what could be the best way to address those calcified clot, those refractory clot? And basically, 3 things to know. They may be 1 to 3% of LVOs, so you will meet them for sure. The actual result of TK3 are 15%, so extremely low. It's always challenging. It's most of the time in a fragile patient. Why? Because you have calcification. You may have calcification at the bulb, calcification in the aorta, calcification in the valve. Those may happen post-coronarography, post-aortic surgery, post-TAVI, and very importantly, it's not really reported, but what I have observed in my institution, in the context of endocarditis. Okay. This has an implication, since when you remove the clot, it's so important, and it's calcified, important to send to bacteriology and anatomology, because we had many cases where it was an endocarditis discovered a few days after. It doesn't, it's not costly to send this as a bacteriology examination. So the difference we made is between M1 and M2. If the calcified clot is in M1, and in M2, both them, it is still worse to do an aspiration one pass or to do a maximalist approach. Why? Because the calcified stone could be linked to a piece of tissue. You could have calcification plus tissue. So the tissue may respond to aspiration or to stent river. The calcification will not. And then, if you succeed, that's fine, and then you may see that you have a tissue plus a calcification coming, but it's rare. Most of the time it doesn't work. And then you should have a plan for M1, a plan for M2. After you test your maximalist or your aspiration, the second technique we have seen to be the most efficient in the cath lab is the double stent technique. We did that and proceed to this test in the angio lab, and the best technique that was able to remove calcified clot was putting 2 stents. Why? Because the 2 stents, they are disconnecting the thrombus, the calcified things from the wall, and when you drag it, you have much more chance to remove, and I think to fail, we show something on the double stent, so I will not go further on that. But there is the clear potential to disconnect the stone from the wall, and you are embedding the stone in 2 stents, and you can remove it. So I would advise you to not waste too much time if it's a calcified stone by trying many, many things, because each pass, you are arming the vessel. Each pass. After 3 passes, 15% chance of iatrogenic dissection. You increase each pass the risk of hemorrhage. So it's game over after. When the vessel is too tired because of the attempt, I mean, you can do whatever you do, but it's finished. I mean, the vessel is killed. Okay, so you have to, that's why it was important, the previous incremental strategy, is because you don't have time to try 7 times the same things, because the vessel is aging. Each time you're trying, it is aging the vessel. You saw even the direct aspiration we have seen here, the previous case. The vessel was spasms. I mean, you do irritation. Always you do something, you do some irritation. So you have a limited number of attempts. So, and the rescue stenting is, in case the 2 stent doesn't work, we can bypass the stone by a rescue stenting maneuver. The rescue stenting could be a coronary stent, especially if it's in M1. So you create a channel, bridging the stone, and this is the best things to do in this case. When you are M2, you can go for aspiration, you can go for a closed basket distal tip like the Eric or the Vesalio stent in order to try to get it. This is in the literature as well, looks better. And you can also do a rescue stenting, typically with a laser cut stent. That's a little bit the algorithm we have. This is a little bit something a little bit different I show you since we had this stone. And here I perform like a Fogarty technique. Sorry, on this, you see I put a mini septer in the artery, and inflating the mini septer, I was able to incorporate, the calcified clot in a big aspiration catheter, and then to get the stone out. If you can see, and you see the form, you can see the shape of this. You see the balloon that is out, and you see here the piece of stone that we will push out. Yes, you see how it is? Yes, it is that kind of some stone. So this is a very experimental technique, but you can Fogarty also very difficult refractory clot. So this is just the introduction for the debate. I don't want to be long, but this is the spirit of it for me. Having an algorithm in your head when you're facing M1 occlusion, even if it looks perfectly okay, you know that boom, 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 you have something to go if it looks like a normal M1 occlusion, okay? And if you go into a special situation because you anticipate because of the imaging, because of the clinical presentation, then you'll have a special algorithm for that kind of occlusion. It was just an illustration to set the debate, not too long.
So, all right, so what we have been discussing is what should be the typical approach. All of us have different approaches, and I mean, Ajit started off by that whiteboard catheter. I think Vincent laid it out, all right, there can be 2 approaches. You can go for aspiration, stent it technique, but after 2 passes in their department, they switch over. Either they try the different techniques, and even then it fails, then you switch over to the rescue techniques. As you said, bypass techniques, you can try angioplasty, stenting, or you place a stent to bypass. And what he showed last part, when it's a calcified clot, then it's a very different picture. As soon as you see it, your strategy has to be completely different. And he showed how you can use a device like Ambotrap or 2 stent retrievers, or in this case, he used Fogarty technique. So we just want to lay out what are the different approaches, number one, how you start with, and if you're not succeeding, what are the other options which we have. All right, Matthew, what's your typical approach in your department? How do you really start off a typical thrombectomy case? Yeah.
So, Vipul, I've always told that we rely a lot on MR. So when we do an MR, we try to look as to what's the underlying pathology. For example, if we see lacunar strokes in the region that has been occluded, or for example, if we see there are some border zone infarcts, we actually today start them on tyrofuse even before we make the puncture. We are so sure that we are treating an underlying ICAD. In all these cases, as soon as we do a stent retriever as a first pass, we will invariably see a stenosis. We dilate right then and there, and we don't hesitate to put a stent if the lesion doesn't stay open. So on the other hand, we do situations. No, what I'm trying to say is, so for example, we see a blooming clot. We would now think that with the larger bore catheters, we can as well start with we still use Solumbra, when we think it's a pure RBC clot, you know. On the other hand, if I see an occlusion where there is absolutely no blooming at all, in that case, I will start first with aspiration. So technically what I said, at one point in time, we're using Solibra as a starting point. Today we start based on what we think is the underlying pathology, because we realize that they behave differently depending on what's occluding. And then if we fail, we would then, one of the things also we use styrofuse whenever we find opening and shutting down very fast, but then there is still a subset of case we are still not able to open.
So, okay, it's very interesting what Dr. Matthew is mentioning. In clot-based decision, that MR is blooming, is RB-rich clot, RBC-rich clot, or platelet-rich clot, and changing decision accordingly. So, Tufel, do you take care of MR and clot type to take a decision, or is it a standard approach in your department?
No, we don't do MR at all, okay? Because I think for us it would take a lot more time. I'm not convinced about that, the benefit, and as time is going, you want to get in there very quickly. So we don't do MR. Our protocol is CT, CTA, even perfusion we have stopped unless we need to, because now we know that you pretty much are doing a thrombectomy in most patients. So I would not do an MR. I just do CT and a CTA. What about you, Vincent?
So in France and in Switzerland, the dogma was to make MR, at the acute phase. So the problem of doing MR is that the in-hospital workflow cannot be as fast as the CT. I don't know if you saw the video we did with Slice on the stroke management, where we are showing all the mistakes we were used to do, and then we rewind, and then we go for the good things. Now we are doing direct to CT. And the average time we had for starting a thrombectomy in Montpellier with the normal workflow, all the mistakes we're doing, and the MR inside, because we're not maybe that fast at this moment, we're starting the puncture at maybe 1 hour and 20 minutes after the patient was entering the emergency department. Now when we go direct to CT, it is 9 minutes when the patient is entering the emergency. So the patient is with a significant neurological deficit, so we put him on the CT, and it is 9 minutes in average to have the diagnosis. And to start the lytics, 15 minutes, to stick the groin, 30 minutes, to stick the groin. So I think the CT now, I don't know, we have published the last trial data, people saw in the New England Journal of Medicine for the large core. So there is no need to make a specific triage with an advanced imaging of the brain parenchyma now. There is just you need to know if it's occluded, yes or not, in the first 7 hours. So it is streamlining all the decision making right now. So you put the patient in CT, see if there's no occlusion. There's no occlusion, then we go into the angio suite. So here we have stopped MR at the acute phase. In Montpellier, there is a lot of centers still doing MR, but for me, due to the last knowledge we have, especially with the large core trial we have performed in France and Spain, that is called LAST. I encourage you to read the results. It's impressive. In the first 7 hours, there is no need to make any triage, just to know if the vessel is occluded, because everybody is benefiting from the treatment.
Yeah. So,
and Vipul, one thing we don't understand, we see a lot more of ICAT in India than we see in the West. In our practice, 30% of the lesions in the anterior circulation is ICAT. In the posterior circulation is close to 100%.
All right.
And so this is something we have learned.
So
we realize that we learn techniques, but we improvise and improve on what we see with our own experiences.
So what we want to lay out for the audience is that number one thing, is it a typical clot or something atypical like calcified clot or ICAT coming in, right? So first clot, you may have your strategy. We have seen different strategies. In Vincent department, they have 2 strategies going for aspiration or stent removal, but be ready to switch over after 2 tries if it is not working out. Or Ajit has shown, maybe in future we'll be using it more wide bore catheters for all of them as go. But keep in mind, if it is calcified and it's a tough clot, as Vincent laid out, there are different strategies for that as well. And of course, we are going to discuss ICAT later on. And I think Tufel will come in, again, his approach for a tough clot of double stent retriever, how he uses it. Atulab, yeah, one comment. Tufel, you can come in here so that you can get started.
I will just add on that. Even on a plain CT, if you see a hyperdense MCS sign or a blooming artifact, I mean, that would suggest probably a fibrin clot more than a red blood cell clot. And before even that, like what he mentioned, most of these cardioembolic thrombus are tough. I mean, they are fibrin mostly, exception being atrial fibrillation. So there you have a relatively, easier evacuation. But otherwise, all these, if you have multiple risk factors, somebody is a diabetic for 10 years, say, hypertension. So if you have more than 3 risk factors, so probably you are going to encounter a fibrin clot.
Yeah, I mean, as I said, I mean, so Phil said, it's up for debate. In our department, we do take a decision at times depending on blooming, but we don't know really whether it really works. That is a topic to be explored of clot type and accordingly. But definitely when there's calcification, we have to have a different strategy. There's no means around it. And now I'll get to Phil going about what he does with tough clots. So we are passing over from regular clot to a tough clot, and then we go on to ICAD, which Matthew has mentioned. We see quite a few of ICAD in our country as well. Yeah, to Phil.
I'm still not convinced about MR, and I hope by end of the day somebody convinces me about MR. I'll leave it to Matthew. Okay. You've seen different approaches. I use double stent as my first pass. So I don't even piss around with trying to do aspiration. And one of the reasons is that you kind of are trying, first pass, second pass, third pass. Why not just go to the most difficult approach? And I don't think it is really a difficult approach at all. Double stent retriever was described around 2017, and you can see the outcome was significantly, seems to be better than doing it with a single stent or aspiration at that time. We're discussing only the technical side today. So how do I do it? Usually I have a balloon guide catheter here, and then this is what I do. I have two stents parallel to each other, one going into one M1, M2, second going into the other one. If it's in the basilar, I go on both sides, and then I will bring the stents together. You can do it, and yesterday Matthew mentioned he did cases where he has put 3 stents, and you can have obviously parallel stents. You can have one stent, 2 stents. You can have 3 stents. You can have 1 stent here, and then you can bring all together. But generally, what I do is the technique which is here. I have 1 stent here, 1 stent in the other one. How do I do it? And I think for me, it allows you to trap the clot much better, particularly in refractory clot. It removes any need for intermediate catheter, so I have no intermediate catheter. And you don't need distal aspiration, and you potentially, when you're aspirating, you can collapse the vessel sometimes, and you may not get the clot. All that is pretty much out of the window if you're using 2 stents. Of course, there is a risk when you're pulling 2 stents. You can cause damage, and you have to be very careful, and I'll show you a case, and then if you're not very careful, you can get into trouble. Then this is some of the data which Mark Ribot has published, and you can see between the first pass recanalization is what we are looking at, is you have a significantly better outcome with in terms of success outcome, in terms of between double stent retriever and single stent retriever, and you can see the difference here. So let's show you the first case. This is a 59-year-old man with hemiplegia, and like I said, in UK, pretty much CT is a main line. We don't do MRs in stroke at all. Also, technically, it's always difficult because MR is in a different part of the building, so I think time becomes an answer. So we have always done CT. So his NIHS is 17. You can see he's come in for a thrombectomy. As you can see, the CT doesn't look very bad here. You might have some ischemia around here. You can see that there is a M1 clot that you can see. And then look, in most of these patients, you will see the arches are, and in Indian patients, the vessels are much worse. Aspects of 5-6, right M1 occlusion, gets a thrombolysis, comes across, and this was done under local anesthetic. As you can see, you got a catheter here, and then you put 2 stents in. My approach now, I have changed from flow gate to walrus, more or less. If I get a walrus, I think walrus is I don't know whether it's available in India, but I think it's a much better aspiration catheter. But flow gate does the job too. The aim is to get 2 microcatheters across, and then I use a 6, and I can use a combination of different. I use a 6 and 4, but it depends on if it's a smaller vessel, I'll go for a 6, for a 440, and a bigger one, I'll put a 640. But I have used 2 6 also. And then you aspirate under balloon inflation. So here you can see you got a balloon right here, and then you have, most important thing is you get into the one branch. So you can see you got one branch, and you can see this another catheter. Don't remove your wire from the first catheter. That is very important, because if you remove the wire, then you lose the track of that branch. So you keep the wire in the first microcatheter, go into the other branch, and then you should be able to know that you are getting into 2 separate branches. So here you can see you have and then once you got one stent here, other stent is here, you got a balloon inflation in this place, and you can have the balloon in as far as you can get, and then you can have a single pass, and you can see you can remove everything together. Here you can see there is a small distal emboli in this case, and the patient did very well. And 24-hour CT, you can see a bit of a ischemia, but relatively done very well. And that's just 72 hours. Difficult access, if you don't always have to use a balloon proximally. Here is a patient in an 87-year-old. As you can see, she has multiple infarcts, M1 occlusion, and it's a very difficult access. Although I always try balloon, here I wasn't able to get the balloon up, and you can see the arteries were looking not very good. I managed to get a large catheter here. I think this was a Neuromax that you get in, and you can see you can literally get it around, and then you have an M1 occlusion here. So my technique would be get a so no distal access catheter, you get a 1 microcatheter here, and you find your way into another microcatheter across. You use a double stent, and one of the benefit of that is sometimes once you put the 2 stents in, you can pull your catheter up also. So you can use the stent to kind of take your proximal sheath up. And then you can see here I had to exchange, and I have used a solitaire 6x40 and 4x40. And then you can see your first microcatheter here. And it's very important for not to remove the wire. I'm kind of saying it again, because first time when you start and you're not sure, you land up taking the wire out, and then you don't know that you keep going into the same branch. So you leave it here. Sometime I will leave the talker also at the bottom. I usually, once I unsheath both the microcatheters, I usually put a talker on them, so that you know you got a very good control when you're removing the stents down. So basically at the groin I'll have a talker on. And here you can see again, your 2 branches here, and you can see that you can get the whole thing out pretty much, and you got a good result. So you can do this in tandem lesions. Here is a case where you got a stenosis, and it was difficult. I angioplasted that, and then I wanted to get in, but I couldn't get in. But eventually what I did was I put a stent in, and then as you can see, you can put the stent, and once you got a stent in, you can then take your access catheter distally. And again, one of the things that you need to do is you can then put 2 stents, as you can see, 1 stent here, other microcatheters here. Very important to use a lateral view, then you know you are in 2 separate branches, and you can then aspirate, or under aspiration, balloon inflation, you can get the 2 stents, and you can take them out. Last, can I do a second? So a complication, wrong stent. If you do this, here is a left M1, and you can see again, you can't see distally, and ideally I should have put 1 here and 1 here, but basically didn't realize that, and then you put both the stents into the same branch, and that's why lateral is very useful. As you can see, when you pull it out, you know you have dissected this branch, now don't go into this because you're going to get into trouble. So I had recognized that I have damaged the vessel and I did not get into it, and that patient didn't do very well. Thank you.
Thanks a lot, Tufail. So this is very interesting, from Ajit's wide bore catheter and no stent retriever to always two stent retrievers. So I have a couple of questions, Tufail. You mentioned 6x40 to 4x40 and 6x40. So any choice of stents here? I mean, how do you choose the size of the stent here?
So my go-to has always been the trevo or solitaire. So, and I think, not sure whether there is big difference. Personally, I don't feel there is much difference. And also because I am a primary double stent person. So I just don't faff around trying to get an aspiration catheter. I've got a distal access catheter, 2 microcatheters, and because I do it as a first pass, as a first technique, primary technique of double stentectomy, then I usually will go with a 6 or a 4. And to be honest, it depends. If I have a striker people in, I'll use a trevo. If I have a Medtronic people, I will use a Medtronic. Honestly, I don't feel there is a big difference between the solitaire and the trevo. They both do a good job. So I just used any of them.
And of course, double stent means MC and MC bifurcation. What about IC occlusion? In that case also you like to use 2 somehow or no?
I love IC occlusion. If I have a T occlusion, I think double stentectomy as a primary technique for me, the success rate is very high.
But where do you place the 2 stents?
So if I can get into the A1, yes.
All right.
If I don't get into the A1, I try to get into the ACA, but you sometimes don't know what that A1 is like. So I'm usually very careful with an A1 not to go with a 6. I usually will put a 4 in the left in the A1, and MCA will go with a 6.
All right. That's pretty interesting. And any question from the audience is, there.
So I just wanted to know what percentage of both symptomatic and asymptomatic hemorrhage post double stent retrievers, and if it's not working, like how many passes do you make with the double stent retriever, and had you any cases with stent interaction, like both got intertwinkled inside the vessel while pulling it out?
With the symptomatic hemorrhage, I don't think I've seen any significant difference in terms of primary stent, single stent versus double stentectomy. We've analyzed recently our data because I have 3 colleagues and now we got 2. One of them, I use double stentectomy as a primary, my other colleague doesn't use double stentectomy at all. So it's a very randomized control between the 2 of us. There is no difference between in terms of symptomatic hemorrhage. I've not had entanglement. What was the other question?
So how many times you pass the double stent?
Yes. So success rate for me, and we have looked at that too, my success rate, primary success rate in double stentectomy has been significantly higher as first pass technique compared to my colleague. But it doesn't always work. So I have had failures too. But usually by the second time you've done it, your heart cannot take any more. And once you know that if your double stents are not working, you're probably not going to work. So my threshold to do a 3rd or a 4th is very low, because when I can't get double stents in and can't take the clot out, I find it that nothing works. So usually for many people is a last stage attempt. If I have done it twice and if your double stent doesn't work, what is going to work? So some of them are just going to fail. I don't know whether you have a similar experience.
So to fail, what we do is, again, we go by the volume of clot.
Sorry?
I go by the volume of the clot. So if I see the thing is, because it's MR, we actually see the clot much better. So if we got somebody from the M1 going to the M2, then we use a double stent retriever, but it's just limited to the M1. I really don't think that's an advantage. So we do the classical Solemnum most of the time, like I said. So we are very, unlike what people believe, for us the whole MR protocol is 10 minutes. We have an MR attached to the ER. It doesn't take much of a difference between CT and MR in our center. No?
Recently, sorry, Vincent?
No, I
Yeah,
think
Vincent, yeah.
there is one very important point when achieving this technique, is that you put 2 microcatheter and you do not recross after opening the stent. I think it's important to say, because people may just say, I open one stent, then I take another micro and I'm crossing the first stent. So just to be said that it is increasing the risk of the procedure since you have to work to cross the first mesh. So if you do this technique, it's 2 independent microcatheter, 1 in each branch, and then you deliver the 2 stent after, just to say that.
Yeah, that's a good point.
Yeah, and secondly, there is something interesting, is that the article you showed on Mark Ribot paper is an in vitro study. So meaning that in vitro, it's much more efficient to put 2 stents than 1 stent. And it has been confirmed also with Professor Mackie in Geneva. He did the same independently, so it's much more efficient. But it doesn't take into account the potential endothelial damage that you may cause probably, in the patient, because it's a little bit more aggressive things. What they have shown in to answer to you, because what you are resolving into the double stent is the incertitude regarding the location of the clot in the M2 branch. We know that anatomically the angular artery is dominant in 60% to 70% of the case, and the clots tend to go in the inferior branch. And when you are doing properly the maximalist approach, normally you aim to go in the inferior branch, in the angular branch, because she's more likely to receive the clot. But this is not a systematic happening. So that means that it can go in the superior branch sometimes. So the double stent is reducing the hazards of not being in the major branch where the clot relies after the M1. So you are always grabbing the clot in these M2 segments. But in vitro, what is interesting, it is that it is increasing also the efficiency even for a pure M1 clot, because of it is embedding completely the clot and disconnecting the clot from the vessel wall. So there's 2 effects, reducing the hazard of the M2 location of the clot. Secondly, decreasing the circumferential contact of the clot with the vessel wall. Now, we're speaking about money. I mean, it's a 6,000, 7,000 first-line procedure, and that requires more technicity. So again, my point is that stroke has to be a wide spread technology in India, in France, in small centers, not in big university centers only, in all the small centers if you want to cover the services. And this is for me introducing a level of technicity that is refraining us from having a very large first-line approach for stroke. So I think this is good in your center to fail in your hands. This is good in many centers, but it will not be in the future the first-line approach of thrombectomy.
Yeah, I agree with Vincent that if you see in our talk, this comes under refractory clot category. I mean, we are not trying to say this should be the first approach. Okay, Tufel is doing it, very experienced, financial not issues, and maybe some Indian centers may also try it. But our attitude here in the meeting is to show these different approaches, and to us, it comes under the tough clot category. It's not coming out. Then one of the options, Vincent shows his option, and one of the options is double stent retriever. So since you are running quite late, Ajay, one comment, and then we go on to the next section.
So Dr. Tufel, for T occlusion, the clot might be just from the MCA to ICA, or it might be going into the ACA as well. So while trying going into the A1, you are not afraid of pushing the clot into A1, which was not there earlier. So as you said, like if it is a T occlusion, so in the first pass, do you go into both the branches, or you go just to the MCA, which is easier to go even with the 2 stents? Or you try to go into both?
No,
in the
preferably MCA, because ACA, going into ACA and pulling it, you are risking quite a lot. So on a CT, you can often see the clot from the T going into MCA, then often I will just put 2. But if I know that I have, and if I don't put I'll go with a microcatheter, like Vincent said. Most important thing is to make sure you are not going through the stent. You have 2 microcatheters in 2 sides. And if I do get into the ACA, then I'll go with a very small stent into the ACA. So and what I've done sometime, I've used a 17 system on the ACA side. And often ACA, I will go for a 17 catheter.
Yeah, so, that's a great point actually, and thanks Ajay to brought it up. But okay,
I'll just add.
One comment, yeah.
Just one comment. I mean, wonderful discussion. I mean, as far as future aspiration, stent retrieval, I mean, just experience. I mean, last year we happened to do, thrombus metagenomics, and we isolated 27 bacteria. So one point I want to make, like Coagulase positive Steph, It was in 8 refractory thrombus. I don't know. I mean, it's not that I can prove it, but something is coagulase positive residing in your thrombus. You need to probably look for new avenues.
Yeah, absolutely. Even Vincent mentioned that in calcified clots and all, think about infective endocarditis. There's a lot more to learn about clots.
Yes.
I mean, this is just an overview. I think one of the issues with the program, I discussed in Rashma, is just too long. We should have kept more time for discussion, but we are here. We are trying to do the best which we can do in a day. So we started from today from regular techniques. We saw from various masters different approaches they use, from whiteboard to do, and then we went to the difficult clots. To us, double stent retriever difficult clot strategy for Tufel is a first-line strategy, and now we go towards the underlying disease. Underlying disease when there is atherosclerotic occlusion. In the meantime, Tufel, you are one of the chairs. Aravind, you are one of the chairs for the next session, and Ajay as well. And here we discuss the atherosclerotic tandem occlusions when there is underlying disorders and dissections. And ICADs. I mean, this becomes the more tricky when we know there is something else beyond just the clot, and what can be the different strategies in this situation. And so, again, Vincent will give an overview of different strategies in tandem occlusions, and then we go on to dissections and ICAD. Thanks, Vincent.
Thank you, Tufel. So, the problem, Vipul, thank you very much. So the problem is that I hate the word tandem occlusion. I think it is an oversimplification. It doesn't mean anything. Tandem just means two. I mean, but what you have in front of you is a symptomatic carotid flow arrest. That's how the things are presenting to you. The patient is with the symptoms, and you go and you don't see the carotid. That's the way it is, okay? So now the question is, and I show this algorithm a lot in France and different places, and also in my team, because I want to make them very clear in their brain when they are watching the patient. So you arrive, you don't see the carotid, and there is neurological symptoms. So first things to do is really to look for intracranial occlusion. Okay, let me see if I can put some. Yes, okay. First thing is to look for intracranial occlusion. So if there is no brain vessel occlusion in the patient, so you have symptoms, you don't see the carotid, and you look the CTA, there is no intracranial occlusion. So now it is an hemodynamic treat, okay? It is an hemodynamic insufficiency due to the carotid occlusion. It is simplify a lot the decision making. There is a brain hemodynamic treat. You need to do only one thing, go to the angio suites, under local, restore the flow, open the carotid. Very simple. Decision making is very quick. If you now have a brain vessel occlusion, then you look the brain. If you see a T occlusion, you come back in the CTA, you don't see the T. So probably, and maybe 90% of the case, it's just a carotid stagnation. Okay? It's an over-diagnostic of a carotid occlusion because the T is blocked, the flow is blocked, so you see a false carotid occlusion, but because you saw a T into the brain, you go for a normal thrombectomy, a T thrombectomy, as usual. If you don't see the carotid, and you see a clot in M1, M2, M3, AC occlusion, now you know it cannot be an hemodynamic flow arrest. There is a problem on the carotid because the flow is not stopped by an M1 or an M2 occlusion. There is the A1 flowing, so if you don't see the carotid, it's because there is a problem at the level of the carotid for sure, 100%. Now you have to rule out the carotid, the cardioembolic occlusion of the carotid. Why? Because it requires a specific approach. I will discuss in 1 minute. It's different because the risk of recurrence rate during the thrombectomy, if you don't solve the neck, is very important. If it's not a carotid embolus, could be a carotid lesion. And then you have atheroma, it's the most frequent cause, the dissection, and the carotid web. So I love drawing, I love tables, but it makes it very simple in your head when you're facing a problem. So, boom, algorithm of decision, then it's pretty clear. You know what you have to do. So let me show you now different type of strategies. Since you are now in the cardioembolic, for example, let me show you the different type of occlusions. So there is the atheroma, first line. We'll discuss atheroma. and cardioembolic. So this is what I'm doing when I have atheroma. Again, I have this table, so I know I have a carotid lesion, and here is the typical sign. This is post-bulbar lesion, calcification, age below after 50, irregular, full stop, and the external carotid is completely free. Okay, very important compared to cardioembolic occlusion, because sometimes the luminogram cannot be easy to understand. So the key point for me is that the thrombus could be completely different, could be just a red cells clot, could be a piece of calcium, could be plaque debris, could be very tough to remove in the brain. Medical treatment only, if you just do not cure the carotid and it is atheroma, you have more than 18% risk of stroke recurrence at 3 months. So the message is to stent. Okay, and all the quote we have from Titan trial is that we should stent carotid in tandem occlusion due to atheromatic lesion, because the stroke recurrence is very high under just medical therapy. So favor stenting. So the first step for me when I got this tandem atheromatic occlusion is to go to the brain. And going to the brain may not be always so easy. An important tip and tricks we are using is that we are putting in the aspiration catheter a 4 mm angioplasty balloon, and with a small wire 014 we cross the lesion. We are inflating the balloon to dilate the lesion, and while deflating the angioplasty balloon, we are pushing over the balloon that is being deflated, the aspiration catheter, and then we are jumping toward the brain, okay? 4 mm balloon, during deflection we are pushing the intermediate catheter, we go to the skull base, okay? If the lesion is very hard to cross, I use the technique I have published already for the chronic total occlusion recanalization, using a 5 French sheet that is like a periscope, like the Merit, and it gives you a lot of stability entering the plaque. Because the drawback when it's too narrow is to have a luxation of your wire of the microcatheter into the external carotid artery. When you use this 5 French sheet, you can engage the plaque and you avoid the bulging in the external artery, so you are much stronger in order to cross. Once I cross with the wire, I make a bougie dilatation with the 5 French, and then I will put a 3 meter exchange to cure the carotid first line when it's too hard. Okay. Once you cross the carotid with the intermediate catheter, we go in the brain and under aspiration, because there may be thrombus in transit from ear to ear. The thrombus is there, but there could be some other thrombus in transit, so we go under aspiration. So you see we are blocking with the balloon catheter, the walrus or the concentric, and then we go under aspiration and we go up and back just to clean the carotid. Once it's okay, we go, we now make, and we see the flow coming back in the intermediate, then we do a small puff, then a run, and we have a good idea where the occlusion is, and we do a maximalist technique there most of the time. That is the stent placed after the thrombus, corking here and removing in one piece. So the third step for us in the atheromatic tandem occlusion is to cure the carotid. So we let the wire, and letting the wire, we come back under aspiration to clean the plaque. Why it's important to clean the plaque? Because if you don't clean the plaque, you may have instant reocclusion. And sometimes with the luminogram, it's hard to understand, so just pay attention if there is still clot on the plaque, yes or not. If there is not, we proceed to stenting using the cangrelor, IV, okay, that is a bolus of cangrelor in the patient, followed by the maintenance dose. And we are stenting the patient in 90% of the case. There is 10% of the case where the stroke was so large and we are deciding to not stent the carotid. It's extremely rare, okay? So then we are under aspiration with the balloon guided catheter inflated, putting the stent under reverse flow, no filter. No filter. So this is the strategy we have for the atheroma, and then we have the strategy for the cardioembolic.
Okay, Vincent,
Yeah,
I mean,
okay.
I'm interrupting you in between because let's just have a few minutes of discussion. To me, this was very interesting. So what he mentioned was there are 3 separate steps to it. how do you cross the lesion? This has always been a dilemma in my mind, atherosclerotic lesion. And when we started off, we were just taking guiding through, but whether that was disrupting the plaque a lot. I mean, it's already a ruptured plaque and you are pushing things through that. How do you go through that in a safe manner? The second step is how you get the intracranial clot out. And third step is what do you do about the stenosis in the end? So if I have to summarize what Vincent had mentioned is that he takes a balloon angioplasty of the plaque, and that partially inflated balloon he uses to take an aspiration catheter across. So this way you created a very smooth surface and you can enter without disrupting the plaque too much, and then he uses that aspiration catheter to clean the ICA. Do you take your guiding or balloon guiding across the tandem as well?
Okay, no, I don't cross with the balloon guiding catheter, just the intermediate catheter.
Just the intermediate catheter, and then it cleans the ICA. Even clots can be in the ICA. If you're using continuous aspiration, then you reach the brain, and then of course is a standard maximalist approach and clean out the MCA. And in the end, the dilemma is what to do the ICA. Clearly, literature shows stenting is good, it doesn't need to increase bleed rate. But in our experience, and what he does is, even while coming back, again aspiration through the stenosis with a wire across to clean the plaque, okay? To me, this is a very clean and looks like a very smart approach overall. And then he places the stent in the end. And now that's a question. Somehow, I think our patients comes in much later. We have had much more when you load with antiplatelet complications in my experience, maybe my Indian colleagues can say. And I thought that maybe the reason is that we are getting patients much later on an average, I guess, than in the Western population, and whether our infarcts are more evolved. So we have in our try to avoid stent. If we do angioplasty, we inject some antiplatelets in our center, and if it is remain stable, we'll let it be. But I don't know what the right answer is. And maybe our chairpersons can give a comment. I mean, do you always stent the carotid in the end or not? Just one point, sorry, and Vincent really pointed out, if it's very tough to cross, sometimes ICA is very angulated, it's calcified stenosis. You cannot take a wire and balloon across, so he uses a 5F catheter with a curved tip to hook the stenosis and then takes it across, and then it's the same method which is being followed. So stenting in the end, any comment from the chairpersons? Is it working? Come on, guys.
I want to comment on one.
Yeah, Arvind. Yeah, please.
See, crossing the technique that is told for crossing the tandem is fine. But in the real life scenario, identifying there is a tandem occlusion itself is a big thing. Because the calcification, if it is not there, then it would be difficult. So we need to study the CT angio properly. That is the crux of the matter. Then we can take these type of techniques. That is the first thing which I want to tell. The second is what Dr. Gupta told, that stenting in an acute setting. It is not just deploying the stent, even you have to look at the antiplatelet that you are going to give to the patients after the stenting. That strategy also is very important, because every case of acute stroke, whether it is justified to put on the antiplatelet agents, dual antiplatelet, especially when a stent is deployed, I am not sure about that.
I think very good. So, in fact, the first comment is what Dr. Vincent covered in his first slide. There's nothing like tandem. Patient doesn't get diagnosed as tandem. When there's an ICA flow arrest, as he mentioned, whether it's tandem, is a big clot sitting there, is it a dissection, is it a carotid web, that is something, is like a separate topic of its own. I wish we could have kept a separate talk on it, and what Arvind has very really laid out. Number two is the stent part, antiplatelet. We don't have Cangrelor in India, so, and it's pretty costly, I think even when you get it. So we use injectable antiplatelet agents, GP2B, 3B inhibitors, because if you give aspirin, Plavix, the stent is a ruptured, acutely ruptured plaque. If you're going to do stent, even for angioplasty, we do use an injectable agent. The only convenience is of not placing stent that we're not stuck with double antiplatelets. But as I said, there's a different, but the literature says stent is good with no increase in bleed rates. In our experience, we have seen some more complication than that. Yeah, Ajay, one comment.
Yeah, Dr. Vincent, the acute stenting, as we are saying in India, like we try to avoid as much as we can. So what is your take when the collaterals are good? After opening MCA, I know that collaterals are good through ACA or PCA or ACOM. So even then you take the decision for acute stenting if upstairs things are being perfused from the pile collaterals. And before putting in stent in the ipsilateral carotid, do you check all those collaterals?
Okay, so for the atheroma, the situation where the carotid is the reason for the brain suffering itself, it's quite rare, okay? So when you do the brain imaging at the acute phase, you can have sometime an idea, because of if the question is, do we have an hemodynamic treat due to the carotid occlusion, or just it's the circular fullis is okay and just the M1 is the reason of the ischemia? I think 90% of the case, it's the M1 occlusion that is the reason of the ischemia. And if you just remove the clot in M1, then the polygon of the Willis is okay in atheroma. But the question is, what is the stroke recurrence rate when you don't treat the carotid in a patient? So what the data show that you have 18% recurrence rate at 3 months when you just keep on doing under medical therapy. Whereas, for example, if you go for dissection, under medical therapy, there is less than 3% risk of stroke recurrence under medical therapy. So the big balance between 18% stroke recurrence due to atheroma and 2% due to dissection make us more, push us to stent more quickly the carotid and to the dissection to be extremely respectful. So that's the first point.
And that's why, in fact, our next section, dissection, and Ajay, you brought it up, literature clearly favors stent in carotid, maybe because some cases there's embolism happening actually. It's not the hemodynamic reason, while a dissection. So in fact, we can address this stent or not stent because next section is dissection. And so if Vincent, you're okay, I present some dissection video, and then we can have the discussion about stenting in these situations as well. I know each of these we can discuss to a long length, but we have to move on.
Just one small thing. See, there's a difference I do from what Vincent does. Whenever I have an ICU occlusion, Arvind, by default, I think all of them have got underlying stenosis, so that the protocol doesn't change. We always have a 70 cm 9 French sheath in the common carotid whenever I have an ICU occlusion. We take the long sheet, that's the Infinity Plus or the Seri base, over the 4 mm balloon. We do not directly take the aspiration catheter. We use that as aspiration catheter to start with. We find it's a bigger bore. The reason we have the 9 French sheath is now, if the sheath is blocked, I can still pull it back into the 9 French sheath and I do not lose access. Other than that, it's exactly the same. In India, I think all of us have realized that stenting in the acute setting has more reperfusion hemorrhage. So like all of you all, we wait and watch. If things are holding, we would do an elective stenting. Even a week or 10 days later, I find is much safer than going immediately. That's our experience in our center.
Just to tell you, there is a randomized control trial called Titans that is testing stenting acute failure versus no stenting. And the largest cohort we have from Titans regarding so-called tandem occlusion show the superiority in terms of treatment outcome for the stenting group. But it is a cohort. It's not a randomized control trial. That's why also we are doing that. And it's amazing because the subgroup of this section does not show any benefit of stenting.
But also the volume of infarct finally matters too. You know, that's one thing we can't exclude.
Yeah, okay, so we'll go on. That's very important. So sometimes before stenting or not stenting, we do angio-CT. Lot of enhancement and all, it gets us worried, particularly basal ganglia involvement. Raj Nivas always points me out. And these are the occlusions in which when you put double interval, more chances of bleed. So we do that. We take all this into consider, how long we have taken to reconnect, how long is the stroke, how big is the infarct, whether there's enhancement or not. So yeah, but literature favors stenting. I mean, it seems. And in Western world, they are stenting, most of them, it seems. But as I said, yes, in India, maybe we are having slightly different experience. So video will play by itself, and how do I stop it in between if I want to? Next. Actually, it's one single video. How can I pause and play at between?
But you're right to say that it depends also maybe of the time of the presentation. If you have a cohort of people arriving in the first 7 hours, you may see that stenting is extremely favorable. If you have people maybe after 13, 15 hours, you may not show exactly the same results. So I understand why you have this feedback if you're saying that the patient is very, very late. So maybe sometimes we are refraining from stenting in our institution too when I see the risk of hemorrhage transformation is too high.
Vincent, you give cangrelon.
Okay, so
You give cangrelon if you're putting a stent.
Yes.
I give IV aspirin, and I don't do anything else acutely. And I then put them on Plavix afterwards. So I'm not very aggressive giving anticoagulant. I don't even give heparin. So I haven't seen any significant difference.
I would say in India we see such exuberant clot formation in all our
Sure,
cases.
sure.
Even we don't do stenting, we end up using some degree of injectable antiplatelets like tirofiban or something. I mean, Raj Nivas is also here. But again, that's a different section. Which antiplatelet? Again, there is no clear guidelines or data to it. In our experience, you have to use some injectable antiplatelet agents on that ruptured plaque. Maybe in India, arteries are different. Our arteries are probably more thrombogenic. We see exuberant clot formation most of the time.
Probably, but I don't think we know.
We don't have IBS in
Okay.
India anyway. Yeah, we don't know.
Everybody gives very different things. People
Absolutely.
give IV terifluban, and I think that's what compounds the whole idea about reperfusion hemorrhage.
Yeah. All right. You're right here, but I guess let's go on to the next. We are running quite late. Yes, Vincent.
Just one point for the cangrelor. The cangrelor, the beauty is the PY12 inhibitor you give IV, and we have a PY12 machine to test live. That means it's less aggressive than aspirin. Aspirin, sometimes you have hyperresponder, so you can set 30% of platelet inhibition in the angio suite. 30%. 40%, not 100%. So when you master the cangrelor IV, you can tailor exactly the target platelet inhibition rate you want.
All right, so we go on to the next case. Is a 56-year-old male and right-sided weakness, aphasia, NHS 16. He was thrombolized and scheduled for thrombectomy. Video. No, but how do I pause it? All right. So this is the CT angio, and it showed left ICA occlusion, small infarct. That's the AMR. Can we speed up the video? Okay. So this is the neuron max guiding we took in, and we did try to aspirate a bit. That's not going to work. So in this case, there was a tapered occlusion on the CT angio, and we strongly suspect it's probably a young man. Uncontrolled hypertension is a dissection or not. You can see there's a large amount of clot sitting there. This is the other view showing again the same IC occlusion. Rashni was the guy with me doing it. We did check for collateral in these cases. This patient was a poor patient. We knew stenting going to be an issue. So we knew there was a great ACOM. So the first was, okay, that, all right, stop it. All right, etiology here, whether, all right, we go back. Again, etiology, what would one suspect? Is a dissection, or is a large clot sitting in the ICA, or is ICAD? Matthew, I mean, what would you thinking of at this point of time?
No, I mean, the history is very suggestive of dissection.
Yeah.
So I would still start with, see, for me, I always look at the MR. If the T1 is showing hyperintensity, I would always think.
Right.
But having said that, I would probe with a wire. I will not be aggressive. I'll gently try to see how the wire moves. The wire is your finger. Is it making a loop there? Am I making a dissection burst? But I will definitely try to cross it, the wire.
Yeah. So we tried crossing it with the wire. All right. Initially, we give one try, and we use the same approach as Vincent mentioned. We use a 5F catheter to angulate and try to cross it, but with the regular 3-5, we just couldn't cross it. So we switched over, but we did take a neuron max a bit in to help us there, and then we decided we tried. It didn't work out. Then we switched to a micro catheter with the Traxxas wire, and it seems once you can always get a feel when you reach a lumen, it became free, and we thought probably we are in the lumen patent artery above. and that's a microcatheter. We could track it. As you could see, most of these cases we do under local anesthesia. Vincent did mention maybe in tandems we can switch to general anesthesia as well. So once the microcatheter is there, we are almost to the cavernous segment. We've gone through the petrous and laceral segment, and we want to check whether we are in the true lumen or not in this patient. Yeah, it was quite free and in both planes. And then we knew we wanted to get a guide systems up there. Okay, so initially we tried whether with an aspiration catheter we can go over the microcatheter, and so we tried over a bigger microcatheter whether we can take our aspiration catheter, but somehow I think the underlying tortuosity of the ICA, we were not successful. And we tried quite a few times, it didn't work out. No, we thought this is dissection, so there's no point. All right, so we took a 4-4 over a stiff wire, and then we took a Navian. I mean, that can something which we can discuss. And once that system was there, and we took a Navian catheter up, and you can see and we took an Emplart's wire in that 4-4, and then we could get our systems up there, because I want a good base camp up there in the petrous ICA to do the intracranial thrombectomy. So that was 4-4 with Emplart's wire and then Navian, and then we could target the neuron max. I took it across in this case. Vincent mentioned we went across because I thought I'm not going to cross this lesion again and again. And then it's a standard thrombectomy technique. So we again, sometimes crossing the clot can be an issue. We just push the microcatheter, it went through easily. And we deployed the solitaire, I think 440 in this patient. I think that's React 7.1. It navigated pretty easily, but it's great to have this great base camp of neuron max in the petrous ICA. And whether I think I can just speed up a bit. No, I'm not able to. No, I can't change the speed of the video. And we checked. This is a standard approach. We just give a very small dye injection to know when the patent artery, and then deployed the solitaire 440. We sort of use push and fluff technique. We deploy the initial part, and then we tend to push out the solitaire, try to engage the clot a bit more, and then we take out the micro and take the aspiration catheter a bit more to try to pinch the clot a bit with the aspiration. And then we wait for a while and take out the whole thing. So in a way, that's our standard approach in most of our cases anyway. And we take it out slowly. We don't pull out very suddenly. And under aspiration, with both the neuron max and the aspiration catheter, okay, we get a great recanalization. And now the question which we were discussing, to stent or not, what to do with the lesion here. Since we were suppressing dissection, you could see the artery is probably loopy. And we were happy there was no major embolism. The ACOM is patent. Most of the arteries are patent. We have already checked there was a great ACOM in this patient. Okay. And doing aspiration, yes, we aspirated when we brought it out. In fact, what step we have missed, we kept the wire initially, traxus wire, to have an access. This is later on when we had finished the procedure, we took out the whole thing. And IC is still occluded. It's a typical thing, it's beyond the blood tapered or closure. And we know it's a loopy artery, will mean placing multiple stents. There's a great ACOM present here, which takes care of the perfusion, and we didn't do stent. As Vincent himself mentioned, in dissections, the data is clear. I'm sorry, it's coming out as native. So all arteries were filling very well from the ACOM region. And that's the CT scan of the patient. It showed only a small infarction. He made a dramatic recovery, actually. Thankfully, it didn't take us much time. So in dissections, we don't try to stent because the data clear. When there's a great ACOM, and stenting here is complicated. It's a loopy artery, will need multiple overlapping stents, and okay, it's playing again. So, and we are, all right, so in this kind of case, we avoid stenting in dissection patients. So
So that is the answer to the previous question.
Previous question, yes, yes, yes.
If the collaterals are good and.
So in dissections, number one, okay, stenting is complete. In dissection, the data is clear that stenting doesn't add to the benefit. Okay, there may be situation, we'll show you a short case, when dissection is a hemodynamic problem. And that's the impression of the hemodynamic issue when we need to stent. So in dissections, usual approach is avoid stenting, as I said. The data is clear, there's grade A, comp, econ. Medical therapy, the recurrence rate is pretty low. Vis-a-vis, as Vincent mentioned, in tandem occlusions on medical therapy, the repeat stroke rate is quite high. So yes, in you go by literature, in ICA stenosis, if you are in trouble and it's not remaining patent, stenting is the answer. While dissections, in most of these cases, we can avoid it. Yeah, Tufail, I think you want to say something.
I'm not sure. I think I would have stented that because the patient on the table and you still have collateral, you don't know whether he still has got hemodynamic, still compromise. In terms of clinically, that might not be enough. And you don't know that. So when you have already crossed that, and you already got a very good access, and the patient was 3.5 hours, this patient was 3.5 hours with a very good, very good aspect score. You may argue, why do you want to not keep that artery open? Because you know when you come out, you're going to lose that artery. So, and that's what has happened. So I take your point, but I probably would have landed up putting a stent there.
Okay, let me talk to you
And I'm
practically.
just not,
It's a great ACOM. I checked the venous delay. There was no venous delay on the other side. To me, like in carotid occlusion, yeah, we won't stent it, number one. Number two, stenting here means multiple stents. Number three, patient didn't have money. Even thrombectomy, we had to get the devices free. So I was very happy I didn't have to stent. So let's talk about practical
I understand.
situations there. Yeah.
But
yeah, you want to place stents, you don't know what you are entering into.
Yeah, so for me, the bleeds post-stenting, and some of them are terrible ones. So the choice is, will he reinfarct versus a bleed? The chances of him reinfarct is very low, very good ACOM. I could see that the vessels are filling. I think your venous phase would have been almost instantaneous.
Yeah.
Seriously, I would just wait.
Yeah, I think, Vincent, please agree with me.
Yes, I think the data are pretty clear. I mean, if you let a dissected vessel in position under medical therapy, you can fear things, but the data is less than 3% stroke recurrence rate at 3 months. This is the data. They are young patients most of the time, so the collateral flow is extremely efficient. Letting an occlude carotid at 70 years old is maybe much more risky than at 40 because the readaptation and the cross flow we saw was just very strong. You know, when we tried to make the flow, the run into the MCA, it was washed like never on the. So I would have done the same in terms of not stenting. And again, you are saying we can just drop a stent. We cannot just drop a stent. I think the maneuver he did with the penumbra to the skull base has boosted the dissection to the skull base. It's like 4 stents. And believe me, I'm doing carotid reconstruction a lot. Here you cannot sort with just 1 stent. You need 4 stents. 4 stents, just aspirin. What do you do? No, here you have to be with
loading with drugs.
Yeah, you have to be very aggressive after oriented therapy. Huh?
Okay, so let's have a raise of hands here among the audience. How many of you stent the atherosclerotic tandem occlusions first approach as stenting? How many of you? I'm raising hand just to ask. I don't do it. All right. So yeah. All right, few. And what about the dissections? You like to stent them after recanalizations?
Actually, the question would have been like the collaterals plus tandem occlusion. The collaterals are there because individual patient.
Ajay, you always ask a question which tells us to go to the next case. So let me start the next case. About some of you know what's going to come, right?
Yeah, I don't know.
You know, he's a good friend of mine. He knows what I'm going to do. So let me just quickly go to the next case.
I just wanted to add one thing for the residents and newcomers. This case was very beautifully done by Dr. Vipul, which is very much expected. But the use of implants in the carotid system has to be very much cautiously. And you might not have focused on that Dr. Vipul never took out the implants out of the catheter. it was just inside. So you have to take care of this point, that implants has to be inside the catheter. You are just supporting it from inside.
Yeah.
The implant tip should not come out because it will perforate, it will dissect further. So this is something which I wanted to add
Absolutely.
for
I
the
think that's a
residents.
very, very pertinent point. Hair crossing was a big challenge. We changed from micro to bigger micro to a stiff wire, then 4/4, then Navian. But I didn't want to cross this lesion again. If I cross it with the aspiration catheter, I do thrombectomy, but I lose the access, it's going to be a challenge to get in again. So let me go on to the next case.
Vipul, can I ask you a question there?
Yeah, please.
So in your case, once you had recanalized, you had kept the wire up, so and then you did all your runs, you knew the artery was occluded.
Oh, yes.
Yeah, but then you went on the right side.
Oh, no, okay, so right side we had checked before, because see, okay, this patient is a worker brought in by his colleagues, had no money, and this is real life, right? Now, how do I say no to a young guy with few hours of stroke and no money, no family there, but how do you say no? So we just decided to go ahead with it anyway, and in Indian circumstances, so it was in my mind, if I come to stenting, I'm in trouble, there is no money. Thrombectomy I can manage. So we checked the ACOM beforehand. I knew there was a great ACOM, so we had checked it beforehand. Only thing is, and we kept the wire across. So in all these tandems, we keep wire across, we withdraw the guiding so we have an access, but we have checked the ACOM beforehand, that is great, okay? So we knew that. In fact, I showed you, I went through quickly, we took a quick run of right, I said there's a great collateral and MC occlusion, so it was in my mind, as long as this man, poor man, I can just get the MC clot out, maybe.
Sure, but my question to you is, if the ACOM wasn't there, and the collateral wasn't very good,
Then hospital will have cut off half of my
then you're obliged to stent it. So I think your point is well taken. I take the point that if you got good collateral, then you may consider not to stent. I may not agree, but that's a good point. But if you don't have a good collateral, and if the patient is in the general anesthetic and you don't know how his NIHS is going to be, how improvement is, then you are potentially risking.
And you realize in Indian circumstances, like Vincent mentioned, 4 stents in acute situation, it can be trouble. So let's go on to the next one.
Dr. Vipul, just one thing.
I'm sorry, Matthew, we are running
I
late.
just want to tell, I always keep a second catheter on a lesion like this. I do not come up without seeing that last bit.
I'm not able to stop this somehow. Okay, so this is another patient, fluctuating patient. Again, we took a contralateral injection, so some watershed infarctions. And there is ACOM here, but doesn't look that great. Okay, this is the key here. You can see some delay on the right side. He was fluctuating. We tried to keep him conservative. We checked for the PCOM quickly. Again, some left-meningeal collaterals. And this looks like, okay, this is what dissection would look like. ICA, tapered off, narrowing, what we should call as rectal appearance. So should we just increase the blood pressure or we do ahead with stenting? We had kept this patient conservative. He was not. So we took excess 9F short sheath, balloon guiding 8F walrus. We want to be ready for a stenting if need be. And then initially we took aspiration catheter. So that's the guiding and under inflation of the balloon in the proximal IC. I didn't want more distal embolism. MCF was patent, right? We just took the Sophia across while aspirating. Something like what Vincent mentioned, goes across the stenosis, keep aspirating through the ICA. And then we took another run. You can see some flow in the IC. We can see the dissection there as well. And then we decided here is not going to work out. Matthew, as you mentioned, angioplasty. He knew this is hemodynamic issue. And you can see a false lumen there. When we cross with the Sophia, so you have to be very careful. Vincent discussing how to find the true lumen in dissection. It's kind of a separate topic. You have to be very careful to go through the true lumen. And then we did some angioplasty. But you see, we kept the balloon guiding inflated. I didn't want to have more embolism going in while I'm doing all. It's like proximal control, proximal flow arrest. Angioplasty doesn't really matter much, I guess, in these cases. And we use a 740 wall stent. Wall stents are useful. They can become much longer than 30 or 40 carotids. And they're pretty easy to manipulate. Sometimes they use a coronary stiff wire to keep them stable. Sometimes tortuous arteries is useful. And then we deployed it and did some more angioplasty. So this is the classical case of hemodynamic. In these cases, there is no choice. And we reconstructed the artery. and patient did pretty well. So these are the situation dissection when you see more dynamic. Then we have to switch to stenting, and I'm very sorry, we just are running out of time. We have a long program, so we'll switch on to the next section, which is ICAD. We can have one comment. When I say no comment, nobody wants to comment. Yeah, just to show the crowd, I mean other people, that yes, there are situations we have to be at stenting, and what approach we take in these cases, balloon guiding, initial one aspiration maybe, but under balloon guiding aspiration, and when we love to use wall stents, because they can be, even Rene Chapeau has shown he takes wall stent up to the petrous IC as well, and these are much cheaper than trying to use our neuro stents in these kind of situations. Now, we went from tandem to dissection, and one comment from Vincent about the technique in dissection. Anything you say, message to the youngsters when you're crossing or doing stenting, one something you have to really take care of.
Yes, maybe the idea of dissection is that everything relies in crossing the lesion, because the thrombus is always fresh. You should not expect like a hard clot, like a piece of stone, like a very bad thrombus to remove. The thrombus is extremely fresh. So if you go through this section, is 90% thrombectomy success. So the only thing you have to go is to go through. To go through, the idea that you should go with a big G-shaped catheter is a false idea, since you can jump into the false lumen doing this blindly, and then you can worsen the false hematoma and close the true lumen and close the case. So I advise you to be very gentle with the microcatheter, to make rotate your wire while you are crossing the lesion, and if you're still stuck too long, it's that you are on the false lumen, so you can remove and try again. There is a tip and trick that is good to cross them, is to inflate the balloon guiding catheter, to push a little bit of contrast, to let the contrast like this, because slowly you may see one part is going in the false lumen and the other may show you the true lumen, so you just have, even if you're under local, to follow the stagnating contrast column into the true lumen. There is another tip and tricks by Jan Grala that is interesting. When he cannot see it, he do a flow reversal into the balloon guiding catheter. He call this the sailing technique, because he's reversing a little bit the flap of the dissection before going forward.
Great. So, I mean, what on your trips to cross? In the first case, using the Terumo wire wasn't a great idea. We probably just made it worse. So, the last part on technical discussion is the ICAD, and just presenting a case, and then we can discuss. And this was a lady, you can see, left MCA infarctions. And you can see a tapered closure of the ICA here with great collaterals. Whenever you see something like that, we think whether it's ICAD, because it already developed some great collaterals. If you see calcifications, you know much better. It was kind of slightly tortuous anatomy, and I think this is the diagnostic catheter, and followed by our long guide over an aspiration catheter. And so if you even think ICAD, great collaterals again, but should we do a debulking? Should we do straight away angioplasty? I mean, okay, the literature says aspiration doesn't work very well. So we always do one pass of thrombectomy, all right, with a stent retriever. I mean, because aspiration catheter wouldn't fit into a tapered origin. It's better to do a thrombectomy if you're doing debulking rather than anything else. So that's the aspiration catheter along with the stent retriever. I wish I could have, okay. And then we take it out. And then the run shows that yes, it's patent, but we can see the stenosis right there. One can wait for a while, but it's a tight stenosis. Do angioplasty and see if you can get away with it. Again, literature favors that patency is much better using stents and injectable agents. So now we know likely it's ICAD, the tapered origin we saw from before. We were planning for it. So as I said, one can do just balloon angioplasty. We can skip this part because of the time. One may think about direct stent, angioplasty, or just wait and watch with antiplatelet. But you know, tight stenosis, they tend to go. We waited for a while, it tends to close down in 10 to 15 minutes. At least they need angioplasty and some injectable antiplatelet agents in our experience. Okay? So, now you have to be ready for a stent placement. So, and we love to have guidings high up there. We do slow angioplasty with a very small balloon, and then we try to wait and watch in such situations. So Solitaire 440 was used previously, so that's a balloon being taken. I think initially we took a 1.5 millimeter balloon just to do a small angioplasty. My colleague Dr. Rashnivas had done this procedure, and small angioplasty, and then we see whether it remains patent with some injectable agents. But it wasn't, I've not shown the pictures, it was tending to collapse back. So we decided to go ahead with the stenting. Before placing the stent, we had done an angioplasty with 2 millimeter balloon. It's great to have you guiding up there at the bifurcation, if one can see this thing. All right. You can't get the marker in. And have guiding right at the IC bifurcation, as one can see there. All right. So what we did is CT before doing stent, just to see if there's too much enhancement or no bleed at that point of time. We injected antiplatelet agents. And in this case, one can debate between balloon mounted or self-expanding, but we used a credo stent here. Now, if you can see already, it seems we have placed it quite distally in the ICA. The proximal part wasn't really looking that well open. So initially the flow is now good. Yeah, let's go. I'm not able to the video at all. And usually we don't like to cross ever with self-expanding stents, but in this case, it felt the artery was collapsing back. I had no choice, so used another balloon, a new balloon now, and we crossed the stent again with a very fine wire. I used actually a avium wire, took a microcatheter across, exchanged with a Traxus, because I didn't want to dislodge the stent, and then we did another angioplasty. I didn't reuse the older balloons which I have already used. And we did with another new balloon, 2 millimeter balloon, angioplasty of the stent. We kept the balloon there, took a run, it remained fine. We looked at multiple angles. There was some spasm in the artery there. We did another CT on the table. You can see dense enhancement, but no bleed. And I think we did a check angiogram which looked later on pretty fine. Okay, so clearly in this case, if you see, yeah. No, this is, oh, let it be. No, but that takes too much time, right? No, let it be. All right, let it be. All right. So, okay, I went through this case a little quickly. Let it be, let it be, let it be. Can we just stop the video? Just stop the video. So, coming to the ICAD, all right. So, ICAD, as I mentioned, we do a thrombectomy one pass first. First is suspicion of ICAD, because straight away strategy changes. You have to be ready to get a guiding eye up. First pass with a solitaire. Literature says stent and injectable agents have best patency. But again, as I said, maybe our patients come in late and everything. We try with the angioplasty and injectable agents first. In this case, it was going away. Then the debate can be between balloon mounted or self-expanding. We use a self-expanding, but we didn't deploy it well. And when we tried to retrieve it to position it right, we couldn't retrieve it, deployed it well. This was one exceptional case where in self-expanding also we did post-angioplasty as well. Ultimately remained patent. We did a check angiogram and everything. So this is how it is. But as I said, a lot of cases we do try just angioplasty, small angioplasty and injectable agents, and try to get away in these patients. But the key is to expect is ICAD, because then you need general anesthesia. You need general anesthesia, you have to be ready to change your guidings and be ready with all these stents and balloons and everything. Matthew has a lot of experiences using just tirofiban and angioplasty, right, in these cases? Yeah.
Basically, again, follow the same protocol that we do for carotid stenting. We dilate it.
All right.
Using a balloon close to about 10 or 15% less than the size, and if the results are good, we would convert that to an elective rather than doing emergency stenting. It's purely from our bad experiences of bleed because of dual antiplatelets running, I mean, Tarofuse running and then converting it to dual antiplatelets.
Yeah.
Just one question. When you are waiting for this is invariably ICAD cases.
Yes.
When you wait after recanalization, it is invariably going to get occluded.
Yeah, that's the.
When you are waiting, will you keep the wire crossed? Because that time the lumen is patent.
Okay, so, once you've done just the thrombectomy.
No, it can never happen, no, Arvind, because we had done a stent retriever or a suction. So everything is out.
So everything is out.
So the
there.
wire is never there.
Yes, once you do angioplasty and everything, of course you keep the wire across. Because that time you are already into this PTA stenting mode. But initially no, but we do inject injectable agents. We know if any chance of remaining patent is if you got this is a ruptured plaque with a lot of platelet aggregation happening. So we start giving them antiplatelet agents for sure, because otherwise not going to remain patent, whichever way you do, whether it's just stent or angioplasty or stent, you need injectable agents to keep it patent, in our experience.
Okay. My question was for are there cases with you that initially you have crossed the plaque, but later you could not, like dissections?
So I would say once you see clot formation, it closing down, cross it anyway. There is no point waiting for complete occlusion and then recrossing a plaque. So once we see it's collapsing down, flow is reducing, we know. And angioplasty is needed in this case anyway. It will be very rare just that thrombectomy they remain patent. So in fact, as soon as you do the angioplasty, until it looks great, unless the clot burden was large and plaque is very, very small, you may get away. Otherwise, angioplasty is almost needed. So we don't wait for complete occlusion. As soon as we see it closing down, we recross, do angioplasty, inject antiplatelet agents. I think the waiting stage is angioplasty and antiplatelet agents. At that stage, really the waiting comes in, whether we can get away without a stent or not. Yeah, Tufail.
The only thing I think we need to be also careful when you get an ICAD is when you do a stent retriever, like what you did here, you are always potentially at a risk of rupture because you potentially have a stenosis. I had a rupture very recently. Have you
Rupture the vessel, is it, Tufail?
Yeah, so there was ICAD,
Oh.
and obviously you don't recognize it, and you go across. And I think when you are not able to cross a lesion, it should highlight you again very quickly that you are probably dealing with an ICAD, and which wasn't recognized. And I don't know what stent was being put, but I was there actually watching it, and I should have stopped it because he wasn't able to catheterize. And then managed to catheterize, and there was I think it was a catch mini which was used because it was M2, M1, and as soon as he pulled out, and we have had one or two ruptures in ICAD, not recognizing underlying ICAD, stentectomy, and as soon as you pulled out, you have a rupture.
Was it because of the M1, M2 location? Like, was it very distal into a smaller vessel?
No, proximal.
I don't know. I mean,
So have you had a rupture?
No, we haven't had a rupture, but again, I mean, Vincent is here, Dr. Matthew. I mean, the debate can be whether you're trying to say we go straight away with angioplasty first.
Dr. Tufail, the case you were telling, after placing the microcatheter beyond the occlusion, did we took the microcatheter run, whether it was there in some of the true lumen or major branch, or it was in some perforator or something? Because beyond the clot, we cannot see anything.
So the latest case I remember very well. It was an M1 occlusion. There was a good collateral. The microcatheter, and our very experienced registrar was doing it, and the microcatheter was not going through, and I should have taken over. I did not take over, and eventually managed to catheterize distally. Did the distal run. M2 was okay. And then I said, yeah, put a stent in, which is when I should have realized that there is underlying ICAD, which I did not realize. And then as soon as the stent was pulled, boom. Okay, and there was a rupture on table.
So, I don't know. We don't do that many thrombectomies. Maybe Vincent can say whether he had a rupture.
No, I think it's uncommon in ICAD when you are in the true lumen to have the rupture. I don't remember, we had ruptures in different situations, but not in this one. I think it's possible also to have a false trajectory into the plaque, and then to make a thrombectomy and to cork the plaque and then to rupture the vessel, probably. But I've never seen that in our center at the moment on ICAD. Of course, we had rupture in different settings.
So,
and the fact of debulking the lesion first is still very important, because when you have an ICAD, and this is also what we need to say to the students, you have, in fact, you have two problems. You have the ICAD, and you have the clot inside the ICAD that has finished the job. And if you just make a plastic first line, and what I did sometime in the learning curve, I just went for direct plastic, you can embolize the clot that were inside the ICAD distally in the vascular artery. So the need for debulking is still there, and if you hear the Chinese guys that are doing a lot of ICAD, and they compare aspiration with stent retriever, again, the stent retriever is much more efficient to clean the ICAD than the aspiration. So I think we still need to debulk, to advise to debulk those lesions, because if you do not, then you send the distal emboli into the circulation.
See, you can have a rupture to fill, in a hard eccentric plaque, where the normal vessel dilates and the plaque doesn't, So it can very well happen in an ICAD, because here we are not really able to image and know whether it's an eccentric plaque. You may have a 80% or a 95% stenosis, and most of the plaque is on one side, so you can definitely rupture, But
No, I know, and I think...
just one thing to fail. I'm sorry, guys. We'll have to just carry on. And to me, the only question in this case was, we can just have a voting here. Should we use a balloon-mounted stent instead of the self-expanding? Ajay, balloon, self-expanding. This one.
For which case?
This one, the case which we showed.
Which you showed.
Yeah.
I honestly feel that it doesn't make a big difference.
All right, no difference. Vincent, balloon mounted or self-expanding?
Why not a simple balloon?
We did a simple balloon, it occluded.
Simple drug-coated balloon.
It was occluding with the balloon angioplasty.
He said it was not staying open. I mean,
So
what he's saying
Vincent,
is...
balloon mounted stent or self-expanding, what would you use?
For me, M1 is coronary stenting.
Coronary stenting.
Yeah.
So balloon mounted from my side.
For me, it's coronary stenting because I had occlusions with credo.
Yeah, Arvind.
Coronary.
Yeah, I mean, yes, our guiding was right there.
Again,
coronary,
see-
because we landed in trouble even after stent placement.
But
which
don't
wasn't
you see,
acceptable.
is it in the mid-egment where all the perforators are there? See, if you're going to use a coronary stent in a segment with the perforator, the chance of pushing plaque is much higher. So I
That is
think
also
all
there.
these are matters we just can't have one shot for everything.
You agree, we also end up, it's very easy, convenient, but they are more costly. But yes, with balloon, you get a very good lumen and probably patency rates may be higher, we'll know the answer. But yes, internationally, balloon mounted stents are favored. When we are not so experienced, we use self-expanding, but our mistake was length of the stent and delivery of the stent in this patient.
See, a credo
That was
is
our
an
mistake.
absolute no in the carotid siphon,
All right.
because it's
Okay.
the worst stent there. It will not even expand.
Okay.
So in some other segments, I don't think it makes such a big difference.
All right, so we just, I know we are running very late, Dr. Padma is here for the next talk.
We have tried few drug-eluting balloons in the same location in M1, and
But
they
in
work
acute
wonderfully.
case,
Yeah, acute case.
okay, that's a thought, and we
Simple
can,
drug-eluting first
All
with
right.
a 1.5 mm
So-
balloon followed by another 2 mm balloon.
lovely, okay.
No drug-eluting.
So the next talk is Professor Padma Srivastava. She is one of the most well-known stroke neurologists in North India. She was chief of neurology and chief of neuroscience at AIMS. At present, she is chairman neurology in Paras Hospital. We are working together. So she is going to talk about MEVO, low NHS, direct thrombectomy neurology. So I think from intervention, and since we have a lot of youngsters here, and let's go to this area. How neurologists look at is this borderline areas of neurointervention, and where do we stand? And chairpersons are Gaurav and Arvind and Rashnivas. Gaurav? Yeah, there he is. Again, Gaurav, I think Gaurav team does a lot of MEVO, so we'll love to hear his comments in the end about this. And Rashnivas, again, my colleague, again, he's one of those stroke neurologists trained in neurointervention. He's part of the chair here. And Arvind, Raj? Okay, let's go.
Thank you so much. Thank you, Vipul. Thank you, Raj, and for giving me a space. I guess I'm the only neurologist who's not an interventionalist. But I guess I have also been your strongest supporter through the decades. So I love what you all do. And, they said, Vipul said give a neurologist's perspective. Now, I really want to give you the perspective of what India stands. Now, what we discuss in a masterclass is what best can be done with the up-to-date science and your experience and expertise. But what really happens on the ground is not just what I feel about referring the case to you all, it's also a whole lot of dynamics which dictate essentially on the ground what will happen in terms of what you can intervene. So let's see this, that, I guess this is where we are, and every single time what you do, I guess, is a leap of faith through a ring of fire. So really admire what you all do. But then the key determinants of the access is, the big elephant in the room, the economics, and that dictate a lot. And also the availability of your infrastructure in terms of the critical corpus of interventionalists. And I see that a huge, the very fact that it's a packed hall, it gives me a great pleasure in seeing that this critical corpus is definitely burgeoning. And then you have your triage systems, which still are at large. So recently we've done this assessment. I'm part of this team which did this geospatial distribution and accessibility of stroke centers and also the travel times. And this is, in fact, we had presented in the MT 2020 meeting this year in Feb. And then largely when you look at the stroke centers per million population, a rough estimate of how optimized your systems of stroke care are, both for intravenous and endovascular. And then we looked at a huge regional disparity within India. And if ideally you have a 3 stroke units per million and 1 comprehensive stroke center, in India this is what we have, 0.41 for IVT and 0.26 for the endovascular. And then the median duration to the nearest part of any of these centers is around 3 to 3.46 hours. And in our population of 1.4 billion and adding some more, we have about a quarter and 17.6% who have an access to a capable center. So you compare it with the rest of the world. So in US it's 80 and 91, in Germany 93% within 30 minutes. So we're not part of Catalina registry, so I'm not living in Spain, where it's more than 90% who can go across. So that's where you have ideal systems, and that's probably what actually dictates when you talk of perspectives, and that includes a neurologist. And this was a summary of travel distance as it happens here in India. And overall, the South is doing the best. And after the West, the North is low down, the mid part of India is dismal, and Northeast doesn't exist. And then we also have, the health performance indicators, and this, in fact, we gave it to the ministry as well. And this is a very old slide of 2016 of what was happening with, the lysis. So we have regions where we don't even have a data. And this, we mapped out the duration, within 4 hours, how much of India is able to reach a center where they can actually get what you can do. And then these are the number of, the IVT and the both capable centers across India. This is within duration of 2 hours. So a whole lot of South, you can see Kerala especially doing extremely well. And within 1 hour, we have up there around Delhi, and down again we have Kerala, and a little bit there in Maharashtra. Rest of India, no chance. And so this is the journey so far. So in 2022, we have 1,000 stroke-ready centers. We've done about 25,000 thrombolysis. And year-wise, and this is altiplase, and I'm not talking about tenectic place. And this also we have a state-wise distribution. Maharashtra is really doing well in a lot of our, at least the IVT part. And then we have this breakthrough of tenectic place which came in much before the rest of the world. And this certainly actually took it forward, especially in the COVID era, where tenectic place just surged ahead. And currently, December 23, we have the percentage of kinetic place, which is in fact, overtaken altic place. So this may be IBT or even for your bridge. And this is the interventionalist as it stands in India. In the US, the number of thrombectomy eligible strokes, and you have that many neurointerventionalists, and we have this huge figure in India, and we have that many neurointerventionalists. So that's where we stand, and that probably does dictate the perspectives in general. So I thought this was more important than, really telling you about MAVOs and direct MTs and low NHSs. You guys know better than. Then this is a graphical representation of neurointerventional centers as they exist again in various parts of India. Again, you have a huge number. The red there means that Kerala really is the king of neurointerventionalists, right? So now let's look at the current challenges in the endovascular, in the medium vessel occlusions. Now, from what I understand, this is a borrowed diagram. Whatever I'm going to tell you right now, in probably 3-4 minutes, is essentially borrowed science and what is being published in the science, in the literature as it exists. So when I'm looking at the medium vessel occlusions, there are, as I understand, the different studies who sort of defined and included different regions. So mostly I see distal M2, M3, some even M4. A1, A2, A3, and P1, P2, P3. There are some who've actually taken A1 and P1 into the large vessel, but largely that's where we have. And also, as probably in the morning I was listening to various talks and the technical expertise, that you have the primary and secondary MAVOs, and the secondary MAVOs are the ones you probably encounter more often because you're intervening largely with the larger occlusions, but you can also have a secondary MAVO even which are not interventioned as such because of the clot friability and distal migration. But then when you look at studies, and you look at, you need to randomized and controlled, then it's more of primary MAVOs rather than secondary MAVOs, because probably, I'm sure you will also agree that randomizing a secondary MAVO while an intervention has already been performed or during performance, and then you ask the patient or the relatives whether they'll get randomized to another procedure, is probably going to be Herculean task. So you don't have too many studies there. And in the published literature, I don't expect you to read all this, but these many studies, some of those studies still ongoing, which probably will give you some more clarity on some of the gray zones as they exist, but I guess it's still there. From a neurology perspective, seems to be an equipoise in terms of intervening a secondary MAVO. So I leave that up to you, because primary MAVOs, as I understand, are far less coming into your practice as against, and most of the studies, if I have to say, the randomized studies were 3:1 ratio of a primary versus secondary MAVOs, where you have the study literature. Now this in the low NIHSS, well, I'll just give you a case study which happened recently, and Vipul and Raj were involved in that. So we have again a 56-year-old lady who came in 48 hours after an acute ischemic event. She had a very minimal dysarthria and a little loss of dexterity of the left hand. And this she experienced when she was out of Delhi, traveled back to Delhi, seen that it persisted, and came to the emergency 48 hours later. And in the stroke imaging, you found a right M1 cutoff. Now what would you do? She's 48 hours into the illness. She's a very low NIHSS. I mean, strictly speaking, the mild NIHSS, I have a lot of, debate on what that means, but then it was definitely a very mild stroke. So obviously she was not thrombolized, and then in the imaging, there was sort of the internal watershed zone, a little bit of an ischemic infarct sitting there. Rest were fine, so she could have had a great collateral supply there, which is preserving her brain, which may hold on if you keep your blood pressure up, or it may just fall down if you are in a threshold. So then the intervention team also looked at it. Well, everybody thought that this fine, she's doing okay. So the next, she came in the morning, overnight. The next probably over 14 to 15 hours, she deteriorated. So quickly the intervention team came in. Miraj, you would remember this case. And then she was taken up for a DSA, found that there was this embryo occluded, and then she was planned. And in the middle, there was also a problem with insurance policies and economics, right? So then she had to be discharged and readmitted with a fresh insurance, and I'm sure all of you who are in the private sector will understand that part of it. But then that had to be done. So that took a little more time. And then she went into the interventional arm, and eventually she has been intervened and stented with, keeping the blood pressure up, and then she was with them for a long time. To cut the long story short, this was a low NIHSS, an LBO sitting there over a period of time, and I think this is one of the rarest cases, Raj, that you finally did the interventional stenting probably almost 6th or 7th day. She did very well. And she got discharged today morning. I just discharged her and I sent her. So you're looking at a case where maybe it was low NIHSS because she's got a great collateral supply. But how dynamic are those collaterals? And if everything is depending upon your clot and collateral, the revolution of a stroke outcome, ultimately it is that, then maybe it's case to case. So look at what the literature says about this. We have all these cases, and if individually, all of them are retrospective, single or multi-center, and eventually, what they found that there is, broadly, there is not much of a take-home message there, because the diamond is cutting the midline. So in the EVT versus the best medical treatment, there is a sort of a clinical equipoise, and it is tending towards a best medical treatment rather than EVT. But I do not agree with this, simply because I do think that there are gray zones. And again here, the forest plot in the symptomatic ICH versus those guys who are only on the, the EVT versus best medical treatment, it obviously will favor the, the best medical treatment. But I do think there's an equipoise there, and I don't believe that we have seen the last of this word yet. And now the last is direct MT. We do have these studies where you have this 5 up there, and no, 6 up there, and the first 2 said the direct MT is good. But for a neurologist, now, direct mechanical thrombectomy makes sense if you're having a stroke on the table during an intervention. So most often we've seen this in the cardiology group. On the table you have, it makes sense. You just go and take it out rather than give you an IV. But then, other than that, the studies which I've looked into, the first 2, direct MT and DVT, said yes, you should go into direct MT. But then again, the perspective will depend upon the logistics, the accessibility, availability, and affordability of how you're going to reach that place. And what time will it take, since the time still will dictate your outcome. The other thing is, of course, the science part of it, the clot characteristics, and when you're giving an intravenous, are you going to go fragmentation, would there be distal migration, would there be an increased chance of a bleed, and what have you, and more of those. But then the last other 4 said that you will not be doing it, that it's better to give an IV and get into a bridge rather than do a direct MT. So therefore, we still have not seen the last word of it. And overall, when you're looking at these 6 studies, you have again the diamond cutting the midline as to the non-inferiority or the superiority, fact of the effectiveness of the procedure. So also the shift analysis, although there seems to be a trend towards having the IVT and EVT. You're looking at the 0 to 1 MRS, and then whether it's successful reperfusion, which obviously would favor having a bridge, and then the SIS, and also there is the local bleed, and then the mortality part again makes no difference. So that's the last of my slides, I guess. Perspectives, whatever it is, we're all talking the same language of bettering the stroke outcome. But I do think that beyond having the best experience and expertise and infrastructure, there are a whole lot of other verticals which dictate, and therefore there would be change in perspectives. Thank you.
Thanks a lot, Dr. Padma. In a very short time, you tried to cover this. Now, MIVO is very interesting topic. I mean, in small vessel thrombectomy, and how do we approach? So, Vincent, I mean, what's your approach in MIVOs? How do you assess when to do, and how you take the decision? Yeah, you can come there. Yeah, sure. Can somebody help him? Hello? Yeah. And of course, there are two situations, and Vincent pointed out, is very, very different. It's a primary small vessel occlusion and versus when we call secondary embolism. And as I said, by the time he's setting it up, Gaurav, any comments upon how do you approach these patients? I mean, clinical decision making to do or not to do and what to do. Yeah.
So I think as Dr. Padma also said, MIVO's evidence is still coming in. We do not have the evidence, but I think from what we have learned in last few years, we have tools.
Okay, I'm sorry interrupting. Do you consider proximal M2 as MIVO or MIVOs? Where does MIVO starts for you?
Above the Sylvian fissure.
Above the Sylvian fissure.
Yeah, A2s above the Sylvian fissures, P2s and beyond.
All right.
Not M1, M2 junction.
And how do you take the decision making to do it in these cases?
So same as you do for large vessel occlusion. So if it's a medium vessel occlusion with a reasonable NHS and we do perfusion imaging, and if there's a mismatch, we go ahead and open it. I don't think we discuss it anymore now. So we are very open. Like if it's not a low NIHS, we open it up. If it's a low NIHS, that's the question I want to ask.
And what's your usual technical approach in these patients?
So Alumbra to begin with.
So Alumbra using which material?
So typically, Red 62 is our aspiration catheter to begin with, and we start with 320 or 420 of stent retriever, which goes through a 017 catheter. And then we decide if we can take the Red 62 all the way up to pinch the clot. If not, we exchange it with the blind technique and bring a 4-4 or 3 max up there to pinch the clot.
All right. So you mentioned Red 62 with a small stent retriever. Otherwise, you mentioned the exchange.
So we do a blind exchange.
Just explain to everybody what you mean by this exchange.
So the blind exchange is because once your stent retriever is in, you can take out your aspiration catheter, and then when you are pushing, let's say a 3 max up, there will be a time when you don't have a wire to hold on. So the stent is holding the wire, so you just push the aspiration catheter, and at some point then eventually you will have a wire to hold on when you are pushing your 3
blind exchange, a fixed wire with a stent retriever, that is what he does, and to take it out and everything. So do you have more complications in these cases when you drag the stent, more SAH somehow or anything like the spasms, SAH?
So spasms, yes. SAH, we do see hyperdensity in the post-CT scans quite often, but they are not symptomatic. Do they really change the outcome of the patients? I do not know, but...
do you face a challenge in finding MIVOs on initial imaging?
That's where the perfusion imaging actually helps, because when you do perfusion, you can actually go back and look at your CT angio and identify where the block is.
Yeah, so that's important. You may miss them, at least if you're not really looking for them. So I think, CT perfusion helps. Our perfusion may indicate that this is where you have to chase and look for a small vessel occlusion. And I think, so is Vincent?
So you do the same or you do it differently? What's your approach?
All right. Okay, so we have been not that aggressive with MIVOs, I guess, yes. And yes, aspiration catheter, stent retriever, and you withdraw, but we have not been using CT perfusion, which is a major challenge at times. So if you have a doubt of an occlusion, we just take off our DSA, you see the occlusion collateral deficit, okay, then you go ahead with it in a standard manner. It has to be clinically significant deficit, okay. If it is right frontal lobe, small vessel occlusion, of course you ignore them, and when significant, you go ahead with them. So yeah, Vincent, are you ready with that?
I'm ready.
But they are not ready.
Technique is not ready. But basically, I was really impressed by the talk of our colleagues from neurology.
Okay. We are there now.
Yes, I am. Yes, I think it's this one. Yeah. Yes. Regarding the most important target is to deliver the service from far. We can speak about distal, we can speak about low NEHSS, but where is the point when maybe 2% of the population has access to the treatment? So I think most of our effort now is to train people, to develop centers, even to do direct aspiration for just M1. That's where it relies the main of the effort of our community right now. It's true in India, it's also true in France, you know, the coverage looks good, but there is some area where there is no good services at the moment. So when it's, when we speak about the distal vessel occlusion, it's very important to differentiate, as you said, the two things between what we call like a primary MEVO, meaning that the patient is presenting to us with the patient is presenting to us with a neurological deficit that is clearly in relation. Yeah, doesn't. Okay, maybe I can use this. Yes. So here there is clearly the difference between something that is primary, something that is secondary. Secondary is that you are in the angio suites, you are making a thrombectomy for M1 and something happened distally. Primary is that the patient comes, he has a left hemianopsia, he has a speech disturbance, and or you find a P2 occlusion, or you find like a M2, M3 occlusion on the left side. So it's what we can call the primary distal vessel occlusion. And this is very different because here you know that the clot you are observing is clearly in relation to the deficit of the patient. So there is no trial that has proved that we should go there at the moment. So we should be cautious. And what we're doing at the moment for us is the deficit is non-disabling, meaning it's not a speech disturbance, not a motor deficit. We'll decide to go for lytics first line, and then go to the patient only in rescue fashion. In the contrary, if the deficit is disabling, meaning there is a clear aphasia on the patient, he cannot speak, okay? Or he cannot see, typically, or he cannot move the right hand, something like that. So we call this a disabling deficit. So then we go to the patient, so we consent the patient and the family, and we evaluate also the technical risk. And this is something where maybe the experience of the operator has to play a role. I spoke with the people that are leading the trial, distal, discount, and I got them at phone, you know, because they're close from having the results. And what they're now observing is that the results may be completely different in between two operators. It's something that we did not have in M1 thrombectomy since the technique is largely reproducible in between two persons in different places, different times. So that's what is making the technique very reliable. But for the distal vessel occlusion, the technicity, the anatomical understanding is something that is key. So you may see a large difference between the experienced operators. So I would say that the parameter of having V-pool in the angio suites for making the decision or the fellow in the night may be something that may be an important decision-making part that make part of the decision-making that is an important weight in the decision. The anatomy, of course, if it's straight or not. And if you think that it is okay in your end and the anatomy is favorable, then we go for distal thrombectomy. If the person does not feel that he can make it because of the distality and the anatomy, maybe it's good to go also lytics and to try to lytics first and to go only in a rescue fashion for mechanical thrombectomy. The secondary DVO, for me, it's less clear because when you debulk your M1 and you see there are distal emboli into the superior trunk in a functional area, for example. Here, you don't know if the distal occlusion is clearly in relation with any symptom for the patient. Maybe you wait 3 hours and the patient does not suffer from this occlusion. So you just rely on your understanding on the anatomy of the patient and on the collaterality. So if you do the run and you see there is a large collaterality that is going into the cortex after the distal occlusion, I just don't touch. Because my experience is that you let it and the patient is really fine. If you see the collaterality is really bad in a very functional area on the left side, or in the motor area, or in the P2 segment, for example, then despite it is a secondary DVO, you may decide to go to increase your TK final score. But again, you have to look what is the remaining occlusion looks like. It is if it's the anterior trunk with a lot of tortuosity, then it's a balance towards not going out, not going in it. If the collaterality is good, yes, you don't go. If you want to go, it's because you see no collaterality and you think that it's extremely functional. Do not forget that when the thrombus looks too distal, I-elytics is also an opportunity. And it's really easy to make. You can just push the microcatheter, push 10 milligrams of alteplase into the patient and wait. It's always an option. How do we perform it? For me, when you are here with a primary DVO, it's like an elective thrombectomy, like an aneurysm, okay? It's not like the rush of it's an M1 occlusion, the patient is suffering, and EHSS 23. No, it's an EHSS that is really low, between 5 to 8, sometimes below 5. And you have time to do it well because you know that the technical risk is much higher than the normal thrombectomy. So we do this thrombectomy as an elective case under general anesthesia as soon as we can, because when the patient is moving for distality, the danger is that your wire is arming the patient, and the rate of hemorrhagic complication is higher in DVO. It is in all the reported literature at the moment. So elective thrombectomy under GA, we go for low profile material, 0.17 microcatheter, with for example, preset stent or 3 mm solitaire, trying to not harm the vessel, small distal access catheter. We are crossing, yes, just with the microcatheter, not with the wire, just pushing the microcatheter if we need to cross to put the stent. We always, before retrieving the stent, put amilrinone or nimodipine to relax the vessel, because the drawback could be that after your pass, you still see an occlusion. But is this occlusion related to a spasms or to a remaining clot? And people, if it's a spasms and you do another pass, you will again harm the vessel, go for iatrogenic dissection, so it's not good. So it's preferable to use nimodipine, so you relax all the vessels, and then when you do your pass, you have more chance to understand what's really happened in the vessel, because the spasms is very high in the distality. Triaxial system, do not hesitate to make 3D, because sometimes, if you don't understand the anatomy, you're not looking for the good vessel, and you're going into complication. If you do a 3D, then you see the entire vessel tree, you understand exactly where is the problem, and you go to the good working incidents, and you are performing safely the thrombectomy. Even if the patient is under local, because you have to do under local, you can do the 3D, because if not a perfect 3D images, at least you have the 90-angle rotation view of the patient that helps you a lot to understand what is the target vessel to treat. Yes, and here, some technical consideration. When you are the occlusion that is in the inferior trunk, it's always a push to do it. Why? It is straight. It is easy for stent, easy for aspiration, easy to navigate. I would say it's a push for you to go. If it's in the superior trunk, you know there is more tortuosity. The aspiration could not be efficient because the mouth of the aspirated catheter could be in the curve disconnected from the thrombus. It's much more difficult to achieve a direct contact thrombus like this when you are in a curve. So in the superior trunk is less good to make direct aspiration. You can do with the stent, but again the stent you have more tortuosity and you have more spasms. So it's works better there maybe. But this is the two considerations you may have when you are doing this. So I try to be very synthetic on the distal, so it's open to open the debate. Thank you. I think, I don't know if you people...
So, I mean, what is your, Vincent, in a typical case of a distal occlusion, what is the material which you use? How do you approach them?
Typically, it's let's see, we have, I have a very nice case last time in slide where the A2, A3 occlusion that I was blocking a very big paracentral branch with a very strong deficit, so I really had to remove this clot, you know. Typically, I go with a microcatheter 0.17,
Oh, 17,
And,
yeah.
Yes, I'm just making an ANVI. I put the patient under GA unless there is no complication arrive. If the understanding of the anatomy is pretty clear for me, straightforward, AP view, lateral view, and I go like that. If the anatomy is not clear at all for me, I just make a 3D run. Okay, I take time out of doing that. Then for this 8-way-3 thrombectomy, I would go with a balloon guiding catheter just to block the flow to when I would do arterial. I would do, for example, if the A1 is good, I will do a 5 French, for example, at the intermediate catheter, and just a 017 catheter. I'm approaching the clot. When I'm close from the clot, I just push the microcatheter, no wire, and the microcatheter is crossing, and you see the microcatheter crossing. Then I use a preset light. I love it because it's very, very low invasive on the vessel wall. My second choice is also solitaire 3 mm in this case, but I don't use more than that. And I just open the stent, and I go for a normal maximalist approach, very gently. And I do only 2 or 3 attempts, 2 attempts only. And no, when I deploy the stent, I put the Milrin on, and I'm waiting like 5 minutes. Because I think in this location, you don't have like 3 or 4 attempts. You have like 1 or 2 attempts to perform. Because it's not proved, there's no clear literature data on that. You can harm the patient. So yes, do it maximalist, do it under the best condition you can, and only 2 attempts. If I don't succeed after 2 attempts, I will not put a rescue stenting in this, contrary to the proximal distal occlusion.
With the stent retriever, do you try to pinch the clot as well with an aspiration catheter? I mean, smaller aspiration catheter or
Yes,
something?
we are corking, yes. It depends on the size. I think it's really important to size the vessel, because if you take too big, you can dissect the vessel by pulling back and putting the distal axilla very far. So size the vessel. Sometimes the A182 is really big, so your 5 French is okay. Sometimes it's too small, and you need a red 43 or a 3 max to get this done.
All right, thanks. So any comments about distal thrombectomy? I mean,
I have a question for Tufel. Here, Gaurav.
yeah, sorry.
So, do you use wire stenting also for challenging distals? Like both Vincent and Tufel can answer. Like we have a couple of cases where we saw that it was like a saddle sticking into the branches, and like MCA bifurcation, it will just keep moving. So, do you still use wire stenting distally?
You mean double stentectomy?
Double stent.
Yeah. Yes. If I have a saddle MCA, I think it's quite good, because you can get, quite often you can land up losing the clot and then you have to go in. But remember, I don't think I'm trying to propose this as a primary line, though I do it and I think it's useful. But it's, aspiration catheters are getting better and better. So certainly there is still some, it's not a clear-cut evidence, but I do both. The only thing, Vincent, I wanted to ask you, I do 3D too. When it is M2, I think a 3D helps, but I use hand injection. I do hand injection 3D. Do you use hand injection 3D or do you pump 3D? Does it matter?
No, I think it doesn't matter. You can do both, no problem.
Okay.
The idea is to have the contrary to proximal occlusion, where the understanding of the anatomy is not a key point. You saw the first case of this morning. You just push the noodle. You can close your eyes almost to see the things coming in M1. But here it's another game. You have to understand the anatomy.
Yes.
Or sometimes, if you on the epidural lateral view, you don't understand fairly the anatomy, and it is a risk of complication. And after you get the 3D done, your understanding now is much clearer, and you know where you have to go.
Yeah, of course. So I also have found that sometimes distal A2 clots are difficult, and perfusion and all. I've had situation, NIHS score is high, you don't see a clot, and you often don't recognize the M2 or the A2, A3 clots easily. And if you do a perfusion, then you realize that there is a perfusion deficit in the ACA. You do a 3D and you can see the clot and it's very good. But in ACA, it's quite hard to get a distal access catheter quite high. So I've often used Tiger Trevor, and I think I have found Tiger Trevor very useful. I haven't catch many works, but Tiger Trevor has been my go-through, my distal access catheter, stent. What is your go-through, and what is your go-through for M2s and A2s?
As I said, we prefer an 017 or a 320 and 420 stent retriever, catch mini or preset. And then we always like to do a blind exchange with either a 3 max or a 4 max to support. And
So you don't have a tiger retriever in India?
I do not have it. I don't know if other people have it. So
Okay. What about you?
The Tiger?
Tiger?
No, I tried a lot with this device, and I have to say I'm really not convinced.
All right.
Because it is adding another step of technicity. And again, you know, my belief is that stroke has to be, the future of specialty is simplification, I mean, reproducibility in between people. And now you introduce another thing, you have to inflate, deflate, inflate, deflate. You pull back, then you inflate. So you create more complexity into the technique. And for me, look the map we saw. You see the green we saw, and you see the red we saw a few slides ago. I mean, Tiger is not the future of thrombectomy for me. It's not. You know, future of thrombectomy is reproducibility. So it's an excess, and also I did it in many cases. I did not saw superiority.
Okay.
I know maybe you did, but I did not.
No, I have no bias. I have used both.
And you add another step of complexity.
So, yeah, I mean, since none of us are using it, but yes, it's an approach. I mean, as they mentioned, 017 preset light and preset light, catch mini, and Tiger retriever. But so I think we'll have to just close this session. And thanks, Gaurav, and for this session. So, I mean, in a short period, we are trying to cover the various different, let us say, technical situations in stroke management. And now we are closing the acute stroke session, and we'll go on toward the aneurysms. And aneurysms will start with the flow diverters, all right? You know, flow diverters are great technology, all right? And all of us are using them, and we use them. But again, I think there's a lot of technical improvement which we can bring in. So rather than showing those pre and post cases, we are trying to go methodically how we improve our technical performance in flow diverters, all right? And of course, last 2 days, those 28 students really had a lot of experience, but now we'll have the first session on setting it right. To me, deployment is the key. And can I invite Dr. Tofel, Sukalyan, and Manish as chairpersons? And the first talk will be one of the best teachers we have in India, Dr. Matthew Cherian, and he'll be talking about the key hand movements in deployment, how he ensures and how he teaches his students to deploy a flow diverter to get it right.
So, you know, Vipul, when you asked me the key hand movements, I was wondering, should I take a picture of the hand and, or should I sort of animate this whole thing? And I finally decided to animate it. So I hope that you'll get the basic fundamental of the key hand movements. So I know there are a lot of people who do very fancy movements, look very stylish, and some people may not look so stylish, but the bottom line is that you do your job right. And even yesterday when I was doing in slides, I said it's more important you deploy it right. It may not look very stylish, but as long as you get your job done, it's fine. So to understand the key hand movements, the first thing you got to understand is what exactly is, or how exactly is a flow diverter loaded. So this is the unconstrained flow diverter, you can see over here. To keep it constrained, you'll have a little pedal in most of the devices. This pedal is what that keeps it in place, and sometimes when you start deploying it, the pedal doesn't release, and because it doesn't release, it may take a cigar shape. So one of the things that I often do really is to actually open the flow diverter in an ICA, in the MCA, and then sort of recapture it back. And when you recapture it, this pedals actually move forward, ensuring that the next time you open, it will open. And that's very important when you want a precise position, especially in a vessel with a bend like the siphon. Also realize one thing, that right over here, there will be two markers.
And this is like a pad that holds the stent retriever in place, and you have to keep these markers. Once your microcatheter even touches this marker, after that manipulation itself may release the FD, and even you will not be able to retract it. Having said that, there's a limit also to recapture a flow diverter. Up to 3 is fine, by 4th actually they start slipping and you may actually lose it. So it doesn't mean you can do it for eternity. Now, this pink is the blood vessel. The green is your DAC. I took green because one of the common DAC catheters we use is the Cat 5, which is blue in color. Inside that is your microcatheter. The microcatheter, very commonly for a large vessel, is a 2-7. The little marker over here is the distal tip marker, and you got to keep this always in focus and in your mind. When you pass the stent retriever across, and as the wire comes out of this point, you will see 2 dots. Keep these 2 dots in view. This is your lifeline. Except for the phenox, in every other stent retriever, once you cross this point, then it becomes a point of no return. So try to do all your manipulations somewhere about a little ahead, a few millimeters ahead. So what I meant is, if you want to try things, please don't try it after you come to this point. The first step, therefore, is pulling back on the micro. Can you see that? Your wire is kept fixed. You draw back the microcatheter, and as you draw back, the flow diverter is expected to open this way. In case it doesn't open, take the microcatheter forward one more time, recapture it, and those little petals that hold it will allow the release to take place. Now that you've got this in place, what is the next step? Remember, at this point, if you push the whole device forward, I'm not talking about pushing just the mandrel forward, you push the whole device forward, it will tend to come and now peg itself on the walls of the blood vessel, right? So you got that, you push this forward, it actually holds and grabs the sides of the ward vessel, and that is the next step that you would do. At this point, if you're not happy with the position, don't be afraid, recapture it back, push your micro a little forward or backward, and restart the step. After this, after that gentle push, start pushing on the mantle as the arrow shows. What happens is, it starts opening up in a nice little funnel like this. This is fine on a straight vessel, and we'll keep it for that for the time being. Once you do that, again do this little push. Every time you push, the braids are now coming up to that close to the 120 angle that you wanted to happen, opposes the wall, and this is a very, very important step. Just because you feel your flow diverter is getting a little short, do not try to keep it lengthened, it's not going to work. It will be a disaster. If that's a problem, better capture back, start afresh with a new flow diverter. And then the next step, you gently pull it back, releasing the tension and bringing the microcatheter to the center again. And then push a little bit and pull, and this is basically the technique that you do. By now the dots, as you see, have come over here. When you come to this point, the best thing is keep it at a neutral position and again retract the microcatheter. Have you got it? So it's a pull and a push, a pull and a push. It's basically you retract, push the whole device forward, come back to neutral position, now push on the mandrel alone, let the flow diverter come out a bit. If you want, I can go through it a little faster one more time to tell you each of these steps. So this is the first step. You retracted your micro. You're pushing on the whole system to get a little bit. At this time, you can even push out a little bit if you feel you've not got enough length. Keep pushing on the central mandrel. You'll find, as you see, the dots are coming closer to the point of no return. At this time, you can still play a little bit, push it forward, pull it a bit backward, and at this point, you can actually pull back on the micro and you released it. One of the problems that you can have is a fish mouthing. So what typically happens is this, you do this and you get a flow diverter should typically look like this. Sometimes it looks like this. One of the ways actually is to pull and push on the central mandrel, and at times it might open.
But more often than that, this doesn't happen, so it might actually twist it. It's better, therefore, to retrieve the stent retriever into the sheath or into the micro, and then once again try a deployment with a little bit of push, okay? The next thing is your tension right. Now when you start deploying, like I told first, it looks like this funnel. You push a little more out, it looks like this. Now, this happens not because you pushed, but because you unsheathed. Now, like I said in the beginning, you deploy a bit, it touches the wall, then don't keep unsheathing, but push out. This is basically called a champagne glass look. Okay, champagne is good for celebration, but not for your FD, right? So now you can do a thing to correct it, just push it forward. Push the whole unit forward. That means just push the micro forward without holding onto the wire. When we were training yesterday, I found many people were holding the wire and pushing forward. That is recapturing. Hold the micro, push it forward, and now you'll get a shape which is ideal. But if you push it a little more forward, it goes under tension. This shape is typically described as a martini glass. Even if you don't drink, maybe get used to these glasses. Fine, so this is again not right. Pull it back a little bit, and you get a look which is typically called the wine glass look. Go slow, there is no hurry. Even when you're working with people, some people be in a big hurry. I don't know why. You can take all your time deploying the flow diverter. Nothing is going to happen, right? So you got that again. So when you start this, you may start where it looks like a flute-like glass, and you have to push it forward, get that corrected. If it is too high, pull it backwards, make it look like a wine glass, and which is typically understood when the micro is bang on the center. Okay, but sometimes you're confused. This looks bad. Now, is it a bend, or is it a twisted FD, or is it something that just happened because it's a bend? So in this case, if you have a biplane, look at the second plane. If it's seen in both planes exactly alike and tight, you probably twisted it and can be difficult to untwist. There is nothing wrong in trying to recapture and trying to unsheath it one more time, but if it happens 2-3 times, you're much better off taking off the device. But on the other hand, if in one view is this way, on the other view it's open. Now if it's not a biplane, just rotate it around your C-arm and you can see this. You know it's basically a problem of not opening. The last and the most important test, the push and the pull. So when you do a flow diverter across the bend, it will invariably look like this. And this is the place that you have to ensure you get your position right. All the techniques after this, once you deploy, are much more challenging than this, right? So the first thing you do is push it forward. It may open a little bit. Interestingly, after that, when you pull it backward, it might open. You may have to do it several times. It may not happen the first time. It's a push and a pull and a push and a pull, and you slowly find it opening up. Sometimes you have to recapture a bit. Sometimes it will give a little length. You never know what really will do the job, but most of the time it will open if you're patient. The next, now you deploy the stent and massage. Who doesn't like one of these, right? Even an FD works exactly that way, right? Okay, how do you give a massage to an FD? Once you deploy the stent across, the flow diverter across, take your microcatheter across it. Keeping the wire inside. Please don't keep the wire outside. What will happen is in a perforated vessel, push, and now what happens is the micro moves forward on the bend. See that? Invariably this will happen. As you push, and when this happens, it stretches this forward. And this is called a massage, right? And you can do that a couple of times up and down. Keep your micro quite distally. It's very, very safe. The next one is the bumping, right? Bumping is an extremely, extremely useful technique. At the same time, please don't go on aggressive bumping. Nobody likes it. You won't like it, and your FD won't like it. How do you do a bumping? This is typically done when the proximal end is not opposed. like in this picture. What would you like to do? Now you have it here. Take your DAC across. It will generally touch the edge. And as you gently push it forward, it will open up. Now, one of the things I've noticed it, if it's just the proximal end, everything else is fine, pull out the micro and do this maneuver. It will work even better because when the micro is inside with the wire, it's sent to centralize the DAC and it may not go. But this, please be gentle. Don't go pretty violent on this. Sometimes it goes outside the FD, you'll have a fish mouthing. You push too hard, it kind of gets crumpled or crimpled and you can have a problem with that. So these are just to show you a large aneurysm and how one can treat successfully, but this is not showing any technique, just to show. So it's some of these maneuvers. So this you've got the Cat5, the Synchro. I don't know if you can see it on your monitors. I hope you can. And so this is what is done. You've got this across here. But when you do a dynacity, always do a dynacity. I know in India some people say they do not have, but whenever you have it as a protocol, even if it looks well opposed, do the dynacity because you will think it's opposed. It wasn't, because here it looks, everything looks fine, but actually you see the distal end is not opposed. So what do? This is where you do the massage. And how do you do it? You can just see what's happening. You're taking the micro across like I told you, and then as you go across, you start manipulating on the micro, and as you pull and push, and as you pull and push, you will actually get the FD to open, okay? Okay, the wire is little out. Normally the wire should be in. It's much, much safer. And as you do this, you will actually get this to open up. So that is called the massaging technique as you do with the wire. And okay, here is another aneurysm. We got a working angle. The angle looks tight. We got an infinity and the triaxial combination, the Cat5 and all that stuff. And you can see the FD over here. And as you deploy, invariably you find this segment will be narrow. Just see what we're doing. We are actually pulling and pushing and pulling and pushing. You'll see that maneuver. Have you got it? The push, the pull, the push, the pull. And this is as you do, you'll get the FD open. Like I said, take your time. Can you see the pull, the push as it opens up? And then you'll finally get this open and you'll get a good position. Okay? But at the end of the day, you see there's still poor position over here on the dynacity. So what do? This is where you do the bumping. So this is the Cat5 over here. We are taking the Cat5 up. Here we are doing a bump exactly at the spot that is the upper end. Massaging usually will not help because massages pushes the upper end here, the convexity here. So as we take it up, it actually pushes against it and it will give you the expansion you want. I don't know if you saw it, but this is exactly what you want. You gently push it and you got that opening taking place, right? Okay. Now if you want to see this open well, do it on a blank roadmap. I'll show you over here what we did. This is to show you doing it. I'm moving it fast. We never move it this fast. Okay, just see this. On the roadmap here, you see that black line up here, which means the FD has shifted up and you got the position that you want. So you can actually do a bump and a massage together, and finally you can get this even with your DAC or the Cat5 at times. The final injection, which is good. So again, another case showing you the bumping. Here you have the flow diverter. You can see the lower end is not looking too great. You take the micro, so you can see this is right here, and you gently move this. Of course, one of the things that happens, I want to show is when you do the bump sometimes, if it's not moving, look at the neck. It just means you're probably a catheter has just slipped out, Okay. So we just do this maneuver bump, bump. Can you see that? Gently touching it to make the flow diverter oppose a little better. And that's how we do the bumping, and you can get that done. Okay, that's an improved position and showing a good. So this is another case. Out here looks straightforward. We do
Matthew,
this. Time is up, is it?
I think so, if you don't mind. Can you show some other quickly, one or two important
Just
techniques?
the last one if you want, I can. I mean, the problem is if you want to show a technique, you can just have a look, the push and pull again. I'm just running it really fast, but you can get the idea of how this is done. It's a push and a pull and a push and a pull, and usually you do multiple maneuvers. By itself, it's not enough. Okay.
Is that the advantage or was that?
Okay, I think I'll just to show you it's all fine, I think. Yeah. And the last one, of course, is when you have a tough case, you may finally have to do a balloon angioplasty. And if you do it well, often you won't need it. So just to show you this last one, I think this is the last. So just to show you this bit, this is it. We complete it, and in the neck, in the angle out there, it's still not open, and it's not on a post, and if it still doesn't work, take this balloon and it works. So remember, when you use a balloon, I use a compliant balloon, and it's always the balloon is inside the FD, not sticking out. Okay, I think that's it.
What stent was that, Matthew?
All these are FDs. Sorry, not
I think.
So final FD needs to be pull, push, massage. It's like a relationship. You never know what works.
Oh, I think this was absolutely lovely. This is
Thank
what
you.
exactly.
That was amazing. Thank you very much.
This was, I think every student who starting doing FD should watch this talk. And what I loved about the talk is, we're all talk about, we jump to balloon and stents in the end. The key, as he mentioned, is during the delivery, all the maneuvers you can do. We'll get this, we're planning to build a site, all these talks will be there, and I would tell everybody to look at through again. He covered all the maneuvers. So best part to me is that during delivery itself, use this maneuver to open up. Don't say, okay, it's not opening up, let's deploy, we'll do balloon. You see, balloon is showed in the end. He showed all the maneuvers which can be done during deployment. And he showed all the maneuvers, simple maneuvers using micro catheter and guiding catheter, which can be done after deployment. And only in the last, he showed a balloon angioplasty. I think that's a key in flow diverter safety. Don't rely on balloon straight away. Use all these maneuvers, keep thinking. And another key point which he mentioned was, I'm sorry, I'm taking all this time, but I think this talk was so important to me, that think through. There's no hurry. Retrieve, redeploy. We need not deploy like an expert in 5 to 10 minutes. Take half an hour, 45 minutes, redeploy, think it over, look at the other view. Is it twist? Is it narrowed? Recapture, redeploy, use a different maneuver. And he showed you all the different maneuvers, which I think one should go through this talk again and again, and he showed the videos of it all. So I think this is absolutely what we wanted, and he has done even better than that. So, I mean, okay, so this is, I think, the talk was great. One should watch again. Everybody, every delivery is just not delivering it, just, okay, it will expand. Some industry will say, oh, our FD will just expand, just release it. No, no, no. You have to keep doing this at each step, keep thinking through which step is going to work and use it accordingly. Yeah, Tufail, you wanted to ask a question, and then go ahead.
I think, Matthew, I was just going to ask you, the last case that you tried to angioplasty, was that a pipeline or a evolve? And the one before, was that a pipeline or the evolve?
So most of what I showed is the surpass.
Okay.
And so what I showed, the last set of workers, most of them. So in general, maybe in 25 or 30 FDs, I may just angioplasty one. The vast majority we manage just by maneuvers.
Okay, that's great. Again, this comment.
Very low.
1 in 25 angioplasty. He relies on his technique, not on the backup techniques.
I am not in a hurry at all. And I always know that sometimes when you retrieve it all the way back to the bend and come back again, the flow diverter property completely changes.
Yeah, keep playing with it. One can play with it. And I think all kind of flow diverters, the same techniques will hold true.
I mean,
all these,
of them
okay.
are reasonably good. I think
some of them are softer. You should be careful with bumping, maybe, or maybe yes, maybe that's what you meant. I mean, in terms of
gentle. And whenever you do these maneuvers, especially bumping, make sure your visibility is good.
collimate the beam so you just see that well, so that don't do things without seeing.
That's another key point.
So any difference in the manual between the nitinol-based FDs and the cobalt-chromium-based?
No, there is no difference really. Seriously, there's no difference. It's just that nitinol opens, probably opens a little easier, it's a little softer, but the maneuvers are the same.
And I think proximal end differs a bit in this FD. Some FDs will take the proximal bumping more easily, sturdier, and some of them are not. And another key thing which was mentioned here, looking at the images. Now, a lot of you may be working on cardiac system, single plane system, but cardiac system have got single shots. So please use the maximum, zoom it up as much as possible, take those single shots, keep looking at the FD.
It helps a lot. If you make your beam very tight, you get, we are radiologists, you understand the concept that the quality of the beam improves.
Yeah, and plus like he showed Vaso CT or Dyna CT in the end, even if you don't have it, use different angles. In cavernous, in one plane will look fine, other plane, so use caudal, look for lack of opposition and play around with it. Don't be, okay, it's done, it looks open, it's fine. The more you oppose it well, less complications and more efficacy of FD is very, very important.
But not the least, never be scared to pull out the FD.
Yeah.
I mean, you can talk to the company later.
Yeah, they will give you another one.
Don't say, I have to put it.
No.
There's no way, I don't have a second one on the shelf. I mean, those can be very, very disastrous.
Yeah. If you're really having trouble, it's twisted, it's not working out, aborting is better, having a complication is much worse. 10 good cases and one complication takes away all the good, all the reputation achieved after 10, 15 good cases. So again, that is very important. And don't be afraid to contact somebody, you know. So I think this talk was great. We wanted a supplementary talk. There is no need for it at all, because I think Dr. Matthew has covered everything quite well in this presentation.
Can we move to the next one?
So we'll have just, I know, sorry.
Can we move to Vincent? Is that okay?
Just 10 minutes of more talk and followed by lamp lighting ceremony. Professor Mehta is also here. We're running a bit late and Dr. Sukulyan has a flight to catch. So 10 more minutes and then we have a very short lamp lighting ceremony as well. And he's talking about challenging access in FD and innovation. So another challenge in FD, we talk about opening. And we'll have now videos in the later session, again using the techniques in opening, which Dr. Matthew has laid it out so that we can all revise them in a way. But the crossing at times is a challenge. So Professor Winston will show some interesting ways to cross. And this will be followed by Matthew, if you're okay, Dr. Sukulyan. Dr. Sukulyan has a flight as well in early afternoon. And then we do the lamp lighting and then the rest of the talks will follow. Yeah. Thank you, Winston.
Yes, so we decided to just run one case to illustrate, so we published this technique in the literature as well. This is a case of 30 millimeter ruptured giant aneurysms. If we make a small drawing, we see that this is a giant, very wide neck aneurysms, with the drawing do not represent the neck, but there is a pecan, fetal pecan rising from the neck. And there is like a small dot here, looking like a dissected things, you know, you can see here. So when you have this at the acute phase, you don't know what really has bled, but you need to treat something like that. So the indication of flow diversion first was clear at the acute phase. This is the 3D of the patient. So you see the mass, and one of the most challenging things you may expect is to just get from the other side of the carotid, okay, because you have no limits to the carotid wall. This is how it looks like epilateral view. And the problem we have is the angulation between the C1 and C2 part of the carotid, and also the probably dissecting part of the carotid that we should treat here. So you see again and again this probable dissection of the carotid. we tried to make an occlusion test to see if it was possible to stop the carotid very simply. But you see there is no parenchymography at all, so the patient needs the right carotid. Simple coiling, double catheter, remodeling for the diverter, intrasaccular treatment. The problem is that if you occlude the carotid here, by the ophthalmic you will have this flowing. You will have also the PCOM flowing. If you occlude the carotid here and you want to occlude all this segment, then you are suppressing a little bit the flow there. And you are cutting the flow of those two things to supply the supratentorial stage. So we thought the reconstruction by flow diverter was the only solution, and it's a rupture case, big hemorrhage, so I'm not so happy to do this case, but all is about to cross the neck, and you see the angulation, you understand it's not easy at all. It was, of course, impossible with the wire. We tried with a small balloon first to try to make some support, but it was so wide that it was impossible. And the only technique, it was the first case I did here before doing it many times now, so my team is doing it. Other people, Saru is now doing it as well, and there is only many other people that are doing this technique because it's a simplification of the crossing of the aneurysms. When it's difficult to just open a web, it's expensive, I know, and you pull back the web to the contact of the wire, and then you just have creating a new wall here. So you just normally push your wire, and what is good is that you don't need to loop, to anchor with a stent. I never do that. I used to do that before, but now I don't do it anymore. Again, my gimmick is simplification, and this is a simplification. You just create a new wall here and just push your wire, and also over the wire, because you still have support, you can put your O27 without bulging. Sometimes you can go, make an exchange, but the O27 will still go there. You have clearly the capability to put your O27 on this. Yes, and after there is a O27 going through this. And also I think, yes, you see this, it will take support also on the web, and you can pull back the web, and you can pull the web against you to make it easier when it's difficult. So then we will deliver the long flow diverter after simulation and sizing, and after we will detach the web and just coil everything. For this case, that was a challenge case. So it's just an illustration of this web redirection technique. It works also with the contour. We did a fantastic case. We will see it later in the day, so I don't want to discuss, but it works with the contour. And it's a very easy and reproducible way of solving complex cases. Most of the people, they tell you, I do 2 loops, 3 loops, 4 loops, then I find the lumen, and I put a flow, then I put a stent river, I unloop everything. I make a wire exchange, I make a O27. Wow, it's a lot of maneuver. And the chance it's failed is very high. This is expensive, but extremely easy to make. I mean, any people can do it. You just need to train like 10 minutes, you will do it yourself.
Great, Vincent.
Thank you.
We plan for a flow diverter. If it really happens, you think you can just cross this aneurysm, and that becomes a stumbling block. There are various techniques. We are starting in a reverse manner, where Vincent shows one of the newer techniques, the only catch being that for us Indians it can be a bit costly, but it's still very elegant. If you're getting stuck, like in ruptured aneurysm, you don't want to go through the aneurysm. I mean, whatever I may think, I don't think I can cross this aneurysm without going through. In a ruptured case, what to do? Now we know there's an option. And okay, maybe it's costly, but it's an option that using the web as a support to cross without going through this aneurysm. I mean, I think it's beautiful. And we'll show you something more basics as well. If we are starting the reverse way, and Sukulyan will show, and then we will also show some basic techniques as well to cross this aneurysm, which can be a challenge. Tofel, you wanted to say something, I think?
No, I think it's a good technique. I wanted to ask Vincent, you had a wire already in the distal ICA in that case?
No, no, this one, it was just, the tip was just grabbing the origin, but no, it was impossible to go. I just show after the navigation to show that it's bring you also support to put O27 and... Yes, most of the time I have no access at all. I just put the web and I pull the web and create a new anatomy that helps me to get it. It's work in ACA, MCA, carotid.
Right, thank you.
Also, Vincent, we're not talking about crossing here. Would you like to tell how long a flow diverter you'll use in such a broad neck aneurysm? Distal anchoring is how important.
Oh, yes.
Yeah.
Yes, I think, and we had a big, extensive explanation to the attendees yesterday during the SLICE Artemis workshop. Yes, it's very important. The larger the neck is, the most important should be the anchor into the vessels, and never hesitate to cover the M1 segment, to anchor the M1 segment.
Yeah.
It's easy deployment, nice anchoring, and don't be tight in the T here, because you will fall down into the aneurysms on this case, and it will be a nightmare. So very nice anchor.
Thanks a lot. So very important, once you have crossed and you think now you'll just deploy, no. Whenever necks are like this, you have to have a great distal anchorage. And as you mentioned, most of these cases will start from M1, anchor from M1, then come into the ICA, so that when you're manipulating to open at the bends, if it is only in the ICA, it may just all fall into the ICA, and then you are in trouble. You'll waste the device, restart the procedure. So in these kind of cases, long flow diverter, a lot of anchorage distally and proximally is very, very important in such dysplastic necks. So we'll have just one small case presentation and followed by lamp lighting ceremony. Dr. Sokalyan, he is one of the pioneers from eastern part of our country in Kolkata. Great friend. He was with us for last 2 days doing the SLICE training course. And he will also show a case in which he used something innovative in crossing the aneurysm.
Anybody has any questions while they're getting this? Any odd?
Yes. Dr. Vincent, what was the access you used in the last case? Because you were having the web for that via must have been used, and you were having a catheter for the flow diverter. So what was the access you used?
So for this technique, it depends if you have to do it in a small aneurysm or for a very big one. This was a big web, I think it was like 227, so I think I added the second access in the common carotid to deal with the web separately. But most of the time when you're using in the ACA or MCA that is not so big, just a 7x3 web is enough, so a 017 catheter is enough to make the technique. You can use like a 6 French as usual, okay? That's not like normal access. But here when it was so big, I used a big web, so I had to add another access.
Anybody in the audience has any questions?
Sokalyan, are we getting there?
This is just another case. So this is a large one, a bit largish. So this is obviously a cavernous ICA aneurysm, and then again the challenge is in crossing. Sometimes it becomes easy for us to cross it with the wire and the catheter, but sometimes because of the wire direction, it usually tends to go away from the outlet, and it's very difficult. And the same, like the last case, what he had shown, that it was a ruptured aneurysm. So this is an unruptured aneurysm, so we can definitely play with it. So this is the angulation. So what you can see that, when the wire goes, it goes to the lateral aspect of the aneurysm. So it doesn't come back medially, and that becomes a challenge. So this is the angiogram. And then again that we went with the triaxial technique with the CAT5, what you can see distally, and then we went with this is 027 and synchro, the combination, and what we can see that in this area, from this part, the exit is, and it was very difficult to go with just a single loop. It doesn't cross because your catheter is in a separate plane altogether. So it has to be in the plane which is quite medial, because as we can see that when the catheter enters, it goes to the lateral aspect of the aneurysm, and it doesn't work. So I tried with many different position of the microcatheter because I didn't want to make too many loops, but it was really difficult to cross with the microcatheter just in without making too many loops. So that's very difficult. And it took a lot of time, so ultimately what I thought is, okay, let us make a couple of loops here and then try to cross the aneurysm and try to find the outlet and then go. So now we can see that there are two loops which are not very friendly, but when you push the wire, it tends to come inside the aneurysm circuit as it forms because there is no support there. And in this situation, what to my understanding, I have found the synchro is the best way. What I use, maybe other operators can put some light into that about the choice of the wire. And you have to have some sort of a support into the wall of the aneurysm to cross actually. So ultimately with making a couple of loops, we could cross them, but at the end of it, you can see that the aneurysm, the O27 has gone distally. And I tried with many maneuvers just to take the catheter, make it straight, but it never happened for almost 20 minutes. And then I took a 640 stent retriever. It went with a support of the distal access catheter and then delivered this 640. Why I took 640 is because it's a bit large and it has a good anchor in the MCA. And then take CAT5 a bit distally and try and manipulate very slowly. So this maneuver, obviously, it's not recommended when there is a thrombus inside the aneurysm. So that might dislodge thrombus and can cause some thromboembolic complication. But with the float, with the stent retriever, because it catches your system distally, it is easy for us to make that O27 catheter straight inside the aneurysm wall and find distally. So at this point, now an extension of it is that you can take your CAT5, put this stent retriever a bit distally, and take your CAT5 also quite past the aneurysm next, and that will help so at the end of it, it looks like that. So it is the way we want to put the aneurysm, put the microcatheter distally and without any loop inside the aneurysm. So that's just I wanted to say. Sure. So any other way to, in this?
No, I think that's a great, I think you made a point about the bigger stent. If you use a smaller stent, it doesn't anchor very well. Yeah. So if you're going to go, if you try a 3 or a 4, sometimes 4 might be okay. But I think it's a pretty good technique to use.
Yeah, actually in our center, like the last case what I've seen, that the support with the web, so it is unthinkable here because of the cost situation. So this is obviously we have a lot of device in our lab from the older cases, and we can use that with the help of those devices. You can do the case, obviously, to keep our
No, I think it was a
costs
beautiful video, which showed all the issues. We also love synchro. And then this has become a new elegant way of straightening the catheter using a solitaire or any stent retriever. I think he showed it very well. Yeah.
No, the other thing which is sometimes useful, particularly if you've got a very wide neck and really big and wide neck, and you're going to need a very long stent, is to track your CAT5 also distally.
Yes.
And I think, and then if you're not sure, you can deploy your stent into the CAT5, and then you come back or deploy if you need overlapping, and then you can deploy overlapping and then retract the CAT5. I think if you got really nasty looking one, and I think in the conference last 2 days we were talking about it.
Yeah.
If you got a big aneurysm, acute ruptured aneurysm, you want to coil it, but if you got a ruptured aneurysm like this, it is important not to just coil it, but you should probably stent it, because once you coil it, you can never go across. Yeah. And actually you do much more harm to the patient. So
what Dr. Tufel is trying to make the point here is, once you have crossed, It's not so easy to deliver a stent. Even the microcatheter may be like flail in the aneurysm. Once you're across and you've got a very stiff system in, you can take your excess catheter like Cat5 or anything, Sophia, whatever you're using, and nowadays Phenom Plus is on a great catheter, you take it across. So the whole system becomes much more stable. So when you're releasing the stent, it's like two catheters, and your guiding becomes like another microcatheter, and you can do all those manipulations, so, and to deploy the stent through the aneurysm in a controlled manner. And that is what our point Tufel is trying to make, that take the guiding across, and then using that as well, it becomes much more stable to come across. Flow diverter delivery becomes more, because flow diverter delivery needs force to open up, right? If it is something weird angles not opening up, but if you have two systems in there, then it's much easier and much more controlled in opening there. Yeah, Professor Vincent.
Yeah. One point I think is very interesting in the remark of making the Cat5 up to the M1 in this peculiar situation is that if you have the 27 and the angulation is really unfavorable, while putting the flow diverter itself, because you are straightening the system, you can re-loop inside and lose your distal access because we have to anchor into M1. So you have to be very distal, but you are losing a lot of room because of the rotation into the cell. So you can, if you can put, the Cat5, I think it's a great value, I think. As well,
that is another thing
we're mentioning.
So Vincent is saying, even taking the flow diverter, you may lose it again, it may bulge into the aneurysm. So one thing is, get your catheter into M2. Number two, when you're crossing it with the flow diverter, keep pulling on your microcatheter, it doesn't bulge. It has to go in one smooth go. Or if you have taken your distal access across, then all these issues are gone when you cross it.
So, Vipul, there's one more important thing when you talked about keeping the Cat5 to make sure that the FD doesn't buckle. So remember another step, never push the FD inside a wide neck. The whole thing will buckle inside. You unsheath, you unsheath.
You unsheath, exactly. You
don't ever forget this. And remember another thing, so therefore, make sure your apposition distal to the aneurysm is perfect before you enter the aneurysm.
I think that's the point we discussed last case with Vincent, that it has to be distal anchorage, has to be very good as well.
You can't do much of manipulation. You'll pull the whole FD and it will happen so fast that next moment the FD is in the aneurysm you are screwed. I mean, there's very little you can do.
In later sessions we have some videos where we
important. Again, go slow.
Thanks.
No hurry. And a Cat5 is a fantastic idea to get everything positioned distal to the neck, then come back slowly.
Great. Thanks a lot, Sukulyan, and you gave us a lot of time last 2 days, and they have been here since Wednesday to plan for this slice training course, and 2 days we were crazy, like 8 to 6, we were absolutely busy, and all of us, so Dr. Matthew, Vincent, Tufel, so Dr. Sukulyan is leaving shortly. So before you leave, let's quickly have the lamp lighting ceremony. I want to invite Professor V.S. Mehta. So Professor Mehta was the Chief of Neurosciences and Chief of Neurosurgery when I was in AIIMS. He is my mentor. In fact, he made the neurointervention program happen in AIIMS. That's the way I see it. He encouraged us to do the aneurysm surplice. And I quote this to many people. At that time, I had started off, and it so happened that I would say, sir, I can't coil this MCA. And he will say, people, I will also leave a neck. Why don't you do it anyway? So he encouraged backups like this. He actually used this word once, that people, I'm more likely to cause mortality here than you. Why don't you do it anyway? And that's the kind of backing. I'm talking about 25 years back. So he was very supportive. He was my mentor at AIIMS. I'm so happy now that I've joined Paras Hospital like 2.5 months back, and he's the chairman emeritus. He established that unit, and he's here now. And I also invite Madam Seema. She's the facility director at Paras. She has been very supportive of the neurointervention program. And she just kept saying, please tell us what you want, and she will arrange it for you. Dr. Padma has already left, and Professor Manmohan. He was my colleague at All India Institute of Medical Sciences, and now he's even a better doctor because he stayed for 15 years more in that great institution, or 20 years more than me. And he's chief of neurosurgery, he's the vice chairman of neurosurgery at Paras Hospital. And Vincent? Yeah, so Professor Vincent runs a very, very big program in France. He holds this slice training course, and first time he held it in Asia with us. 2 days of training program. We will show those images. You can see behind. 3 days we went crazy, We use 3D models and AI systems to make those 28 students practice actual flow diverters, all these maneuvers. We taught them real time with actual devices. He arranged all those devices, maybe 70, 80 flow diverters we used up in this workshop. He arranged everything, 3D models for us to make it happen. And Matthew and Tufel. Tufel is of course from UK, but to us he's a local Mumbai guy. You know, for us he'll remain so. He's one of the renowned neurointerventions in the world now. And Matthew, you have all seen by his talk. He's one of the best teachers in this country. So all of you, I'm really thankful. As Matthew said, you are not going to suck our knowledge dry. I will not use the extra words which he used. For the last 3 days, they have been very, very busy with us, all of them. And please, sir. I'm so sorry, 1 second. Pallab. This shows when you get fatigue what happens. Dr. Pallab is our chief of neurocritical and neuroanesthesia. He's most important to me. All of you guys, if you want to do well, have neurosurgeons backing, enough knowledge to convince a neurologist, but be very close friends with your neurocritical care people. They save lives all the time. I'm so sorry. Thank you. Please go ahead. So before we start, can you say a few words on behalf of all of us?
Such a nice gathering today. I never expected that this will be the strength of the, so many people have come. Now, as Dr. Vipul said, when I was in All India Institute, I used to do a lot of aneurysm. And many times, a morning a case will come, angiogram will be done, and meanwhile I'll tell my resident to open the case, and while I'll coming back from my office, I'll clip the aneurysm and go home. And when I went to England, I saw Dr. Golkar doing a lot of interventional cases. So when I came back, I asked my neuroradiologist, Dr. Nalin Mishra, and said, I was very excited to see those cases when aneurysm being coiled without opening the skull. So, but often Dr. Mishra would discourage. No, this is not a good case for coiling. So I quietly go to Vipul and said, why don't you try? And that is how we started. And after the ISET trial, as you all know, there was a lot of debate on whether coil or clip, coil or clip. I think there will be no conference without this debate on clip and coil. But today I think this debate is gone. There is no debate. I would say they are complementary to each other, And most of cases, of course, are dealt by the interventional neuroradiology with very nice, good results because of advancement in technology and, of course, the hardwares and machines. And I wish that this continues to further grow. There are certain complicated cases which still difficult for intervention as well as surgery. And sometimes, and Manmohan is going to talk to you on bypasses in such cases, and the importance lies still. So I feel that practice for both neurosurgeon as well as interventional is essential. And with this, I congratulate Dr. Vipul Gupta for he's a very good technician. I think I have seen his result and our excellent result. And once you see the excellent result, you also feel that yes, because what is best in the patient interest should be done. That is what always I say. And if I give a case in his hand, I feel very safe. Thank you, Dr. Vipul. Thank you.
No, I think one thing I learned from AIMS is we have to develop, whether we are radiology or teamwork with our clinical team. There's no other way around it. Believe me, if you're doing neurointervention and you know your neurosurgeon is going to back you up, it changes things. Number two, a lot of our radiology background, we are not used to morbidity, mortality, risk-taking. When you work with neurosurgeons, so you have to learn this surgical attitude. What we are doing is surgery by another means. Surgical decision-making, clear-headed decision-making, protocolized decision-making. So we have to learn that attitude as radiologists. Even neurologists have to learn that attitude, okay? So we have to develop that surgical protocolized thinking. You know, we can't be physics radiology people. We have to have a surgical mind to handle these patients because it's not a matter of intervention, it's a matter of good outcome. That's what I would say. So just before we stop this ceremony, Madam Seema, would you say a couple of words of encouragement to everybody? Because you need to have hospital backing as well. It doesn't work the other way. You may know all the techniques. Hospital backing is very, very important to do anything. What do you say? And yeah. Yes. All right.
Good afternoon, everyone. And I'm too small to say anything on this platform right now, but I just want to thank Dr. Vipul on organizing such a beautiful event for all of us. I think it's very, very knowledgeable. In just 15 minutes last being in this session, I could see this is really the most knowledgeable session I've ever seen. And thank you so much, sir, for joining us. And I think we have a wonderful team of neurosciences, and I'm sure that we'll be doing very well in future. Thank you. Thank you so much.
Thanks a lot. So again, we'll carry on with the program. I want to thank Dr. Mehta and Madam Seema, Manmohan, Pallav to take out this time to join us here. So again, we have got the master of the teaching, Professor Matthew Cherian. He'll talk about again, challenging access and innovations in crossing hostile aneurysms. Yeah.
Honestly, for me, it's such a pleasure seeing Dr. Mehta. Many, many years back, when we were just starting to coil, my sister-in-law had an ACOM aneurysm, and I was astounded at the fact that they were so minimally invasive. It was terrifying. She had no visible scar. She had nothing. I mean, he did it under the hairline. She came out with nothing, and within 2 days she was back into the room. So sometimes we think we are so fortunate we don't have such brilliant surgeons all over the country. But I think Dr. Mehta is one of the greatest vascular surgeons this country has. I don't know if you realize it. And the many, many people who trained under him, I think, have been so fortunate. So thank you once again for that. So today, thank you so much. Yeah. Great teachers are very hard to find. So today, so the next talk I'm going to give you is how do we cross a difficult aneurysm. You know what? If you do not know how to do this, every aneurysm is difficult to cross. So let me assure you, difficulty is a very relative term. What would be difficult for someone may not be. So I enjoy making my presentations look a little bit like art. So difficult angles are always difficult for everyone, right? Okay. Now, these are some of my favorite tricks. Some of them I discovered on the way. Some of them were told by people to me, right?
The problem comes in when you have a large aneurysm, which you also, how do we cross it, right? So you look at this, this is a crazy aneurysm by every standards, right? And you would say, how do I cross this aneurysm? I was just telling Vincent, maybe I never used a web, never dared to use a web for the fact that, you know, it's another 7 lakh device. So unless the company makes a non-detachable web that could be reused forever, it would be a good idea. So let's show you how this works. The first thing, you take your catheter here and do not try to cross it directly. It's never going to happen. So don't even try it. It's an absolute waste of time and totally ridiculous. So take a wire. Take a soft wire because it's going to fold inside. And I generally, very often use a Traxxas, but a soft Traxxas, but you can use a synchro, but provided it's an unruptured aneurysm. So what happens is the wire takes this loop and finally it will find its way out as you twist and tog at this point when you have got this perfect working angle. So as you tog and push, you'll get this way out. So that's fine. Then, can you see the blue line? Is it visible? That's the micro. You take the micro up, 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 and up. So when you take a 2/7 micro catheter, sometimes it may be difficult, sometimes may be easy. So if it doesn't go, you have to take a standard like a head weight, which would go much better than a head weight 17. It's fine. But the challenge is what Sukalyan was talking. How do I straighten this loop? Just pull the wire out. That's how you straighten the loop. One day I was struggling with this and Dodi was standing behind my back. He said, just pull out the wire. I said, as simple as that? It is as simple as that. If you pull the wire out and your micro is in a distal position, the micro will not fall back. It's a fundamental. If you don't know that fundamental, you will struggle and you'll struggle and you'll struggle. So remember this fact, softer the catheter, the easier to track, softer the catheter, it will never fall back. Have you got that? It's a fundamental. That's why I said, if your fundamentals are right, difficult aneurysms are seriously not difficult. So we have not had a single aneurysm we have not crossed. I'm not saying my numbers are in thousands, but it finally will go. And this is a simple maneuver. Remember this always. If it doesn't work, you can try something else. Here it is. And this is exactly the maneuver that Vincent was saying. When possible, take your Cat 5 across. I'm not saying Cat 5, Sophia 5, any of those. And if you do that, you're very stable. You can do, because you want to oppose. And if you're going to push hard on the FD in the neck, the FD won't oppose, it will buckle into the aneurysm and you will have a problem. Okay? So I hope you can see this. This is finally the procedure we did. Very well done. Now, how do you take a micro across a very bad tortuous distal vessel? So most of them, unfortunately, look like this. And you want to take this across this, right? But the problem, what happens is, when you try to do this, this happens. No. It looked very easy before, and this happens even when you take a 1/7 micro. You know, and there was this case once, so if you get a synchro extra support, it can sometimes be a miracle. But a synchro extra support is also a dangerous wire. It's got a habit to whip forward, and sometimes you can perforate, but sometimes this can work, and you may be able to take it across, and again, pull back the wire, it will straighten. Look at this, terrible looking vessel, a crazy artery, but the end of it, you see, we are trying with something else, it was not going, and then we'll show you how it would. So this is actually stacks of images, which is a lot more realistic. It's just not happening, we couldn't get even a tog on it, and this is with a synchro extra support, where it totally behaves so radically differently, and we could cross. And you can also see there's a little bit of a step there, and by pushing on the extra support, you can actually take this across.
okay, and there it goes, okay, fine. That is it. Finally you do the treatment and you got this and it's fine. Okay. This is just, of course, the same thing you saw, how you do it, the push-pulls, and you got this done and it's fine. Okay. Okay. How do you take a micro across close to a hairpin bend? Again, a very similar situation. You try to take it, it keeps kicking back. Over and over again, this happens. And then we discovered a very simple thing. So in sheer frustration, we tried with the SC27, we tried with the headway, we tried with the extra step, it is not working. We just gave a curve to the micro. It was amazing the way it moved up. Unfortunately, I don't have the recording, I think, I'm not sure, but it seriously just went like a dream, you know. So I don't know, yeah, this is the one. You can see the bend. Can you see how tight that bend is? It's so insanely tight that sometimes it just will not take that bend. It keeps buckling all over the place, right? So remember this very simple technique, and I found it astounding by just giving it a curve which is like a C, and it just tracks across, and it just goes. So 3 points he asked, I gave you 3 points. Getting beyond the curve is possible, and most of the time, if you got those fundamental rights. Thank you.
Anybody has any questions? Any comments? Vipul?
I don't know, I've been talking a lot, so again, crossing techniques and with the animations, I mean, you've covered quite a bit, and anything, Vincent, Tufel, anybody in the audience?
I have to say, recently I failed in a very large carotid ophthalmic artery aneurysm in a lady who had presented symptomatic, and she was young, and I started the case at 9 o'clock in the night, 8 or 9 o'clock in the night, and wasn't a good thing to do. I tried, I managed to get across eventually with a 17 catheter, and I didn't want to atlas it because I wanted to exchange, because it was a giant, super giant ICA. So at 1 o'clock in the morning, I gave up. So it was 1 o'clock in the morning. And I actually had a little bit of trouble here and there, but I'll stop. I should have probably put a baby Lee or something. A baby Lee would have been too small, so I didn't want to do it. So I decided to leave it, speak to the neurosurgeons, and there was a possibility whether they wanted to clip it. And on Monday morning, on table, she went on table, she was unruptured, symptomatic. On Monday morning, she just went on the table, anesthetist was going to put her to sleep. She ruptured on the table before, and she died on the table. So I learned my lesson, and I don't know whether at 1 o'clock in the morning I could have carried on further, but I couldn't cross. I tried everything, looping. But I think my mistake was on that day, it was the 5th case, but it was an elective patient who had come in as a and I bumped her from another elective case, and I think starting at 9 o'clock in the night was probably, I was already on my 5th case, and I was tired, and it was in London, so I was going to go back. I'd missed my train, I'd missed everything, and I think starting cases like this so late in the night itself, I think, is a big problem.
I absolutely agree with you, Tufel. I mean, a lot of times, my major complication, when I look back, you start a difficult case late afternoon, you start struggling with it, what else have you done? And you know, intervention is very funny this way, it's micro-invasive, but it needs very fine control, very alert mind, and I think it does make a difference to start cases late, but what you faced, sometimes you feel you can cross it, it will work well, but all of us get stuck. And aneurysm is a deadly disease.
Well,
yeah.
I mean, just a point for many people who are young, I think you get into this complex that you can achieve everything, and you get into this complex that you are invincible, and one day the aneurysm just
that aneurysm recently brought me down to ground, that I should not have started a supergiant carotid ophthalmic 9 o'clock in the morning, in the night.
Yeah. So that happens. And thanks for sharing. Only when you share this real life situation, you realize how tricky handling these patients can be.
People,
So I will just quickly.
I have a comment. Arvind.
Yeah, please, sorry. Yeah.
No, all this while what we look at is the anatomy, that there is a curve and all. What we are not concentrating is also on the hemodynamic. What I do sometimes is I arrest the flow proximally and try to cross it. It will just cross.
So I'm very happy you mentioned it, because I was going to show some crossing techniques, but doesn't include the flow arrest, which does work at times. So let me go back to the very basics as well. Some of this has been covered, but I'll quickly go over some slides in few minutes of crossing techniques. We have seen web-based crossing technique, microcatheter shaping crossing technique, solitaire-based, and as Arvind really mentioned, flow arrest does work at times because the wire is not going the right direction, but the flow is taking the other way of the microcatheter. Flow arrest does help. So let me go over some of my old cases. Looks like a very straightforward crossing of a basilar giant aneurysm, but whatever we could do, we couldn't. In that era, we were crossing with a balloon. That one of the technique was, and you take a loop across, and then you inflate the balloon and straighten it, and then you exchange it and place your microcatheter followed by a stent or a flow diverter placement. So this was the older technique when we used to use balloon to cross. Another is microcatheter straightening with wire. Again, a large paraclinoidal aneurysm. These are the ones which are difficult to cross. It keeps going in, but at times, you know, and we crossed it a bit, but the microcatheter just wouldn't track beyond this degree. It will bulge into the aneurysm. Sometimes wire may go across, and beyond a limit, here you can see microcatheter was getting stuck. So we had to go through the aneurysm. But sometimes when you go through the aneurysm like this, so there's a way that you are going from here to here, and sometimes the catheter has gone from this to this. Sometimes you can just straighten it just like that. So this is what we did. These are 2.7 micro. We went in, and when we went distally, all I had to do is keep the wire in the middle of something around here and just pull back gently, and we could just straighten it. So have this in mind. Once I've gone in this direction, then we need not do any extra. Okay, we could have deployed solitaire, other things. Sometimes you can just straighten it just like that. This is just another way of getting across. And then of course we could straighten it, and that's the flow diverter, and we could get ahead with the placement of the flow diverter. I think Kalyan showed this very, very well of straightening through a solitaire. Just another case, again a large cavernous. It looks like very easy to cross, but sometimes direction of the flow is such that it doesn't. Maybe flow arrest would have helped, just as Arvind mentioned recently. Again, we went through the aneurysm, and once you've gone across, we are deployed. In this case, we use a 4 mm solitaire, and you deploy and you straighten the system using the solitaire and to get across it. And that's a solitaire another angle. You deploy partially, just part of it, and just pull back gently, and one can straighten the catheter and then go ahead with the flow diverter placement in such a situation. Sometimes your wire goes across, your mitral is going across, but the ledge effect is that it gets caught at the edge of the aneurysm. In fact, I think this was the second pipeline done in North India when Dr. Bokhari had come. We were starting this program of flow diverter when I was in Vedanta. Again, it's an IC aneurysm. Our wire crossed easily, but microcatheter was getting stuck here. Whatever we could do, we could use a stiff wire, anything. So nowadays we don't have to use this pretty often, but we use 2 wires into the system. So with a Traxxas in 14 wire, you can push in an 08 wire like a Mirage or even a hybrid. And so we placed 2 wires, and then the microcatheter tracked across because it just straightens the catheter. So sometimes you can use, nowadays we even use synchro stiff wire at times, okay? You can use that, that's a very nice wire, or sometimes you can place 2 wires through the microcatheter so that it tracks across the aneurysm, and then the flow diverter placement was pretty straightforward, and this was the, so very quickly I tried to cover using balloon, microcatheter straightening. You can use a solitaire, you can use 2 wires, and of course we have got the web technique, and we have got a flow arrest technique, and we have got microcatheter shaping techniques covered by all the faculties in this session. So, you know, so I think, and I'm sure one of the youngsters will come up with a newer technique in the next meeting as well. Younger guys are pretty innovative, and that will happen. Yeah.
Just one point, there is startup company doing steerable wire, And maybe all this will be forgotten after those guide wire with us. So, I mean, you can shape the wire with an handle, so you can completely go in any direction, even if you don't have all a position. So it's coming. Asteria is a company, Switzerland company, is making those wire. Now not on the market, but it's really impressive. So maybe it will become even more simple, even if it's complex in these tricky cases.
And I think one more thing, Whipple Bendit catheter.
Yeah, bended catheters.
It's also pretty good, and it will, you can bend it around, and I think
it is a steerable tip. That means from outside you can change the tip direction of the microcatheter. Known as bended catheter is not yet available, but in future that will be great in crossing this aneurysm. Technology is really helping us.
Can you teach me about this fluorous catheter that you told?
I have never done it, but people mention it does work.
So how does it work? Because I've never done that.
What we do is, usually I take a coronary balloon, or this one 4 by 20. I arrest the flow proximally in the ICA.
Right.
And through that, by the side of that, I take a microcatheter and take it.
And you think that works?
Yeah, it works.
Okay.
All right. Good. Okay, so I think we'll close this session. Thanks a lot to the chairpersons, Amit Tufail. Let us give him a nice clapping. He has been with us for the last 4 days and ever active participant. So we go on to the next session, and Dr. Shailesh, Dr. Anita, and Professor Vincent, can you be the chairperson? I don't know whether Shailesh is here. But we are changing the sequence a bit because Professor Mario Martinez from Spain has been waiting for a while online. His talks are online. There are 2 talks of him. One is on fusiform aneurysms, overlapping flow diverter. We want to cover this topic. At times, one flow diverter is not enough. And sadly, when they were printing the session, our printers missed the one session from 12:50 to 1:20 about troubleshooting. So there is another talk by Dr. Mario about migration of FD and challenges in opening tips and tricks. So he will take both the talks, and this will be followed by Dr. Manmohan Singh's talk on bypass surgery. So can we have Dr. Mario's talk? I mean, I think they're good. Can we start it?
Hello everyone, welcome to this ANVI Masterclass. First I would like to thank Dr. Gupta for the invitation. It's a really honor to be here today about talking about this wonderful topic. I hope you enjoy the presentation, and if you have any talk we can discuss after all. Well, this is the name of the topic. It's called flow diversion, herniations, or migrations into aneurysm sac. This is important to discuss the types of the migrations and how to solve these terrible complications. There are some technical tips and tricks, and I think that you are going to find it really helpful. That happens to me in some specific cases, and believe me, I spend a terrible time to solve, so I think it's very important for us to share this type of experience in order to minimize the potential mistakes or the potential bad times that we may have by achieving this type of complication. Well, this type of overlapping herniation could be devised prolapse into the aneurysm. So the reality is an underreported complication. Nobody talks about that. There is no descriptions, into the publications, no description into the trials. So the point here is that it's a really potentially devastating technical complications that may finish in an arterial occlusion or may finish in thrombembolic or hemorrhagic complications. There are different causes for having this type of complications, herniations. So First thing is it could be immediate. They happen just immediately after placing the flow diverter. That's called procedural. Or may happen into delayed fashion. It happens. You need to know that it happens weeks after the implantation. Now, most of the times is because of foreshortening of the device. Maybe more frequent when you have some arterial mismatch, because some of the arteries have proximally or distally, they don't have exactly the same diameter, so you may have this arterial mismatch. And what's going to happen is which is called watermelon phenomenon with a foreshortening device. Another cause will be catheter. Yourself, after finishing the deployment, you may push the microcatheter into the device and foreshortening and prolapsing this or sending the device in the aneurysm, so it will be the one creating this and and another reason could be try to do too much sheathing in the delivery. And it may happen, it's an example to see that if you want to sheath too much in order to increase the length, the device, what may happen after that is going to foreshorten, because the device usually goes to the length that is designed for. So don't try to change the length of the device by sheathing more or try to pulling back more, to cover more segment, because the stents naturally they're going to foreshorten. That's just called accordion effect. And I think the most typical reason is the incorrect device sizing, because you select a short device. So if we need to understand there are two different types of device migration, could be proximal or distal. So imagine this case, it's a proximal artery, for example, proximal ICA, then the aneurysm, then the distal ICA with an A1 or A1 here. So if you analyze this and you have this type of anatomy, so you need to differentiate between proximal and distal end of the device. If you can distal end, protrusion, we could go benign because it's really easy to solve this type of complications. So the device go back here, you have the device implanted, the device proximal migrated into the aneurysm. So this distal end migration could be easily solved by renavigating the system with a loop inside the aneurysm. You may do this, and I will show you cases later, don't worry about that. What happened with the main problem is the main problem is when you have this proximal end migration. When the proximal end goes into the aneurysm, then you have a really, really problem, because we could call malignant, but it's not malignant, it's just to illustrate. It's a really complicated way to go through, because it's not easy to find a way. Usually the devices bend, this is the natural way, so it's really complicated. You can imagine that you cannot go so easily inside using the microcatheter. I'm going to show you different techniques for trying to regain the access, which is the proximal end. So again, proximal end complicated, distal end more easily to technically match. Okay, so let's talk first about the easy one, the distal navigation. So this is an illustration of the case that I did some years ago. It was a supracardiac Intrasaccular, and we initially placed the device here in this point. This is the distal end. And distal end seems okay, but we could say it's a little bit closer to the aneurysm. If I had this case now, I would probably have distal end here. But anyway, we placed the device here in this junction, distal ICA. The patient did pretty well, but 3 months later, patient tell us that they have some headache, so we did a CTA. And that's what happened. You see, you have a tremendous proximal, distal migration. You see here the device is completely inside the aneurysm. And this happened because we have this mismatch diameter, and we place the device really close to the aneurysm, and we place the device in this junction, in this port. So having this for sure you need to solve and you need to treat. So how to solve this? Easy. You navigate through the stent. You have the proximal end open, so it's just go through, do a loop inside, achieve distal position. You may do my recommendation with a double balloon. Then you inflate the balloon and keeping the balloon of this segment. You see the stagnation here, and now the devices are much more stable. Well, let's go into the more complicated migration, which is the proximal end migration, the malignant type. I'm going to show you two cases of this complication. This is the case 6DC, and this impression. It's a supraclavian. Sorry. So it's a supraclavian pigment aneurysm, large. So we place the pipeline in this line one, as you can see here, and then we navigate it more proximally over the neck, and you see the proximal end. So my mistake first was to select a very short device for my 18. Having this case now, I would go select a 30 or similar. And I tried, because I realized that, I tried to, try to stretch a little bit more and do more shifting in order to do this a little bit larger. So this is the maneuver. It seems okay after the finishing the maneuver, but I retrieve everything back, I retrieve the micro and the wires, and I did the one, and this is what happened. So completely proximal and migration inside. So now we have a problem. I presented this in different meetings and we have different discussions, and nobody had the answer for, solving this complication. So we try to regain the access, going inside again the stent, and we spent many hours, actually 3 or 4 hours. It was impossible because the microcatheter always tend to go to this part, because you see it's a typical, way of the blood inside with this shape, so it's impossible to achieve this core inside the stent. So we, after 3 or 4 hours thinking, okay, we realized that we need to try to move, I don't know how, try to move this proximal end of the stent from this position to this position, and keeping this, then we were able to regain the access. So to move in this, what we thought was to do this maneuver. It seems dangerous, but really very gentle. So the way is to place the balloon, around the stem, close to the aneurysm lumen, inflate the balloon very gently, and at the same time, pulling back the wire to avoid overpressure. This is a really risky maneuver. Just you know how to do that. So we inflate the balloon, pull back very gently. Then we change a little bit the position of this proximal plane to securely inflate a little bit more. Now we have more inflation, and now it's more easy to regain the access. So we kept the balloon inflated without touching, and then we select another micro wire, and at the same time we navigate through this distance. So once we are doing that, we did this another one. Then we inflate the balloon, pull back, and we have the stem at the level of the neck. Once you have the stem at the level of the neck, you see how is the real diameter. So obviously, it was a completely wrong decision or device selection. After that, we were able to navigate the microcatheter, just keeping another wire inside for not losing the access, and then we telescope a very, in this case, 2 additional flow diverters, and we can recover everything and not only reconstruction. This is a really complex maneuver. I realize that. So I need to hear what is the publication about that, because we publish it in JNIS. In case you want to review, this technique step by step, everything is well explained here. So I recommend you just to read it. Another case, proximal, this is a different kind of analysis. It's a more disgusting proximal, but may happens too. And in this particular case, the device was good, but weakly, so it was really angiogenetic. But we tried to navigate through the stent into an angioplasty, because distally they were more fully open, and with this you push the system inside. So it could be, this is angiogenetic, so we need to do exactly the same maneuver. The problem is here that we couldn't go through like the other case, but the good thing is that we have a lot of space around to do different loops, so we can do one loop. Doing one loop inside, we can do exactly the same maneuvers. This is the material that we use it for navigation. And once we place a distal system distally, sorry, what you can do is open the stent trigger distally, instead of double balloon, as you remember for the other case. In this case, it's an stent trigger. And this is stent trigger doing pull back system, straighten the system, and using the same micro catheter, you may do is placing the flow and later more distal. So this is the case. It was a giant proximal cavernous case, partly from those, as you see here. We select the radial approach, it's already taught to its anatomy here. And this is the 3D test to understand how with the shape of this aneurysm. So we tried to open the device. It was a Clot clonking device, pipeline, the longer length may require more time for the distal opening. So we negotiate well, we open more layers. Here is open, but we still have some stenosis. That's why we try to do angioplasty, and this is what happened after navigation. We push there. So you have now the stent open, but you have the proximal endocardial migrated. And the worst thing here is that we have also some clot here, because it was partially thrombosed. So we try to get the access, and very gently, after several times of moving, is navigated through the clot, very gently. And it was surprisingly for me because it was really soft and stable for navigating. So we did it in 1 or 2 loops, we were inside. Once you arrive and you have the microcatheter in a distal position, then a solitary stent was open in M1 and 2, and then we gel everything back for spreading the system. You see here, and we spread all the system back, and through the maximum we deployed another flow diverter on the final, and then we fully covered all the segment. You see here how is the total reconstruction of this segment. So my recommendation strategy is very driven than so, because obviously this case is happening because of our technique. So this is an illustration to see that we can avoid this type of complications. You use an operative here. This is plastic aneurysm in the supraclavian segment with a very short landing zone here. So if your plan is to place it for that better, in this ACL, it is okay, but you need to realize that you have a high risk of having a distal end proximal migration. So one of the ways to stabilize the device is placing here, for example, in distal N1, or even here, N1 and 2, and then you make up another space for negotiating, so you have a very landing zone. But you still prefer to come here the way it is to run, for example, coils. And this is one of the recommendations that I'm telling you that if you run coils, you are minimizing the risk of migration. This is the case of this view to understand more or less the following. And just to have we place the device, you see here you have this opening of the device on the aneurysm. We place another microcatheter J, and after that we place some coils, and the coils allow to fully open the device and prevent the migration and stabilize. So the coils are not for increasing the occlusion rate, the coils are for stabilizing the device and avoiding immediate or delayed migration. This is a nice example to see. This is a device very short landing zone, but they are fully stable because the coils are keeping the device in place. So it's one of my recommendations to using coils. So technical tips for take from proximal interrogation are more dangerous and should be avoided as much as possible. For bailout, always loops, intramural loops are necessary, so you need to be familiar with this type of maneuver. You need to do how to undo the loop. For undoing the loop, remember you do a double loop or a stent trigger, or a combination of both right now, so you have the two possibilities. And in conclusion, I give this conclusion is better to avoid and solve. Remember that giant aneurysms are challenging and usually associated with atrocity. Tips to avoid migration, select larger devices, anchor very distally, pay attention on sizing. Sizing is very important. Sometimes we are, very fast and try to, select whatever device. Take your time. Do a nice sizing. If you have a free device segment into aneurysms, be cautious when you do an angioplasty or you have some tendency to foreshorten. Remember that coils may prevent the migration. If you are not sure about aneurysm, then telescope a second device. And remember that for diversion and constraint into the aneurysm movement, opens to nominal and prolonged or short term, and then the according head. Okay, so thank you very much. This is all about this talk. I hope you like it. If you have any discussion, please let me know. I will be very happy to talk with you. Thank you very much.
Thanks a lot, Mario, to record this. It's a very nice discussion. I mean, overall, you covered all the technical points. And Vincent, so.
No, thank you, Mario, and hello. The presentation is very nice, and the malignant form resolution is impressive. I was wondering if, before doing the technique with the balloon, if you had tried to remove the stent by using a snare, since the flow diverter is floating, so maybe you have a chance to grab it with a snare before just removing it. And before, did you try?
Good morning. Can you hear me? Yeah?
Yes, we can hear you.
Perfect.
Yeah.
Thank you, Vikul. Thank you, Vincent. Yes, we tried several things. We didn't try, at the end, to put it as a trigger. We didn't, or a snare. We thought about that, but, placing a snare inside the aneurysm could be an option, for sure. It is the first time that I had that complication. Terrible, believe me, it was a nightmare for us. But any option is okay. It's a good suggestion. So whatever you have on shelf to try to remove it or change is good, but we didn't try that in Europe. Maybe next time.
Yeah, no, very interesting. And I love your message, and I think it's a very good message that the anchoring zone, the wider the neck is, the longer it has to be. So it should be as long as the neck. If you have like 10 millimeter neck, you should have 10 millimeter, at least 15 millimeter anchorage. Is the best way to avoid those kind of difficult problem.
I think, yes, the way you mentioned, avoidance is the best. Long device, understanding how it will open in the fusiform aneurysm, great anchoring, having enough device proximity so they have to recross angioplasty stable was absolutely great. But I think once in a while everybody can dislodge one, so I'm really happy you showed the tips and tricks of the trade, how to, if you have ended up a problem, then how to get out of it. And I really want to thank you for it. And now, if everybody's okay, we can go on to your next presentation about, let us say, overlapping devices. So please carry on.
Hello everyone, and welcome to this ANVI Masterclass. Thank you, Dr. Gupta, for your kind invitation. This is my really honor to be here. I'm going to review this specific topic, which is the overlapping flow diverter, the tips and tricks, and this topic will be related to the second talk that will be the next session, which is about flow diversion migration, because at the end they're both related. You don't a good overlapping to become migration, so at the end there are different technical issues to discuss here. So, let me show you my opinion about how to size proximal to distal, distal to proximal. Well, there are different topics to remind and to remember when talking about overlapping flow diverter. Okay, so let's go. Well, overlapping or telescoping, as you may call it, is an underreported and underestimated. Nobody tells us specifically about this. I reviewed all the trials, and there are some technical content, but it's not well estimated. There are some technical nuances because the potential complications are there, and if you don't do the technique properly, you may have problems because at the end, for sure, you will have to telescope for that for different reasons. Where the long segment maybe is fusible giant reason, or tissues, or you need a faster occlusion, or the landing zone is short. There are different, possibilities to telescope the flow diverter. Some minor recommendations, just the distance, because one of the most issues when you place distal approximately the flow diverter. If you don't have the possibility to measure the neck, or you don't have a clear whatever, at least remember, if you see the neck diameter The minimum is to have the same length proximally and distally. So it's a good orientation. If you are starting and you don't know how to size, is that you see the neck here is big enough, at least the minimum is to play distally. If you do that, you are minimizing the possibility to have device migration or problems for needing. So telescoping is an easy technique if you do in a space segment. So if you do in a space segment, it's no problem because it's very easy to navigate with the system and then go through. It's important to don't lose the wire on the first stent. If you lose the wire, you may have problems with this technique. And again, it's recommended to do a space segment, right? Because otherwise you may push and you may for shorten the first device. Another problem is that you do telescoping on the core of the junction, you may have this type of problems with the opening, make the device go open well. So remember, if you telescope here, it's better to do the telescoping much more distal in order to have a better opening of the second device. So remember, straight segment and as much distal as possible if you have this angulation, right, to have this problem. So let's see some practical cases. This is basilar, retrovascular projection aneurysm. We follow up this case because at the beginning in 2013 the patient was non-symptomatic, then becoming symptomatic, so we decided to treat the more conservative at the beginning with a Leo scan, as you can see here, and some coils on the contralateral side before patient would remain stable, but at the end recovered some years later. So we decided to review the whole diverter. So we decided to retry with flow diverters, and we are planning the strategy. It's a long segment, so for sure we need to telescope flow diverter. We need to oversize to minimize the perforator's damage, and in this case, which is very straight because the muscle is straight, could be as possible to do from distal to proximal the conventional way. Minor thing is try to avoid telescopic segment here to minimize the risk of perforator damage, so we telescope from the non-proximal part. Right? So in this case, we navigated first over minor catheter, no problem. We placed in this, it was 2018, and if you remember, it was at the it was a 19mm flow diverter. So after placing the first flow diverter, it was again very distal here for P1B2 segment, and we navigated more proximally. We placed the distal location to have a better stability of the device. Again, the device was oversized. We placed the long flow diverter all over the Leo stent, and just below the perforators, we decided to place the second flow diverter. So it was really easy to re-navigate. Again, it was a free segment, so you see here the area of telescoping, which was short, but again, it was an easy case to see from the distal to proximal conventional approach. This is the follow-up. We see the stability of the device of the clot. For sure, it's a really problematic, vascular, there are really, controls and topics to cover here, but the patient remains stable, even when we realize that the prognosis is poor in this case. Another example to see a fusiform case requiring for the reconstruction. In this case, again, we select to place very distally the device to avoid, the course in order to minimize the risk of migration from distal to proximal with the radial approach. And in this case, we select a Silvista baby, which is a very low profile flow diverter, where you may play the flow diverter through a 17 system. So in this case, telescoping is very easy because right after the deployment, you may not navigate very easily this low profile micro catheter. If you have a bigger micro catheter, you may have problems with navigating the system again. So again, in this situation, we place the second one very distant to ensure the stability, and we place the second from distal to proximal in a very long segment. So again, this is an easy technique because it's a low profile for the diverter, more easily to telescope than the conventional ones. And this is the angiographic result of this fusion case. If you try to telescope in a big aneurysm with a big flow diverter, the 20 centimeter catheter compatible, the short pipeline, you may have this type of problem. So this was a really problematic case. You see the tight articulation of the M1 here, and you can imagine how complex it was to deploy. At the end, we were able to open fully the device for short and for sure, and after that, we need to telescope. So this is the situation. You said the stent and flow diverter distal in M1, and you have the 3 segment here. So really, we tried to navigate the 27 catheter was not possible, so we waited for there. We felt a lot of tension, and then we were able to navigate it and to telescope, but it was not a good technique because this is the ideal segment of telescoping, but we were not able to do this. So if we have this case now, I was able to do a proximal to distal telescoping. And this is an interesting topic, where to do the proximal to distal approach. So this is an example of this classic bifurcation aneurysm. And in this particular case, we did the sizing, this is the Siemens side. You see here how much length do we need for this, and for sure we need to require for using 2 flow diverter. But imagine due to the conventional approach and you place the first flow diverter and this is the proximal. If you have the 3 segment, you may have this type of problems with crossing, and you may have this type of proximal and migration, which is a really potential complication. So in this situation, when you think that you can face in this issue, it's better to place proximally and then distally. So this is a nice way to do that. And this is the technique that we use. We placed in the first flow diverter, and then we navigated the diverter 7, and we placed the second flow diverter and did the full reconstruction with this proximal to distal maneuvers. So we are facing here overlapping telescoping. This seems easy, but potential catastrophic complications are related. You need to know the anatomy, you need to make your plan, know your material that you have on the shelf and the devices, and for sure, good sizing is the best way to avoid unnecessary. And last thought is just to slide is to show my top 10 technical nuances for telescoping. Avoid telescoping in a 3 segment. If it's angulated, it's even worse. Don't use the support of the wire of the first flow diverter. If you have significant angulation, lower the profile of your catheter as possible. Remember, proximal to distal is an option where you are having the risk of using the wire or moving the first flow diverter. If easy to navigate this first segment, then it's okay. Then distal to proximal, the conventional approach is safe. Remember, combined with other stents, it's not necessary to place another flow diverter for different reasons. So you have other possibilities to place the laser cap or even stability or whatever. Regarding the sizing of the second device, remember again, the same or larger than the first flow diverter to avoid having problems. Ideal setting of telescopic at least 50% of the device. The minimum should be 1/3, not less. And my recommendation, give an angioplasty after placing both flow diverter for improving the acquisition, and remember, avoid telescoping over perforators like basilar MO, A1, A2 junction, for minimizing the possibility of having problems. So thank you very much for your time, and if you have any questions, please let me know. Thank you.
Thank you, Mario. Again, a terrific talk. We've covered so many technical aspects, I think. So Vincent, I mean...
No, thank you very much. Very nice topic. And as we discuss with the flow diverter now being available in much longer lengths, maybe we have less need to telescope, but we still need to telescope. Yesterday we did a workshop with all the Indian teams, and there was a huge, massive aneurysms to be treated, and even with the 5x40, you needed to have 2 stents to cover it, so it's still something we need to master despite the longer length of a diverter. And I would say that the proximal to distal for me is the way to go as soon as you can do it, because you do not take the risk of losing the lumen of the first stent. So it's bringing to you a level of safety, reproducibility that you may not have from distal to proximal. The only reason to make distal to proximal is if we're doing from proximal to distal, it will undermine your capability to finding the outlet of the aneurysms. But if it's not, I mean, the level of safety, you just put one flow diverter with a nice anchoring, and again, you underline very well the need for perfectly anchoring the stent when you are doing telescopic, because you have to re-enter, you have to do some massage. So, no, I love the idea you have underlined for us, and maybe it's just a question for you. If you have to select now a technique, proximal to distal and distal to proximal, and the two looks okay, what would be your choice, Mario, now, since you have demonstrated all those experiences?
I think that you point perfectly. So it depends if you are able to catheterize the distal part of the artery. If it's easy or it's doable, then proximal to distal is a fantastic option that you mentioned. The problem is you place the proximal flow diverter and then you are not able to find the way. But at the end, you have different options for solving. So if you predict that you're going to need a bronchoscopy, I would select probably proximal to distal, but it's really complicated. And in terms of the indication, for sure we have no flow diverter, but there are many hospitals that they have some flow diverters on the cell, but they cannot select the nerve because they don't have it in the hospital at the time. So I think that we all need to be familiar with this technique, even though we have very no flow diverters in the market.
Great. I think, Mario, you really covered all the technical aspects and the nuances. And as Vincent mentioned yesterday, sir, in the slides training, we made our all the fellows practice the overlapping flow diverters, and your talks has sort of complemented it beautifully. And really thank you. Record all these videos, be available. You were waiting for a while, and maybe next time when we do, we'd like to have you here in person. It'll be so great to have you here. And thanks a lot for all the effort. I think let's give him a nice hand, Mario. All right. All right. See you soon. Yeah. Great. Thanks a lot. Okay. So now, I know it's almost lunch session, but we have one more talk, and Dr. Manmohan Singh is here. I just told you he's my old colleague from AIIMS time, neurosurgeon, and he was professor of neurosurgery at AIIMS, and then just some time back he joined PARA. So I thought, you see, even flow diverters are not easy, overlapping, displacements and everything. So as I said, always have neurosurgical backing. And I do send even now many cases for opinion for bypass. Only thing you have to know which surgeon can do the bypass. And you should have a surgeon who is willing to do bypasses. And even if patient doesn't get it done, they come back, patient has an opinion. It's very important to have neurosurgeon in loop. In such cases, it gives us confidence even if they don't get bypasses, and you should have somebody. So just to give you a glimpse of how they're doing bypasses and safely how can be done, I really wanted Manmohan Singh to talk about it. Yeah. Thank you.
Hello. Thank you, Vipul, and good afternoon, everybody here. So I'll be talking about the high flow bypass in complex aneurysms. So this is still a requirement in the field of neurovascular surgery. And the indication for cranial vascular bypass, we all know that it has become definitely uncommon because especially the high flow bypass. And there are a fair number of situations where the high flow bypass is still needed. Let's see that which conditions are there. And the indications are that giant unclippable aneurysms with poor or no crossflow, and there sometimes that extensive skull-based tumors where we have to excise the vessels in situ and do the bypass. And a low flow bypass is required if a patient tolerates the balloon test occlusion but fails the hypotensive challenge. And the high flow bypass is required if the patient experiences deficits at normotensive phase of balloon test occlusion. Then how do we select that bypass selection? Either it is the radial artery or the saphenous vein. The average patency rate at the 5 year of the radial artery is around 90% versus saphenous vein for around 80%. The radial artery graft, what are the dynamics of that? It is definitely a little smaller, like 2.5 to 3 millimeter, with a blood flow rate of around 40 to 150 cc per minute. And it is definitely a bypass graft for choice because it matches the lumens of M2 and the P2 intracranially. But it has definitely got a bypass a disadvantage, which I'll show in one of my video also. It undergoes a lot of vasospasm. And it is usually managed by the saline distension, and that it has to be kept soaked in calcium channel blocking solutions. The saphenous graft is also not a bad option, and it has got around 5 millimeter of diameter with blood flow rate of 70 to 200 cc per minute. Easy to harvest, and there is no athromatous change, and it has definitely a wider caliber. And disadvantages include that caliber mismatch because it is definitely a bigger vessel and we have to reverse the graft because it has got a valve, and that distal end of the saphenous vein goes intracranially and the proximal goes in that neck. And it is also prone for kinking and a little more risk of thrombosis as compared to the radial artery. And this is a case of less giant aneurysm and which had the progressive blindness and a young girl, 21-year-old. And at that time it's an old video and the patient couldn't afford this stent and this flow diverter, and this patient was subjected for bypass surgery. And we opted for radial artery graft, which are, and it end to side EC and M3S anastomosis was done. And this is a video. And I do that bypass while passing the graft from the middle cranial fossa medial to the mandibular ramus to the neck. So it shortens the distance and the graft is absolutely straight from the neck to the intracranial compartment, and the dynamics of the flow are definitely better. There are no kinks even for that saphenous vein. So this is a chest tube is actually being passed as a conduit from neck toward the intracranial compartment, and through this chest tube we'll pass the radial artery graft. And this is the Sylvian Fisher dissection. And to prepare that recipient vessel. Now you see that this is a radial artery. It is very, very elastic. The moment you stretch, it goes to that the site of that recipient side, and it immediately retracts back. So to tackle that, we have to take these adventitial sutures to that soft tissue at the neck so that you can pull it down. So no doubt the radial artery has a very decent length, but sometimes it has got a different problem because of its contractility. It is dilated and then subsequently it actually yielded. And after that, we just did the arteriotomy in that external carotid artery. And with the 8-0 proline, the sutures are being done, all interrupted. So this first that the proximal anastomosis is being done. And once this anastomosis is complete, so then you just put a clamp on, that is the temporary aneurysm clip on the graft, and first release the distal clip and then the proximal clip so that the flow is restored to the external carotid system also. So now the intracranial compartment, now again you see that you pull the vessel, it comes, it is lengthened significantly, but at the same time it goes back. This is elasticity, and sometimes it is a great problem. So then we have to just stitch it back onto the dura and then in the pile surface also, so that it remains in place. So this was a very, very tricky situation in this particular day, and that is usually not the issue, but sometimes it can have a problem. So again that pile sutures so that the radial artery stays in place. And once it is there, then it will stay back there. So now this arteriotomy to the M2 segment of middle cellular artery, and with the help of 10-0 sutures, that is a nylon suture, then anastomosis is completed, the M2 radial artery bypass graft, the all interrupted sutures. And once this bypass is completed, then the distal clamp and then the proximal clamp. So this is completed. But at the same time, you can see here there is some bleeding. This was basically a branch hole of that radial artery graft, so which was actually closed with another suture with a 10-0. So sometimes this is also a problem because the radial artery branch hole sometimes can bleed. So again after that all the sites were closed. So that first the distal and the proximal. Now that neck clamp has also been taken off. Now this is very well pulsating. Now this is that ICG is done. So to see that the patency of the graft at the end of the surgery, it is very well filling. And this is the cranial side, this is the graft, these are the MCA branches. And now we will go back to the neck side also to see that everything is filling from the neck also. This is that neck side, this is the ECA, and this is that radial artery bypass. So after that, that aneurysm is actually trapped. These are the permanent clips. For the neck, we have just ligated the internal carotid artery, and these are the aneurysm clips at just proximal to the ICA bifurcation. Okay. Sorry. So another case is that I want to show that this is giant M1 segment aneurysm, and she was a 22-year-old female patient who presented with the recurrent history of transient ischemic attacks and had also repeated episodes of headache also. And this is the CT scan, which shows that is a giant aneurysm which has the calcified wall at places, and it is brilliantly enhancing on contrast, mean that there is hardly any evidence of an intraluminal thrombosis. So in this case, you can see that this is angiogram, and it is filling from internal carotid artery, and there is a very good cross flow from the opposite side also. So radial artery ECA MCA bypass was done in this patient, and that was not a big issue, just like the previous scan video I have shown that it is done. But at the end of surgery, what I had a problem that I could not reach the proximal end of that aneurysm. There was hardly any space available. This is such a big aneurysm, the wall was calcified. I couldn't see where actually the ICA is there, where is the ICA bifurcation, even A1 was not visible. So nothing could have been done at that point in time, because I couldn't then close this ICA also at that. So I just did the bypass and came out. And next day I asked my colleague to do an angiogram that sees what is happening there. So we are not cross-clamped the ICA, at the same time we are not isolated the aneurysm. So angiogram was done, and it was very well filling from that whole of the radial artery graft is filling, and the aneurysm is also filling from that internal carotid ICA injection. So then I asked him to do that, please the test, that balloon occlusion test from the ICA. Once he did that, aneurysm stopped filling, because that radial artery graft has taken over, and there is hardly any filling to that aneurysm from ipsilateral ICA. So that after that, the ICA was ligated. And the patient didn't have any problem, and subsequently the patient was kept from follow-up, but from the opposite side, there was some filling. After 6 months of time, everything disappeared, and that this radial artery bypass graft has taken over. So sometimes these are the tricky situations where that intervention is also not going to help these patients. So bypass graft is always a savior in those situations, and I can tell you that this can save life, and definitely it is a tricky and little challenging surgery for all neurosurgeons, but it is possible and it is doable and should always be learned, and because in many situations this is the way you can get away from a problem where the endovascular procedures are not possible. So just by concluding here that all neurovascular surgeons should be familiar with the high flow bypass. A well done bypass has a decent longevity and a very good long term outcome, and high flow bypass comes for rescue where that endovascular procedures sometimes fail. Thank you. Questions are welcome.
Thanks a lot, Manmohan. It's really, really great to have a good neurosurgeon, vascular surgeon backing you up. And as you showed, high flow bypass particularly I've done many check angios with them. It's a great technique, and it's great to have him here as a backup. So as I said, even if treating giant aneurysm, you should know in your area someone who can do bypass surgery and send cases. If nothing else, patients don't complain. Even if they don't get it done, you have taken an opinion, you'll be more peaceful, patient family is more peaceful, they have explored all the options. So as I said, all of us should know one bypass surgeon, and only challenge is we should give them enough cases to have their skill going. And Vincent, any comments on this case?
No, impressive. I was impressed by the angiogram, because the bypass I've seen, sometimes the reflow into the MCA is weak, and here it looks like a normal angiogram for the distal MCA. My question is, the fact that you are using the radial artery, if I understand, is improving the flow compared to someone that is connecting the temporal artery to the MCA. It is far better in terms of flow. Did I understand well?
You are saying that temporal artery to?
It was a radial graft,
yes,
that you have connected at the neck.
ECA, external carotid artery to middle cerebral artery.
Yes, and some people, they are using just a big temporal artery to
connect here.
Exactly.
So
that is the low flow bypass.
that is a
temporal
low
artery.
flow bypass.
Yes.
Okay, high flow is when you have the radial, because the angiogram, it's amazing, is far better than what I've seen previously.
True, because the superficial temporal artery is a low flow bypass, because if in such giant aneurysm, if you are diverting from superficial temporal artery to middle cerebral artery, the flow is inadequate if you are going to clamp that vessel. So that requires a high flow bypass, because low flow bypass is indicated especially in today's scenario for the moya disease. So because that you just have to augment a little bit of flow, so that over a period of time, the STA, the superficial temporal artery, takes over. So the indications of high flow bypass definitely are less, but it is required, especially in MCA aneurysms, where that sometimes that endovascular procedure may fail, or sometimes in the PCA also, posterior circulation, where you may have to go ahead with that high flow bypass. So otherwise, in the low flow bypass is indicated chronic occlusive diseases, not in acute setting. So like sometimes maybe arthromatous diseases with the moya formations, or moya disease in particular in kids. So that is requirement.
Great. So thanks a lot, Manmohan, and we had kept you waiting for a while. It's not easy to get neurosurgeons out in afternoon. He's a very busy person, so let's give him a nice hand. Bypass surgery is not an easy skill, so we have to respect neurosurgeons because their skill is so challenging and they work very hard at it to get it. I think our learning curve is shorter, and to become a good bypass surgeon is a very big challenge. It takes long time and dedication to do it. So I always feel we should have neurosurgeon around us backing, and we should respect them and collaborate with them, and not have this, okay, I want to do this. No. When you send it to them and patient come back also, is fine. And if they don't get it, they get a bypass, then it's fine. So one should be open to taking neurosurgical opinions in all our cases. So now we'll break for lunch. I know there's some sessions pending, but I think we'll do them post-lunch. But we are sort of shortening the lunch by 10 minutes. So we start, now it's mainly video case studies of flow diverters about blisters and tricky cases. So since we have only one day, we can all squeeze our lunch in the next half an hour. 2:15 we start and sharp at 2:15 post-lunch. All right. Thank you. And thanks a lot for Vincent to staying on the chair for so long. He's a great person to have in the meeting. Thank you. And Raj, okay, Raj, you are here. All right, so, okay, yeah, I know we had a pretty short lunch break, but we have a pretty longish program to cover. So we'll start this session, and so now I think because we jumped a few talks, we'll go back to them. I think the next presentation is from my department, and we're talking about some basic videos, how we treat the blister aneurysms in our unit. Okay. And of course, and the person chairing this session is no other than Dr. Uday Limay. So let me tell you, when I was in AIMS and our department wasn't so active, and Uday was leading the KM, there are 3 terrific guys. So he inspired a whole lot of neurointerventional generation. So seeing them, I can remember I had a fight with NK Mishra actually. Look at them. So that's how they work. They do all of this, and we are not doing anything. So they changed the attitude of a whole generation of neurointerventionists to go out and do it and make things happen, and their meetings. I still remember Lonavala attending this complication meeting he started off. So as I say, he's been a huge influence in neurointervention field, and a whole generation, even people, I may not be that young, but he was an inspiration and to follow and to be very active and aggressive in this field. So let's give a huge hand to Uday, All right, so just to show, blister aneurysms, there was an era when I should treat them with stent-assisted coiling, and which was a big trouble, and I published my outcomes as well. And then we started using flow diverters in these patients. So I just want to take you through maybe 1 or 2 videos of how I do it. But to me, the technique remains very, very important in this patient as to from where. So this is the classical blister aneurysm, right? So you can see it is from the superomedial wall of the ICA. The ICA is slightly swollen up. It's not from choroidal or PCOM. When we see any aneurysm there, we know. So we like to do simple FD. Some people internationally do double FD as well. And some people like to place coil. But we have realized now a single flow diverter done well works well in most situations like this. So how do we plan the antiplatelets here? All right. So what we do in our department is, we use double antiplatelets, and usually we just load them before we shift the patient. Our logic being in 2 hours will have effect, so by the time patient comes in, we give anesthesia. These are very straightforward to cross and deploy the FD. Oh, Rajiv is also here. Rajiv, can you join us as one of the chairpersons, please? So Rajiv Jha is here, one of the senior neurosurgeon in Nepal, but again, one of those neurosurgeons who has been encouraging and mentoring neurointerventionist, and is a great friend of the country and my personal friend. Okay, so what we do is we load them just before, and then we go ahead with it. And Tufail, in your department, do you do a preloading or you use injectable for blister aneurysms? How do you handle them?
For blister, I usually give prasugrel 2 hours before the procedure, and usually 30 milligrams is enough. I don't give 60. And then on table, I will give IV aspirin just before the stent is deployed. And that has been my protocol for years now.
Okay. So ours is the same, except that we don't have IV aspirin. We load with oral aspirin, and I've been using 50 milligram Pasul, but we don't have testing available. But yes, we have seen some cases of bruising, then we decrease the dose, but we haven't had any bleeding complications,
So IV aspirin has become very difficult to get now, even in UK. So people are doing either put a nasogastric tube or they're giving per rectal.
All right. So anyway, this is the angiogram, again showing the classical blister aneurysm there. And this topic we were discussing in slice training, from where to place the flow diverter. Do you place it only in the ICA, you develop from the MCA? So my philosophy has been, we always do from MCA. If you really want to compact the flow diverter, I want it well opposed, we always start from ICA, use a lot of force. So distal access is very important. This patient has a huge loop. We use seri-base so that we can take even this loop. And we're taking a microcatheter, over that a 4/4 DAC, and over that a Navian. All right, so we use this coaxial, triaxial techniques a lot so that we get a very stable base there, because flow diverter needs a lot of force to open up. And as I said, where to deploy? We deploy from MC. We deploy from here. Sometimes the opposition may not be good. We have endo leaks. This patient also had some aneurysmal changes here, so we use the longest flow diverter to deploy up to this segment. Otherwise, usually we'll end it just before the ophthalmic, but this was an exceptional case with, as you see, there's another aneurysmal dilatation here. So we covered that area. Now sizing becomes challenge here because see the artery is really expanding. You use a large flow diverter, we'll have a problem. So what we decided to use a 4.5, and our attempt was to finish before that dilatation in the cavernous. As I said, they're easy to cross, and we use this, and you can see over this microcatheter we've taken the guiding up. Once you're deployed to this degree, this is where we tend to compact them, all right? And when you're pushing the flow diverter to compact them, somebody should be pushing in the guiding as well. See, now we have withdrawn a bit as Matthew showed, and then we push it hard, and you see how it has expanded here. In the other angle also, you can same thing. We withdraw the microcatheter and we push it very hard, and somebody should be pushing in the guiding at the same time for it to really work. And we try to get even a dark line here, expanded as much as possible in the region of the blister. Again, another of those procedures. So we have really compacted here, expanded here. Now we can see we take an angiogram, good wall of position. And maybe because we manipulated excessively, you can see it was not opening up in this area. And I tried a few times. I think we resheathed it once, as Dr. Matthew showed in morning. We deployed a bit more, kept manipulating, and then we could open it. As I said, we don't like to rely on balloon in the end. You manipulate that time to get it open as much as possible. And again, we have compacted it, so we know we have opposed it well, and then we finish the deployment. You can see it's not well open here. It's not a major AVRE. We always withdraw the micro and the wire, and you can see it snapped open there, and then you use a microcatheter massage, and you can see we sort of shorten the flow diverter here, so as to bumped the microcatheter engaged the wall of the flow diverter. But I wasn't happy about this area. So yes, once you're not happy, it's acute. We did angioplasty as well. You can see some slowing of flow, but I've seen once it's a well deployed flow diverter, usually, and there is not much of a problem, patients tend to do well. And one thing which I missed, if you can see, there was already a drain placed in this patient. She had mild dilatation, so whenever we have a worry like that, we get a drain placed. It may be EVD. Even if we don't want to drain, we get a Omaya placed. Omaya is something when they place the tube in and there's a sac below the skin, so we can drain it any point of time. What we usually do is we start early morning. We'll tell our neurosurgeons to place a drain at 6. Okay? We wait for 2 to 3 hours, get a CT scan done. If there is no bleed, drain is in right place and everything, then only we load the patient and we give anesthesia and go ahead with the procedure. So that's a protocol we follow. It has to be coordinated with neurosurgeon, so that in one anesthesia we do the whole thing, and it's very gratifying in this patient, a situation which was very tricky to handle in the past. And as I mentioned, one flow diverter deployed well usually is a great technique to handle these patients. But to me, why we wanted to show was plan for a drain beforehand if you have to. Number 2, antiplatelet regime should be very, very clear as to what you are going to use. And 1 second, let me just stop this. 1 second. We'll just tell you how to play the next one. And number 3, have a very stable guiding catheter, because if you do a lot of force to open up the flow diverter, your guiding catheter has to be stable. It should not be coming down. And even when we are sort of using force to open the flow diverter, somebody is pushing in the guiding catheter. That's the only way to happen. And if, as I showed you, sometimes it is twisted a bit, not opening, resheath, redeploy, do all your manipulations. And the lower end of the flow diverter, microcatheter bumping, is a great technique to get it settled down. And if need be in the end, yes, use a balloon. But as I said, most of the cases, just like Matthew, if you deploy it well, then doesn't need to use a balloon in the end. We just show in short another case of blister aneurysm. This patient was actually a MBBS student, and so you can see the artery was kind of dilated here. In other angle, we can see the classical blister aneurysm. Of course, in this case, as I said, usually we like to finish around ophthalmic or just proximal to ophthalmic. That is what we plan. We always like to take a guiding high up so that there is no issue in taking the flow diverter. And so we start deploying from MCA. That is our protocol in all our cases, because that's the only way we feel we can really get greater position in the region of the aneurysm. Again, you can see you want to create a dark line here. Again, the same thing. Guiding is high up, and you use a lot of force. You want a dark line here in the region of the blister if possible. So we do all our manipulations. So you can see I love this dark line. I know that in this region I've really sort of compacted the flow diverter a bit. And once you deliver the lower end, very frequently this is a pipeline device, it doesn't open, then you can use microcatheter to open up. It's usually not a major issue. So lower end you deploy with some force, and you can see it's not well open. Again, you use microcatheter and manipulate the microcatheter to and fro like this, as Matthew also mentioned, to open it up. With the wire, microcatheter goes into the aneurysm, but then you can take a traxus wire and then use the edge of the microcatheter to bump it a little bit more. So we love to do this massage and manipulations and to get it right in the end. And this was the end result in this patient. Again, you can see slightly overexpanded but very compressed flow diverter in the region of the blister aneurysm. And what we realize in most of these cases, one single device is a vaso-CT, not a great image. For vasospasm, we had to do an angiogram after a week. We don't usually do early angiogram, and the aneurysm was all gone. And in our experience, yes, we do cover the anterior cerebral artery in these patients, but usually there is ACOM, and to me, a bleeding complication kills a patient. So, but you have to cover it, and usually since slightly oversized flow diverter ACs remain patent, or they get taken over by ACOM. Initially, it was a worry for us because in subarachnoid hemorrhage, their vasospasm can also come in, but somehow we have realized it has worked well, and we don't get too many ischemic complications in these patients. So, this is how is my department's technique in handling blister aneurysm. So, we can have some comments. Somebody would like to use 2 flow diverters. Does somebody use coils with the flow diverters? Anything different one would like to do? Yeah, Tufel.
So, if it's a blister aneurysm,
yeah,
I usually, if I can, I try to get a coil, and sometimes it's impossible. But if I can't get a coil in ICA, there's no, for me, I will always put another flow diverter in. And I can show you a case where you have not done also, when I haven't done it, I had a rebleed. Okay, and I can show you a couple of cases like that, where you have put only one flow diverter, blister aneurysm, and bled 3 months down the line too. So single flow diverter, I think it is not necessarily absolutely protection. You may be protected, but you still have a risk. So where cost is not an issue, I just put 2 flow diverters. If it's a blister without coil, if I get a coil, then I'm much more comfortable putting 1 flow diverter.
Okay, so I used to do stent-associated coiling, but I mean, and we've done quite a few of them, but you know, trapping a microcatheter in the small ones, placing a coil. Of
course.
So, and that is why I wanted to bring this up to discussion. What we realized, a single flow diverter really works well in our hands. When it's a biggish aneurysm at times, then I do place coils. You know, I either with a balloon or just trapping a micro with the flow diverter, we place a few coils. We have had one case of rebleed, and that was the case I used nitinol-based flow diverter. So, and usually I use cobalt chromium-based. Pipeline has been a favorite in this particular situation. So maybe I became superstitious. All of them work very well. I've just come back and I don't use nitinol-based in these acute SCH in these blister cases. But I don't know, maybe all flow diverters work the same.
If you put a 1 flow diverter in a blister aneurysm and it's okay, but I don't think you can call it completely protected, because you will have patients with a single, they are on double antiplatelets, you got a single flow diverter. In fact, if you don't see filling of the aneurysm, still not protected, because these blister aneurysm is a disease of the wall. And I have seen cases where there was no filling of the aneurysm at all. Nothing. You had 1 stent, didn't fill, there was stasis at the end, and patient rebled. So if you look at the literature also, it's very difficult area, but it's not a surgical target. and it's purely endovascular because surgeons would wrap it, and you can correct me if the surgeons are here, but I am not convinced that one flow diverter makes the difference, so I always will put a second flow diverter.
Yeah, Vincent.
I'm doing exactly like Vipul. I think the very important message you gave us is, if you want to do such a case, first you need to check if the patient will need or anticipate the need of a ventricular shunt, and to make the ventricular shunt being placed by the neurosurgical team before you load the patient. The literature, the data report up to 24% of bleeding placing a ventricular shunt and double antiplatelet therapy, whereas you have only less than 9% of hemorrhagic if you do it before and after you load the patient. So this is, we don't have data for 1 or 2 flow diverter because we don't have the answer. I put only one, and I have to say we're happy about that. In the literature, flow diverter in the hemorrhagic situation, rebleeding rate in the first 2 weeks is 4% in the literature. So there is rebleeding after flow diverter at the hemorrhagic and during the acute phase, but I think it does not justify 2 layers systematically, because you increase also the thrombogenicity of the procedure, and you don't. So that's also something we should consider as well.
I agree. None of us have done, at least I haven't done 100, maybe I've done 40, 50 of blisters overall by now in all those years, and we have had one bleed. So one would say, yeah, maybe we also have 2 to 4% rebleed rate, but whether it's a belief that using a lot of force to compact it and get great opposition really helps in getting away with one flow diverter, but again, I don't know, and Tufel is right. Maybe in next patient I have a rebleed, I will change my protocol.
Yeah, Dr. Tufel, just one more clarification. Like the coiling, the blister aneurysm, because this is not a secular aneurysm, and most of the time it is small. Yeah. With your expert hands, yes, you can put coil safely, but putting in a coil in a blister, the intra-procedural rupture risk is too much.
No, I totally get that, and I think that's why you have to be very confident and safe, and if you are not happy or not comfortable, then I think you should not attempt it at all. I totally agree, and in fact, because I have seen rebleeds from blister, and I do a lot of medical legal work and a lot of expert, I work in a litigious world, and we were talking about it, the lawyers are always after us, okay, in UK. So you have to be so careful. And whereas it's different in different countries, but in UK...
In our country, families go after us, which can be
yeah, but
worse.
families here will probably just beat you up, but if they beat you up, you can take some beating and then you're okay. But when they sue you for £1 million, then you can be in trouble.
Let's ask Uday, just a comment. 1 FD, 2 FD, FD with coils. What's your first choice?
Yeah, good you asked. Never go with the idea that I'm going to put 1 flow diverter or 2 or 3. So always look for the morphological change in the aneurysm. Stasis, non-filling, flattening, there has to be a definite morphological change which we watch for. If there is no morphological change, then the aneurysm will bleed. And I've seen a few. And so that is the one thing which we absolutely watch, 1 flow diverter exactly like you do. But there has to be morphological change in the aneurysm. And the last thing is, before discharging the patient, we always do a DSA.
I think that's also some good idea.
I wanted to make that point, although that's a good point.
Any chance you see too much filling, growing, these aneurysms can change very quickly. It's a very good idea it sort of settles one's heart that, okay, most likely things will remain fine. This is a very tricky disorder. In era of FD, it becomes so much more easier to handle than the past what we were doing. 1 stent, 2 stents, coils, this, that, recurrence and all of that. But I wanted you to know that there are different protocols, and we have our protocol. As long as well open, small aneurysms flow change, even when there is a hemodynamic change, we may not see it angiographically. That's how the physics. So I would love to see that. Even if I don't see that, if my flow diverter is well opposed and everything, we are okay with it. That's what we have been doing, but as I said, nobody has 100, 200 cases data to say that your protocol is the best. And so we can let it lie here, and all of you have heard different opinions. You have to form a protocol and sort of see how it works for you.
But the important thing is follow up what Uday said, and you're saying, but we also have a protocol. Usually if I have a blister aneurysm and I put two flow diverters or flow diverter with a coil, I usually do an angio or a CTA at 24 hours. Usually then I have another one at a week. Then I usually do one at a discharge, and then I do one at 3 months. So that's our protocol. And because we are very aggressive in making sure, because you can rebleed. I can show you cases where patients have come for a follow-up at 3 months, and I have a patient who came for a follow-up at 3 months and bled in the MR. So these things happen. So I think we have there is a policy across UK to follow them up very rigorously.
All right. Great. I mean, Vincent.
There's just one point, because we don't see the disease and we are only looking at the luminogram, the trap could be to underestimate the length of the disease, meaning that you want to stent and to cover with the flow diverter, and you are too short. So when you are doing with the flow diverter, also it's very important to cover very largely from the M1 to the carotid, because we saw a case where we thought it was cured, but the dissection just progressed distally to the lesion. So, and because we're working on luminogram today and not with the intravascular understanding of the whole disease, it's very important to be sure that you're covering the entire disease.
Absolutely agree, and we don't mind as long as, if in doubt, please use a longer flow diverter, number one. Number two, in these cases, since we compact a lot, we lose the length. So we don't care, let it come back, even overlaps ophthalmic is fine, but you have to get a great wall of position, particularly in acute stage, and you're going to play in a CSF drain in these patients. And as Tufel laid out, I mean, one can have mishaps, whatever protocol you have is a deadly disease, and one can still have mishaps. And so, I mean, as I said, maybe we don't have the perfect answer, but these are the various approaches, and that has been our approach till this moment. As I said, tomorrow one case rebleeds after a perfectly done, maybe I'll change my protocol and start following something else. That happens all the while. We can never be dogmatic that whatever I do is fine. So, okay, so we'll go on to the next session. I mean, so we are doing some unusual situations, so which will be now, we're talking about distal aneurysms here, when you do deconstruction, when you do reconstruction. So let's go through this patient. This 55-year-old male with ventricular hemorrhage. Again, you like to have a drain hand. This is the kind of aneurysm. This is the pica, right? Pica is whole irregular, and this kind of aneurysm is there. So it's a big question now what to do with this artery. I think there was a mistake in the age. This patient was around 25, 30. I remember this very well. So what will be our approach? Deconstruction or reconstruct? And if you want to reconstruct, how do we do it? I mean, Uday, how would you?
Can you show the pictures again?
Yeah, let me go back.
Yeah, let the picture be on the screen.
Yeah. This is a big pica. You can see a lot of branches coming out of it.
Ruptured.
And ruptured, acutely ruptured, fourth ventricular bleed. We got a drain in, yes, but what to do?
So as always, you know our opinion. As always, reconstructive or making patency of the artery is supposedly safer. Supposedly no one wants to occlude. But a deconstructive technique is not just sexy, it is actually very effective.
Yeah.
And so distal picas, they will have on the surface of the cerebellum, they'll have collaterals from the scar.
Of course. So that is very important. Distal picas, we have done a lot of occlusions. We do few reconstructions. Acutely ruptured distal pica, and usually they do very well with parent vessel occlusion. We don't even do testing. We just go ahead and occlude those artery. But this was slightly proximal. This is where perforatus can be there and everything there. So.
But if you can always inflate a balloon and actually do a BTO.
Hint, we are in a flow diverter session.
Dr. Vipul, the proximal artery is also not healthy.
Yeah.
From the origin to the...
It's irregular all over. So point is, even if you occlude here, is it patient really safe? This was very irregular artery.
This is irregular artery.
Yeah. So let me carry on. Of course, there are no simple answers. So we decided to, and this was a big pipe, a lot of branches, young patient. So we decided that we'll go ahead with the reconstruction attempt in this patient. The biggest challenge was how to cross this aneurysm. It wasn't so easy. And I absolutely believe in very, very distal. We access again, as I said, we get EVD or Maya done. I really love distal access. Yet saying battery is running low. Excuse me? Battery. All right. So we'll keep all these wires. Sometimes I even like to cross them with a hybrid wire. Once you get a micro across is fine. This is super curved synchro. We love synchro. We'll give it like a tight pigtail shape. But this took long time. I kept struggling. And I thought whether I'm going to end up rupturing while struggling. You took an angio. Then I placed a balloon in the vertebral so that I can control the bleeding if need be. If need be, bleeding happens. And then with super curved, somehow we were able to cross it. And in the other plane, it was very useful to see that the wire is going around. You give it a torque, slight pressure, give it a torque, and slowly it may travel distally. So this was a lot of trouble, many wires wasted before we really managed to do it. You can see how crumpled the wire is because we get a very, very tight pigtail, as tight a loop as we could, and that only helped us to cross the lesion. Now the straighter part of the wire comes in. You can see we just torquing it and slight pressure keeps going in, and then we were able to navigate a headway catheter into the aneurysm. Now also when you're doing FD in such, you want to worry about the distal, and you see the whole artery position will change once you place the microcatheter. That's a Vista baby. Whole artery straightened off, but we know it will reform when you deploy the fluid force. It reform into its original configuration. The challenge here was to get it right absolutely to the edge of the artery because the artery looked diseased. But when we tried to deploy with force, it hyper-expanded in this area of the aneurysm. At a turn, we had to use some force, and as soon as we use the force, it will bulge into the aneurysm like this. I wasn't comfortable with this. It was sort of bulging into the aneurysm too much to my comfort. So we decided we'll resheath and deploy with slightly less force and see how it goes. So we resheathed it, and as I said, we kept a balloon there. You needed to support microcatheter, number one, and number two in case of any bleeding. So that's a hyperglide which is there in the vertebral. Now less force, even then it was bulging a bit, and I realized I have no choice. And we realized maybe we'll end it at the time you took an angiogram to know where you will end. And we decided to complete the deployment right at the origin of the pica. And you can see slight fish mouthing of the tip of the flow diverter. Use this gentle massage, use this up and down movement to sort of snap it open with the wire and microcatheter, some gentle massage of the microcatheter tip. We didn't want to push too much, and then it's okay, it settled down, and we were pretty happy with it. We felt there was some clotting happening here. I placed micro, gave a little bit of injectable interpolated agent. We watched it for a while, and thankfully this patient did well. This is CT scan on the table to look at the device configuration. Maybe the proximal is not perfect, but we were sort of okay with it. And I think we have a check angiogram of this patient as well. I think this is, during the stay, we did a check angiogram. Like sometimes we do in ruptured aneurysm, what's really happening is an early check angiogram. And then I think we have a delayed check angiogram. So whenever we extubate such patient, we tell them to keep, this is delayed angiogram. So this stenosis in the artery, but it remained patent and patient remained fine. And ultimately he has done well. So we can, anything we could have done differently.
Can you show us the angiogram with the stenosis?
The last one?
Yes, just to understand what happened.
I don't have better.
Where is the stent here?
So stent is here, up to here, I think up to here. And there's a lot of instant stenosis. The artery has become smaller as well overall.
So my understanding is probably there was a collaterality, do you think?
Yeah.
I mean, I would have been really afraid to occlude this artery as well, but I see that probably it could have been done, but I would have been conservative as well, but probably yes. You see, it was an ICA, as I understand.
Yeah. ICA was very small. It was a huge artery.
ICA and pica artery, so very huge artery.
And the problem was, it was all diseased till the proximal. So if you have to, don't do a focal occlusion, you can't coil the whole artery.
Yes, it was too proximal.
Young man,
very
55,
interesting.
it was like mid-20s, 30s.
Very nice case, huh?
But Just want to show how synchro can really help at times. We love synchro while we give it a super duper curve as much as we can make it into a pigtail. And then somehow it talks well and slowly, but it was quite like a treadmill test to cross that aneurysm. So that's why in between the case we prepared a balloon and placed it. Worst come worst, we rupture, we inflate the balloon and close the artery and get out of it. Yeah, Tufail.
Well, I know you always talk about being very conservative and safe, but I think in this case, all the manipulations were quite risky, good in your hands. Probably I probably would have tried the same maybe, but I think when it was going like that, you need to still consider parent vessel occlusion. It's probably the easiest and the safest technique. Just close that, and you're not doing any manipulation. I don't know whether you have a long-term follow-up on this. Sometimes you put these small stents in these distal vessels, you follow them up, and they are occluded. So you get a very expensive occlusion. So
you're absolutely right. We have also some small stent occlusions. You are absolutely right. And it's a little uncomfortable at times. You place them perfectly and they occlude, particularly in acute SS situation. You are absolutely right. We have seen that as well. Number one. Now, only worry in this case was a big big pica, and the whole artery was diseased. So I was worried about perfect occlusion. But yes, 80 to 90% of distal pica aneurysms, we still do PVO. Maybe we should have started with the PVO case. I don't want to send a wrong message that all these cases we try to reconstruct. No. This was proximal, and I thought I had to coil till the origin of the pica because the whole artery was diseased, and I was very uncomfortable about that part. And we started this case with this, okay, we'll try this. It doesn't work out, we do PVO and come out and everything. But yes, it was very tricky. It was very challenging. I absolutely agree. And acute SCH with time, when the 70 micro fluid diverters came in, we were very enthusiastic, but we have seen acute and chronic occlusions both, particularly in acute SS situations. So with time, I have become a little tentative that even if you deploy the device well, outcome may not be great.
I think one of the things is when this artery moves.
Yeah.
Okay, and when you move, you can pretty much share the artery at the origin too, because I have very recently done exactly what you are doing. I got carried away, tried to reach, and as I managed to reach distally, I had one of my fellows with me, and he said, oh, it looks okay, but I saw the shift of the artery. The artery, the whole curve had gone suddenly, and anesthetist said nothing. And I said, I think I've ruptured this.
So,
and it had ruptured.
We'll quickly show one more flow diverter. What you mentioned is absolutely right about artery moving, and it really frightens me to use this thicker regular wires. So quickly go over. This is a 54-year-old female. I think she was a doctor herself. Again, as I said, don't send a wrong message of placing flow diverter and all, but this patient again had a huge pica, and we have done a reconstruction. But I want to show what that, as Tufela just mentioned, artery moves and is very uncomfortable in acute SCH. These arteries moving around. Initially, this looked like a great, and again, a very lot of big branches coming in, so we thought we'll reconstruct. And but when you place a regular wire, your 12 wire, Traxxas wire, Synchro 14, all these artery moves a lot, which makes one very uncomfortable. The standard protocol, if we have to we get a drain in, and we get a big guiding right up to the pica origin, so as to give us good control. That is very important. To get Fargo max up there, you have to have your neuron max into the vertebral artery for a while, then only the guiding really goes up and in a stable position. Now we know we are in there. But in this case, as soon as used a wire, I'll show in the pictures how the artery started to move, and I was very uncomfortable that what am I really catheterizing now? You're not even sure whether the artery has all moved around, while this looks like a big pica. So again, we keep even 08, 01, 0 synchro we love at situations like this. So you see how the artery is moving? So now you get the point with Tufel, and this is very uncomfortable, right? I don't even know where to take the turn. So I took out this wire and I use a Synchro 10. So in this case, I switched to a smaller wire. This is a headway. Take a new road map so you know where you are, and use a much softer wire now, like a Synchro 10, to cross it. So which leads to less movement and slightly more comfortable and less traumatic in these very small vessels. So,
Vipul, we have a neurosurgeon at Stenting, so we could ask him whether he would consider bypass and parent vessel occlusion.
Okay, so okay, I'll stop the video here. What you mentioned is a perfect solution. The problem is India have never seen anybody doing pica bypass. At the best, All we have seen is STA-MCA or ECA-MCA bypasses. You know, I haven't seen anybody doing ACA, PICA bypasses. We just don't have it.
We can ask Rajiv what is.
In my opinion, most of these pica aneurysms, they are associated with intraventricular hemorrhages.
Yeah.
So issue is not only aneurysm, dealing with the aneurysm, but also to manage the hydrocephalus. So definitely, and these pica aneurysms are not difficult to clip also. So what is our, as a neurosurgeon, definitely practice is we first put this external ventricular drainage, and then definitely we do the permanent, occlusion, that is clipping. And the best treatment is definitely if you have some bypass surgeon, then that's the best option.
Yeah, but at least, I don't know, PJ, are they doing
Yeah,
any bypasses
Dr.
for smaller
Vipul, I just wanted to add another point, like unlike the MCA, M3 branch or ACA, A1, A2 branches, they are very much supported from the brain parenchyma outside. But these arteries in the posterior fossa, they are just lying freely in the subarachnoid space. So they move much more when we try to cannulate them and try to go distally. So they got straightened, and there are higher risk of vessel injuries, because when we go distally into the M2, M3 and those branches, they don't they don't change their course. But in posterior circulation, yes, they do, because they are lying freely in the wider subarachnoid space. And if they bleed more, because there is no tamponade effect of the brain there. So this is the point I wanted to add.
I think in this
because
case,
you took the next one, and because the anatomy is totally changed, the first when we took. So that is something looks very risky.
I agree, these are uncomfortable. And if this was a smaller pica, as I said, again, maybe, you know, it's a flow diverter session, you are showing a couple of pica cases, 90% distal pica we occlude. Only when we see a very huge pica at times, and like the first case, proximal ones, we think about reconstructions. So maybe I've done only 3 pica acute cases of reconstruction, 2 of them I'm showing here. So rest, we have all done PVO. PVO is great. Even if there's small ischemia, they all recover very well, all right? So let's not take away that from PVO as a first option and everything. But as I said, you know, and here you have to be very, very careful. Your fellow or whosoever with you, Dr. Rashmi was with me, keep an eye on the wire, because here you're talking about this wire is into one branch of the pica now. So very, very careful, and you take multiple runs to see that everything is going well. But yes, flow diverter delivery in this case was pretty straightforward. I mean, there was nothing much to it once we went across to deliver it. And she was a young lady, as I said, young doctor, huge pica, so we had decided on preserving it. And this one wasn't as tricky as that one to do. And there is some stasis in the aneurysm. We debated whether we want to place some coils in there. We thought maybe we'll complicate the procedure too much. There was quite a bit of stasis and flow change immediately. As I said, no heparin post-op. We reversed the heparin, low blood pressure in the extubation. And this is 3 months follow-up. Most of the aneurysm is gone, well preserved. In this case, no stenosis of the aneurysm and anything, so we done well. So yes, let me start from there. 90% of pica ruptured, we do PVO. It's a great technique, safe, effective. In those cases also, I sometimes use synchro 10 wire to catheterize, not to traumatize the artery and everything. Only when it's proximal, and like in last case, it was again a huge pica, doctor, working gynecologist, okay, we do a reconstruction, but PVO works well. And as we discussed, yes, long term, what happens with the small stents, we are beginning to understand now. Or we are beginning to know that we don't understand now. Let me put it this way. So that is a very, very valid question. As Vincent mentioned, maybe that first patient had collaterals, or whether collaterals develop over a while, they tolerated better, maybe. And as Tufail mentioned, these are not easy procedures. These are high-risk procedures. So we just wanted to show some technical aspect, that distal guiding, balloon in hand in vertebral, using 010 wire. You don't want to push your 12 and 14 wires into this pica. And during the delivery, you have to keep an eye on the distal wire is going to a small branch. And whatever you may do, you still have a PVO or a stent stenosis or arterial occlusion on hand and follow up or immediately. These are all to be kept in mind. Yatufel, you want to say something?
Well, I think you made a very good point here, saying this patient was a doctor. Yeah. So you change your attitude, and because of the VIP syndrome. And I think it happens to all of us, because we sometimes ignore what we have been doing because of somebody we know, somebody from the family, or somebody is important, and we modulate our practice because we think there is a small risk. But like if you see that your last angio, there is still some small nipple there, and that means you still don't know at that stage whether she is protected, because there is still some blister there. And that is a problem because we all have done this. In years of experience, then we do the same thing, and suddenly somebody from a family comes, we change our attitude, we don't want to do it, what we normally would have done, and I have got into trouble too. So, and you think, wish I had done it different. Especially happens when it's a consultant colleague, or somebody with you, and then you operate on him, and you change your practice, and then it affects it.
Okay, again, maybe should have shown more. It was a huge looking pike. As I said, still PVO is great. You offer those options to the patient. Sometimes it looks like a big pike covering a lot of cerebral hemisphere, and you worry about collaterals being enough. And the second case wasn't that tricky. The artery was quite straight forward. I think, but that doesn't mean we have a hammer and nail and we have to use it. You are absolutely right there. It is like cavernous aneurysms. Come on, we discussed in the slice training course, PVO with a grade ACOM, PCOM, with a grade ACOM, no venous delay, to me is one of the safest neurointervention I can do, right? Then why are we placing flow diverters which have interplated issues, less occlusion, more mass effect issues? We are trying to reconstruct. So we are in first case I'm convinced. I would like to occlude that pike. At the best, tendril thrombus will do a PVO, right? Okay, all right. And reconstruction versus deconstruction, yes, I still offer all my cavernous aneurysms PVO. And I quote them less complication chance than a flow diverter. If there's great ACOM with no venous delay, I think PVO, cheap, easy, local anesthesia, 20 minutes procedure. That's it, right? Only when I see a very huge pica, it use not like ICA pica. This patient should have moved from Israel, huge pica, a lot of cerebral hemisphere filling through it, young patient, highly functional patient, even if they have, and this didn't look like that difficult a reconstruction. Maybe it's a choice, but I don't know the right answers. I can't claim to be. Vincent.
No. I think it's the two cases are different. The first one was dissecting aneurysms with a large disease. It was not only the aneurysms; all the rest of the artery was sick. Yeah. And in my experience, when the artery is sick like that, it's very unlikely that when you occlude it, you have a problem. I don't know why. Maybe the flow is already changed after that, but it's very rare when you have a dissecting vessel that something happened. Almost never. And the other one, we thought it was very punctual problem, it was very small. The neck was large, but the disease was really focal. Yeah. It was straight, the diameter was larger, so the risk for flow diversion complication, size of the vessel as well, the importance of the flow. So it was for me a very good indication to try to keep the artery patent, especially because he's young. I think it's also something we need to take into account. Yeah. And she needs all his brain at his maximum to continue his career. So yes, I understand that you want it to be conservative. And we have the tool, because the 017 microcatheter with a flow diverter, it was not there before. There is an alternative to that, it's just to put a braided stent, like a Leo or like Evo stent from Microvention or Leo from... It could be an alternative because there is literature showing that just braided stent without being flow diverter is enough to reduce that kind of aneurysms.
Yeah, so I think Vincent made a very important point. Sometimes we worry about perforated, but dissected segments, the damage is already done. And patients tolerate it, or already there's an infarct and it's done. So we should worry less about perforators. That's an important point. And Tufil made an important point. I may be happy showing, look, it's largely gone. But as long as any aneurysm remains in ruptured, we are in danger zone, right? And that's an important message for us to carry. that we can't ignore that point, that there is still some small amount of residual aneurysm. And third important point, as again Vincent made, was in smaller aneurysm, even British stents work like flow diverter, something like Evolve, with even a smaller holes than Baby Leo, maybe even better. So sometimes, but only thing, we debated that point, and I'm more comfortable in safety with the British stent any day. Only thing was largest aneurysm. So I would have liked to place some coils with the British stent, and I thought 2 micros here really complicate the situation. But yes, in smaller vessels at times, British stents work very well. And as you saw here, there are no right answers there. If you have any doubt, PBO. You've got 2 masters sitting here saying PBO. Uday.
Yeah, sticking to the point, you made the points already, but sticking to the point of your great use of synchro, we have a very low threshold of shifting to the hybrid 7J. Absolutely atraumatic, it is fully J, curved on itself, and it's never going to catch something or perforate.
So that's a great thing again. Please don't use regular wires, whether we use synchro 10, sometimes we use hybrid, it's that J wire. Be very conscious, these are smaller vessels which will may cause injury pretty easily in these situations. So now let's go for small vessels to some big vessels and where we had a problem. Now this was 80-year-old female. One may argue that why we were doing it, and she was actually an international patient, and for all my perception, the family and the patient were very clear as for symptomatic and for treatment. So, and look at the anatomy, tortuous anatomy, but we thought once we are up there, the aneurysm looks okay, and collateral was there, but not too great. And we went in for reconstruction. Very tortuous anatomy in access. We had to use SIM. Even from radial, the angle wasn't great. And so in these cases, we use SIM, and then usually sometimes we'll use an Amplar's wire and to keep things stable, to get her guiding up. But as I discussed in the morning, Amplar's wire, we don't form a loop in the ICA, either in the CCA or in the ECA. And over a coaxial system, you get a long access sheath, and then one is in game, and the sheath has to go into the ICA. But in this case, we thought access is the only issue. After that, it's straightforward, but trouble started later on, okay? And when so many loops are there, I just use a 5F catheter to go across. So usually we take a micro catheter, 3A distal access catheter, followed by a 5F guiding. And you can see even then the manipulation of the sheath was beginning to get unstable. And so I think that's the 3/8 microcatheter. Then sometimes switch to a stiffer wire, and we have managed to get our 5F there. And now I thought it will be straightforward. We want to place a flow diverter. We thought it was a straight segment, and this was a artery pretty wide. This was a derivative stent. But as soon as we came to this area in the clinoidal region, and it wouldn't open up, and the catheter will sort of twist there. And it will behave like this. You can see the stent will just twist there. The whole thing will just rotate and will twist there. We tried many times. I tried push, pull, we resheath, redelivered, again resheath, again redelivered, different forces. And while it looks straightforward, in this region, if you see, it is the flow diverter kind of twist. Now looking back, maybe we should have taken distal access more distal, but the proximal access was so bad, we were not able to manage. And out of a lot of struggle, it was just opening up to this degree here. Lot of manipulation, and we thought, okay, we'll do angioplasty in the end. And now I will stop here. Now problem is, when we were focusing there, and we delivered this end, I think as Vincent showed in the slice training, I think I delivered with too much force. Now what happens even when we are experiencing and you're struggling with the device for a long while, one tends to get excited, okay? And sadly, I didn't even notice this end was like this. And I tried to cross it with a micro catheter, and I damaged it even more, all right? And then we saw something is wrong, and what we did was, without contrast, we decided to do a CT scan on the table to understand what was really happening. And you realize how this end, by initial delivery and our manipulation, we have sort of destroyed the end a bit. So what we did was, we used this vaso CT, and we rotated in multiple planes, And then we decided that is where the hole is and we can enter safely. So we use this CT scan image to enter the device, and I use a hybrid wire over a 17 micro catheter. All right, like Uday you mentioned, very soft wire, didn't try with a 27 micro at all. So we use a very headway micro catheter, I think it was duo, with a hybrid wire, cross it softly so we don't damage the stent anymore. And then we did angioplasty in this particular patient. So this is a case of fish mouthing, but delivered by extra force and because of our excessive manipulation. So this is we created two views where we realized if this angle it goes like this, then we are safe. And then over a 17 micro catheter, we were able to cross with a very soft wire. Then we exchanged with the balloon. And with one angioplasty there, the stent expanded, at least it was comfortable, not still perfect, but comfortable. This was in the aneurysmal segment. And then we came proximally.
What stent was this?
This was Derivo. And we did angioplasty here as well. I don't have the pictures. After angioplasty, we did another vaso CT, and it looked reasonable. I watched it for a while and left it there. Didn't deploy a stent, as you mentioned. And now we were happy we are done, and then what do we see? You saw it?
No.
Okay, sorry. Let me go back. Something we don't see often. Let me go back here. Let me play it for you. And just when we thought, okay, now we are done. Ajay, what's missing? Motor cortex artery embolism. Come on, this patient was on ticagrelor, heparinized and everything. Now we have embolism in hand. Now what to do?
Just put heparin.
Huh?
Just put heparin. Microcatheter is right there. I would be very aggressive here.
So we took the microcatheter and we injected some injectable interpolated agents. Usually that works very well in our experience. This is acute platelet clot. It didn't open up. So in desperation, I made another puncture and we decided to check for collaterals. And that is where we were, I guess, lucky. And we had a great collateralization and we left it there. Okay. Now question is whether this patient did well ultimately. We did multiple angiogram. Now the inferior end looked fine. Maybe still not perfect, but we left it there. We didn't place a stent there or solitaire there. And that was the end of the story. So what do you say, Vincent? Solitaire?
For the distal emboli?
For the distal emboli, I mean, what more could we do?
No, because I think we're in a kind of secondary distal vessel occlusion. I mean, we have no level of evidence that this occlusion that is very distal is harming very much the patient. So I think one solution could be to awake the patient and to evaluate the patient, because you are on the double antiplatelet therapy, you will go very distal, making a stent, making a thrombectomy. There is chance that it is working because it's just very recent, so it's a red clot, so there is no. But you still adding something more to the procedure. You will have to pass through your flow diverter. I mean, I would probably just do pharmacologic, like you did, depending on the complexity. If it's really straightforward, it's a proximal M2, I will make a pass as well. If it's very distal, I will maybe look at the angiogram, see if there is no collateralitis, as we said this morning in second IDO, assess collaterality, assess functionality, and make your decision. If you did what you did, it was anatomically, it was distal. You tested the collaterality, it was good. So you could.
The challenge was with all that heparin, injectable interplatelets, ticagrelor in the system, making the puncture. So we always do ultrasound guided puncture. Thankfully, my team always have got this peripheral IR guys. They're very used to ultrasound guided puncture. You have to make it a very, very careful puncture at that point of time. Yeah, Ajay.
So, Vipul, the proximal end, what I feel in many cases with us also, while we try to bump the proximal end when it is not opening, so while trying bumping with the catheter, many a time the proximal struts, they like tilted or moved inward. So this is what we can
Yeah,
see
so
on
I
the expert CT
we delivered too much force, and we were
yes.
so focused on the stenosis, I tried to cross and I made it worse with my micro. It was overlapping the bone in that working angle.
Yes.
So the message is that fish mouthing can happen if you deliver the proximal end with too much force, and in bumping you may distort it even more. And so, I mean, Vincent, when all do you see this kind of fish mouthing or stent distortion at that lower end? I mean, what are the situations it can happen?
Yes, it's exactly what Vipul said. I think there is two types of fish mouthing. There is the mechanical fish mouthing related to an excessive manipulation or a discrepancy between the diameter of the neck and the size of the vessel. And this is also in relation with the anchoring zone. The length of the anchoring zone, the longer it is, the less prone to experience distal fish mouthing you will have, since the stent has time on the distality to spread the difference of force induced in the aneurysms, you know, to make a repartition of this force in the length of the stent, the distality. If you have a very short anchorage in distality and a large diameter into the aneurysms, then the modification of the diameter of the aneurysms is, I mean, it's just the flow diameter is just one piece. The braid at the end is the same than the beginning, so each time you do something at one part, you're modifying a little bit the rest of the structure. So if you have not this anchoring tool that is too important, then you are pushing on the stent, then you are fish mouthing the distality. So first, there is the distal mechanical fish mouthing. There is the proximal one. The proximal could be because of non-opening, but the massage can solve it. And the problem is that if you want to make a massage too strong or too brutal, you can, because there's a gap between the wire and the micro, you can take a stress with you, and what we saw, and then you disconnect the stress from the other one, and then you are destroying the mechanic of the stent. And now the stent is sick. Okay, this is the mechanical one, and there is the, I would say, the biologic fish mouthing. This may come in a delayed fashion, where the healing process of the tissue is applying forces to the stent, and stents will be changed in shape because of this healing traction that will occur on the stent, and especially in the young people, especially the women. So it's different type of deformation of the stent. Acute for mechanical reason, immediate, and in the second way because of the healing process.
So Uday, we were discussing in this slice course this kind of distortion of the stent, and I practically destroyed the end of the stent a bit, truthfully. Should we have deployed a solitaire or any other stent there? I mean,
that's the thing you can do. I mean, this is such a long stent and it's reasonably well opposed arthroplasty and everything. You have had a small problem, distal embolus. You don't want to pull the entire construct out.
No.
So,
no, I didn't want to pull it out,
yeah.
sure.
So that's the only other thing that you can do. You watch it for half an hour, go out and come back, or maybe repeat an angiogram and see if everything is okay, I will leave it.
I think this is what discussed in the slice course, and Professor Mason made it very clear. If you have any doubt about this end, we left it there, and then solitaire, Atlas stent is a great choice there. It's got good radial strength, and it will, this end which we have sort of destroyed, the integrity of the stent, it will oppose it well, and it works very well. So fish mouthing, as I laid out, you deploy the stent at the curves, it can fish mouth. You deploy too much force, it can fish mouth. You use a micro catheter to manipulate, you can distort the stent and fish mouth, and Dr. Vincent said that on follow-up, intimal healing at times in younger people and says in women, I mean, it can lead to distortion of the stent. In acute phase, if you have any doubt, one can deploy a laser cut stent with a good radial force to oppose it well. Just one small question and then I'm done with this. Why do you think we had problem in opening up the stent in that cavernous area? I mean, why it wasn't opening up?
For me, it's twisting, I think,
Yeah.
because the risk factor for twisting is curvy access and long stent. Because what's happening when you are putting the distality of the stent, you are anchoring your stent. Okay, that's fine.
Yeah,
but your micro,
it twists here.
But yes, but your microcatheter, in order to arrive in the M1, it did like this, like this, like this, and finally get the M1. So in M1 you are deploying 1 centimeter, but the stent is fixed now in this direction. But the catheter, when you unsheath, is not unsheathing like that. He's unsheathing like that because he wants to come back to his normal trajectory. But here you are transmitting the rotation to the stent. So the stent is rotating with the restitution of the microcatheter, and then is twisting. So that's a normal, that's an obligation to see
so
this.
So what he's saying is, one view may look fine like a straight artery, but the other artery, the curve is such that catheter, when it comes to this area, it twists a bit, and it's a long stent, and microcatheter twists a bit and rotates the stent. And I changed the stent. I threw out one stent, used another one, whatever I could do. Whatever I could do.
Or you can do 20 times, it will be the same. I did it in vitro as well, it's exactly the same. So the only way, what you did, is that after, if the stent is not that much attached, when you will plast him, you will force the braid, to untwist by plasting it. That's what you did.
Just a comment again about your twisting. This is DFT, right? This is Derivo DFT. And Vantage is DFT too now, isn't it? Right? Nadine? Vantage?
I think, Raj, we will let go of this one.
No, it's cobalt.
We'll go to the next one.
Yeah. The twisting is long stent is not uncommon. Yes. And I see it very often nowadays in Vantage too. So you have to untwist it. And I had a couple of times when I've learned how to untwist it. Long stent, you need to pull it back, straighten it up, to remove the tension so that you untwist the twist,
Oh, Okay, so I've got one more thing, one more case. So we have discussed about fish mouthing a bit, we have discussed about twisting a bit, and this is the one last short presentation. Again, an old lady, and no collaterals, ophthalmoparesis, and one can see there is something happening here as well. No collaterals, there were no good ACOM, PCOM. How do I go? All right, and there's a stenosis there. What is this stenosis? Is it a thrombus? Is it a fibrotic band? Is it atherosclerosis? I mean, what are these narrowings associated with this? Some of these aneurysms are likely to be.
Can you show a 2D, because that will be overestimation.
Let me go. No, it was a bad one. In one plane, it was really bad. It is. Of course, it's not so bad as this, but it was a severe stenosis there,
Well, I'll tell you what I have done before you show. I would not worry about that stenosis, and I have often used Evol here, particularly because I'm comfortable with the radial force. And I think these are commonly seen in large cavernous aneurysms, where you see a little bit of stenosis, which is pseudostenosis. You put a flow diverter in, and that just goes.
All right, so we carried on. This is, I think it's a pretty old case, I think maybe 6-7 years back, and bad access, we were doing through femoral that amount of time, and again the same technique, you get a SIM, long sheath, implants in ECA, long sheath in, and then use a micro and 3/8 DAC to get a 5F Navian. In this case, we use a pipeline. As you said, we wanted a flow diverter with a strong radial force. I tried to do just want to see how much will it expand. So I think this is hyperglide balloon, and we tested it, and hyperglide or transform, and it was opening up a bit, but not too great. But we thought, okay, let's do the flow diverter, and we'll do another angioplasty after placing the device. And this is how, in this region, it just wouldn't open up. I used a lot of force, but this is what it would end up being, I could manipulate, resheath, replace. These are some of the videos. So again, we use a lot of force in trying to open up that area, trying to do a flow diverter angioplasty of sorts.
This is pipelines?
This is pipeline, and the older pipeline, not even Vantage. So, and it just wouldn't. You can see how my guiding is moving. I was using a lot of force, and it just wouldn't open up. We tried our best. It opened a bit here, you can see, but still significant stenosis there, and we thought that's the best we can do. But we compressed the flow diverter a lot there, so that in angioplasty we are able to open it up. And again, you see there was significant narrowing for whatever we could do in the device in this region. We completed our deployment, This is how it was. Okay? And I did angioplasty. Okay? And this is how it remained. And is Matthew here?
No, he left.
Oh, so I called up Matthew. I sent him the pictures. I said, Matthew, what do you say? He said, it looks like a significant stenosis people, it may occlude, and patient didn't have collaterals. And so what to do now? Will we leave it here or we do something more? I mean,
Coronary stent.
Yes.
yeah.
Put a coronary
So,
stent.
so thankfully Matthew was very clear. We you have no choice but go have a coronary stent. We thought we'll give it one try, and we did a coronary balloon. It didn't work out. But navigating the coronary stent was a problem. So what we did, we took a micro catheter, placed a stiff coronary. Over that, we took a 3A DAC through the stent and kept the guiding right up to the stenosis, because otherwise the stent wouldn't go in. When the guiding was there, then coronary stent, we could get it across. Otherwise, there was just too much friction. Yeah.
Yes.
And then we withdrew the guiding. That's it. The coronary stent was just stuck there. You can see it just wouldn't go any further. And we deployed it right there. And we left it right there. And then what happens in post-op? She was fine. And immediately what we see on table CT is a lot of enhancement in subarachnoid space.
Ce reperfusion syndrome. Hein?
Yeah. And look at her CT scan. After a few hours, we dropped the blood pressure and she developed seizures. Thankfully, no bleed. Brain was swollen on that side. Decongestion. We lowered the blood pressures. Thankfully, she did pretty well. No bleed developed. So she developed hyperperfusion syndrome there as well.
Is this hyperperfusion syndrome or this is contrast toxicity?
So see, this we have seen in many cases, dye in subarachnoid space, enhancing, and it goes away in few hours. But this, after a few hours, the whole brain was swollen on left side, sulci were gone, and this was hyperperfusion.
Oh, well, you haven't given contrast here. So the reason I'm saying is because you can get isolated syndrome, because this is an isolated compartment.
Yeah.
You had so much contrast, that could be just contrast toxicity. And we have moved to Visipeg now because we had a lot of Omnipeg problem. And I think that is contrast toxicity on that side. That's why she has seizures, and you must have given some steroids.
Oh, we always give anti-epileptics whenever we see such enhancement.
I think
we give anti-epileptics, steroids
that
on the
is
table.
just, yeah, but that is just immediately post procedure on table CT.
No, so the seizures happen in evening.
Yeah, of course.
So we have seen, Tufel, this kind of enhancement, we've seen quite a few patients nowadays. Usually you do the evening CT, is all gone. Most of it is gone. They do very well. We give steroids and antiepileptic. But this patient, we give steroids and antiepileptic, and she was fine post-extubation. But then evening, I don't have, this is from my previous institution, so I can't get more pictures, but the whole sulci were gone and the brain looks swollen. And in this case, we assume it's hyperperfusion.
What is true is that the contrast toxicity, most of the time the patient awake with a deficit. I don't know if the patient is awaking with the deficit, with the contrast toxicity.
Yes, of course. And
there is no time lapse of...
Yeah, that time lapse what you are saying.
You what I understand that she was under general anesthesia, maybe low blood pressure, and the time she recovering the normal pressure, then she has the demand, then she has the reperfusion syndrome.
I think I agree, I accept that. If there is a timeline between, if you have a normal period, then you are probably looking at a delayed hyperperfusion. If you wake up with that, then you got to have a similar feature, then it could be contrast. You did I learned something here, what you are showing me is you had pre-dilated it.
Pre-dilated with a...
Which is amazing, because I would have done it.
Okay, that's very interesting. So, we use neuroballoon. Now, question is, would anybody pre-dilate with a coronary balloon?
So, I had this discussion with Rene about something very similar.
Yeah.
And one of the discussion was that we should, if you see stenosis, we should think it is real. And particularly here, after your inflation, it was real. Then you know that it wasn't pseudo-stenosis. Then maybe you should have just put a coronary stent in the beginning, because after the flow diverter, if you put in there and you knew that you're going to get occluded, you could have got into serious trouble getting through it.
I absolutely agree with you here. As a mind, we're not tuned to do coronary angioplasty pre-flow diverter, but what you're saying makes absolutely sense. It would have been so much more convenient to do it beforehand. And
yes, but the crossing, once you put a coronary stent it's very hard to cross, okay? Sometimes you have big surprise. It looks straight, but it's very hard to cross. And if you have some manipulation to do for aneurysm in the stent to open it, I think if you do that, I would say, okay, you put a coronary stent, okay, you prevent the reperfusion syndrome by making pressure low for 3 weeks or 1 month, then you wait for re-endothelialization and then you go for flow diversion. Maybe it would be like that, because it's not an easy procedure, you know, to...
Yeah, I know, and when I had to chat with him about this, and the problem is crossing the coronary stent, and in that case, I put a step flow diverter, and I kept the distal wire and access to get a coronary stent in.
I think the only way to get
which is exactly what he did.
After makes more sense for me.
Yes.
Because it's like silk going into flow diverter. So even if it was a little bit challenging, you can go with the intermediate at the mouth of it, and you can always place a coronary stent.
I think this is a better way of going, because I think putting a coronary stent and then going through it, it's not easy.
To me also, it's you increase the difficulty of the...
Yeah, the key is to get your distal access catheter across the stenosis if need be, then coronary will navigate and withdraw your guiding catheter and then do it. Nowadays we are getting such terrific distal access catheter. This is an older case, and maybe that will make it more convenient. Yeah, Uday, please.
Yeah, so the point is, this is an extradural narrowing, whatever, maybe it's a part of the pathology. So you did it in the beginning, tried to open it with whatever balloon you had. But this is okay at this location. If the same thing happens, like for example in intradural VA, commonly seen, sometimes in M1s, then I would be extremely not keen to do a pre-plasty. We just deploy it, otherwise don't even do the case, because we have seen arteries rupture.
Yes, I absolutely agree. I have had some cases intracranial where I just didn't do the procedure if I think it wasn't going to open up rather than land up in trouble. I mean, so intracranial, as Uday raised, this is an MCA, there's a stenosis. What would we do? Would we not do the procedure, or you're okay with whatever we did here in cavernous location? This is just the last question. I think we are getting quite late. We go on. Next talk is Vincent Yost, that's stent technique.
No, it's too fake.
Okay. All right. Yeah. So, intracranial stenosis. Yes. Then, if these are safe to do in intracranial location with stenosis.
The same things? You mean like a supracranial aneurysm with a stenosis like that?
Kind of stenosis, would you be okay with deploying flow diverter and then trying to place a coronary to open it completely?
Yes, I think once you have done the job with the flow diverter, it looks okay to me. If you think the narrowing is too risky for the patient because you will have instant thrombosis, it is a crucial carotid, yes, I think you're not, it's not an obligation to make a 4 millimeter coronary stent. You can be a 2 millimeter coronary stent to ensure a minimum flow inside that, you know, to not have occlusion.
All right, great. So we close this session. We are going to the saccular device. So we try to discuss twisting and fish mouthing and parent vessel stenosis and blisters and distal flow diverters. And now we are going to the hot topic of intrasaccular device. Whichever one you want to Tufail. And we have got the master of IST, Dr. Tufail. And he'll be covering the techniques of intrasaccular device deployment.
We continue here, right, Vipul? We continue here.
Yeah, you can say, then you can criticize. It's okay. So thank you very much for the invite, and I'm not a master. So we're going to go through web and contour, because these two are available, and known extent is available, and hopefully RTs will be available soon, and if you want, I can go through the delivery of RTs if you have time. So contour versus web, as we're going to do together. As you can see, web is this way, contour is basically sealing the neck of the aneurysm. And I think all of you, if you're going to go for intrasaccular technology, don't just think about the device, think about the whole process. Think about how do you do an intrasaccular device. So if you want to use RTs, you want to use contour, or you want to use a web, you should understand the basics about it. And if you see contour, you're looking at equatorial plane. The aim of the technique often you should be is trying to get a catheter in the mid of the aneurysm. Sometimes it's not possible. You wait for this flowering to happen, and as the flowering happens, you can then position. But in contour, what you want to do is you want to seal the neck, okay? You place it here, it's not going to work. You place it too low, you can get into trouble, but you want this marker somewhere down there, okay? And then you can see if you do flow diversion, because it's a braided stent, you get some flow diversion in it. This is a famous man here, so I thought I should just show one of the video, as you can see. And I'm going to, from the time point of view, it doesn't matter what the patient had. You can see there is a ACOM aneurysm that you can see. It's wide neck, and you can see the neck is quite dysplastic here. You could argue that this artery is diseased here too, so you might want to, well, why do you want to do, sorry, that doesn't work like that, does it? So you can see that there is and then you can see the ACOM. What is important is try to get into that artery there, and if the video works well. So basically, like any coiling procedure, you get your best view. Here you can see what Vipul is trying to do. He's trying to access the aneurysm. You see the neck of the aneurysm. You can see that he's trying to get around. Here you can see the manipulation. In the workshop, I was trying to get everybody to understand. I always use two hands, one hand to control, one hand to push the device. Everything in neuro, if you're going to just starting, learn to control things. Here the device is being prepared, as you can see. You prepare it in the water, you push it out, make sure, like any flow diverter, any braided stent, it's the same thing that you do. And as you can see here, the device is being tested. Then you put it in the back of the hub, and then obviously just ignore this. These are my designs. And there you go. You get a flush in the back. This sheet of the serous original water stripe, but this hasn't been changed. Hopefully it will change. It's quite flimsy. And then as you can see, the device is coming in. You should try and stop here, pull the device back to make sure it's attached before you start pushing in. And as you can see, it's coming in. When you deploy the device, the aim of the thing is to, one of the good thing is that if it touches the wall, it's not as traumatic as when the web comes in. As you can see now, the device is coming in. It will start, the catheter will self-center if it needs to be. If it's touching the wall around, I wouldn't get too hassled. I've never seen a rupture with this device directly because of the device. And then you can do a very similar technique, a little bit of a push, open it, push and pull. As you can see now, it's opening up, and then, is it going? Okay. Has it stopped? And then you can see again, yeah, as he's unsheathing it. Now you have to kind of judge where you want the device to be placed. The intention of this device is to get the neck cover. The intention of the contour is to get a Y, like a Y stenting. So you come down in the neck as much as you can. Okay, so that's pretty much. I think the last part of the video I missed it, didn't I? He's very slow operator, so I haven't got that much time to show you. I think I'll have to get people to go a little bit faster. There you go. So you can see now, the device is now being come in, as you can see. And now you are coming up here, as you can see now you're crossing that marker. And then the device opens up here. As you can see now it's opened completely. Now at this stage, you can see this marker is here. This is the detachment point. That's a good way you can do a CT to have a look at it. And as you can see, it's well opposed. That's quite an important point. Always make sure that the device is opposed. And now we having a Dyna-CD on the table, I think it's a very good way of making sure that you got good opposition. And as what he has done here. And then again you can see, and that it looks pretty good in all the vessels. Look at the flow. Don't get very worried about that there is some compromise. It's kind of the similar feature that RTs has. You got enough flow around the device, so you should be able to get flow across. If you think you have compromised, you can resheath it and put it a bit higher, but don't be scared to get the device low down. If you keep the device in the artery, if you don't break the flow, you will get recurrences. If you look at an ACOM aneurysm that I have treated, here you can see it's a wide neck ACOM. You can see the catheter is coming in. And if the video works, as you can see, the catheter is coming in. Again, one of the benefit of this technique or this procedure is of using contour is because you're not using via catheter, which is a little bit stiffer. Sometimes when you're coming in and you're hitting on one side of the wall, you're not much worried about it because you're using Henry 721 and it's often a much more softer catheter compared to the via. So if you look at it here now, let's move to the next where I can get the device in. So you catheterize like usual, get your position. Here you can see the catheter is a bit higher, which is good because you can then decide whether you want to push or whether you want to unsheath. So again here when you got quite a good access, you know you can pretty much get the device a little bit more comfortably in. As you can see, the device is getting in, and as you take a little bit of time, I always use distal triaxial system. I don't use benchmark. I think when you get into trouble, it's not easy. So don't hesitate to use triaxial system. And then you can see again now the device is being placed. As you can see now, you know that in this position you're going to be coming. Here you can see that I'm hitting the wall here. I'm going to try and now push the device. The device is touching the wall, as you can see in this projection. The catheter is going to self-center. I'm going to push it out. As you can see, the device is now getting just pushed. You'll come down, and then you can reposition you can manipulate a bit. Very important, like remember I said, when you are getting it up, you need to test that it is attached. When you detach it, you then have to expose this marker, but then you got to give a little bit of a kick up the arse of the device, because that's what we call as a stabilization test. So you want to make sure the device is stable and it's not going to move. So here you can see now the device is here, and you can then manipulate the device. As you can see now, I can manipulate the device a bit more. And I'm giving it a little bit of a push there. This push is very important when you do contours. Okay, if you don't do it, your device may not necessarily know that it is stable. Either it can move in or it can move out. And I have seen one case which I was proctoring. I forgot to tell the person to push it and give the stabilization and test it, and the device came after the detachment into the MCA. So be very careful. As you can see now, you got good opposition. Make sure you got a wall opposition. If the device doesn't touch the wall, the device will get pushed. And then the CT. Again, in another video here, you can see the device has been pushed on this side, and you can see the opening. You can play. You can then bring it back. You got another aneurysm here. This is Vipul's case. And you can see now he's gone in. Obviously this patient has a lot of money. So you can see now you can put another contour, and you got two kissing contours there. So you can see, and you got a stepmother in the middle, but two kissing contours. When you look at the aneurysms like these in a distal ICA, like all the cases, you can get into tricky problem because of the access, and the catheter can jump. Height is not a problem in contour, so that's one benefit of contour when you're accessing again, because here you can see again when you catheterize, you're always going to end into the wall eccentrically. If you're going to have a web, it can be very difficult. You can see you got a nipple, you can't push. If you can't push, you'll have to unsheath and you'll end up coming out. Instead here you know that you are safe enough, and then you can take the wire is out, and then you can see I've tried to get up across there, and let's see the web, and sorry, contour, where is the contour video, so you can, hopefully this works. And now you can see that you have managed to get it despite this very difficult access. There you go, I think this one is the video where you can see you're playing it, you're literally deploying it from the neck of the aneurysm. Here you can see, and as you will deploy it, it will fall into the aneurysm, and you know that you don't need to put a stent, you're reasonably safe from the A1. From the time point of view, I've got a web. Is that both the presentations in the same time, or? Okay, good. Okay. What you do improve, I know now, if you have got a big aneurysm, you're putting a 9, 11, 14, please try and put some coils, as you can see here. Here I have got a jail catheter, I've got a contour at the neck, and you can see here, you got a contour, you got a coil. These are difficult aneurysms to treat with any intrasaccular technology. So I have improvised now in what I do, I will put some coils. Okay, you may ask me, why don't you put neck stent? Because I think contour has a much more better flow diversion than neck stent. So you want to put some coils, contour and coils, and I have 2-year follow-ups on these, and they do quite well. If you have, I'm going to stop on contour here, because you can improvise it with many different, look at the wide neck aneurysms. Again, you can see, I think here again it's a very wide neck aneurysm, but you can get a contour sitting there. And you can see the contour is sitting here, and it does the job. So exactly the same thing that you can see. You got problem, but I'm going to stop from the contour because we are talking about techniques, and I'm going to go for the web presentation. Shall I just continue? Yeah, is it okay? So contour, again, I used perioperative antiplatelets. I usually treat it like a flow diverter. I will always give antiplatelets. I give antiplatelets for 4 weeks double and another 4 weeks of single antiplatelets. Web, you can do web on its own, web with a stent, web with the coils. If aneurysm looks like a web, it's good for web. If aneurysm is good for RTs, it's always good for web. If aneurysm is good for web, it's very good for RTs. That's how I look at it. The shape is very good. RTs is a bit more softer now, so it's more compliant. But you can see this is an ICA termination aneurysm. It looks like a web. And I know that I don't want to put anything else. Web will do a great job. How do I deploy a web? Here it's a 71-year-old. You usually have a CTA or an MRA, and you look at the dimensions on the CTA, MRA. Again, it will tell you. Again, I don't use web now in large aneurysms because I know the recurrence rates are very high. Whereas you should not be worried about putting in a less than 9 millimeter. I think the recurrence rate are a lot lower. 9, 10, 11 millimeter up, I think the recurrence rate of webs are different and higher. So here normally again, I always use triaxial system. I am probably very conservative in that way. I have a younger colleague who uses benchmark for flow diverters, benchmark for everything. But he has problem that I don't have. Okay, so in Britain everybody is different, so you don't have like the German and the French system. The boss tells you what to do and everybody does that. In Britain everybody is a boss. Okay, so I don't care who has a problem as long as I don't have a problem. So I use a triaxial system, and as you can see, there is the technique has changed, and VS17 has come in. You can measure. You've got a chart, but I don't bother with the chart because I've been using this for years. So I think now I've been using web for 14 years. The deployment is not, it's something everybody would have seen. You have a triaxial system, you got a catheter. When it is not balloon, now when it is balloon, it is soft, But when it is not balloon and it's stiff, you have to make sure you're not touching the wall, otherwise you will go through the wall. When you look at the angiogram after deployment, you can see now the device is very low and it's in the artery. But it is a very soft device and you can resheath it very safely, you can put it back in. And here you can see after the second deployment, you can see the device is now in the aneurysm and outside, the artery is very safe here. So you can play with the device and it's a very beautiful device in a very good aneurysm. It does a great job. In a right size, right shape, it can be a very good technique of treating aneurysms. So repositioning, you can see how it works and it will do the job. Here is a MC aneurysm, as you can see. And it looks like a web. It's going to do a web, okay? And you can see the catheterization of the aneurysm, and then you can see you're getting into the aneurysm here. And okay, so here you can see I can catheterize aneurysm slightly faster than Vipul, but you can see, sorry Vipul, I'm just kidding. Okay, so as you can see, the catheter is on a slightly eccentric on the other end. You've got to be very careful, but it looks okay. And then you can see the web is coming in. As you can see, now you've got a web here, and you have hopefully the deployment part of it. Now you can see what you do is, again, you make sure you don't touch. If you're touching, you bring it back. You then unsheath it. Here you can see I'm unsheathing the device, making sure I'm not going to go any further. Unsheath the device, position it in such a way. Now it's a very soft device. Now you can play with it. It looks a bit forward, and then I think I can, if the video works. Okay. And here you can see now I have played with the device, and I'm going to bring the device a little bit back. It's a bit forward. I always want to make sure, because I'm always competing with the surgeons, and the surgeons don't like these small neck recurrences in UK for some reason. I did not know aspirin was a very dangerous drug, since all the younger neurosurgeons start coming in telling patients, you're going to be on aspirin for life. And aspirin is a very dangerous drug, and honestly, you have to make sure that you get good results. And I always, no offense to neurosurgery, but neurosurgeons think aspirin is the most dangerous drug, and that's why you should never put flow diverters in. But here you can see the aneurysm, and that's why you need to, if you're doing MCAs, you should get good results, because the surgeons get good results too. So I think it's important for us to get good results here. And once you are in, and there you can see the position is good. You can innovate. Here is a patient with a basilar and SCA. You could put a web here and a web here. For some reason I decided not to put two webs, and here I have decided that I'll put a web on the top and I will flow divert the aneurysm. And here you can see the web is up here. I've got 1 minute, 56 seconds. And then you can see the web is in. And you can see there is a pipeline on the other side. And I know that this aneurysm will disappear with pipeline. And Vincent correctly may ask me why I did not web. I had no answer to that question. I must have been in a mood to put a pipeline on that day. But I think you could have easily done a web in that. So I think you're correct. I think that was a misjudgment on my call, on my behalf. So acute, I think it's a brilliant technique. Here is a large hematoma, big aneurysm. Surgeons would love to clip this, and we can put an endovascular clip, as you can, I'll show you in a minute, where you can see large aneurysm. I usually show this in neurosurgical conferences because that pisses a lot of people off, but in a nice way. But you can see I've got a jail and I've got a web, and you can see you can put a web here and then you can coil the aneurysms. So you can innovate with the technique, Well, what is important is to see whether it stays like that in the long term. Sizing is an issue. If you see now Web 17 is beautiful, it's soft. You can put it in benchmark, but it is very soft. And there you can see there's the device was put in by one of my colleagues who doesn't put a lot of web. And this is the problem. The problem is you should do enough to know that you can anticipate that this is an undersized web. What happens as soon as you detach it, it has turned into other side. This is not a device problem. This is operator problem. Okay? And this is why devices get bad name, because that was undersized device. So please, if you don't do enough, make sure you have people around you who will know what to do and give you that opinion. And the opinion is there. I'm going to stop here because I think I can show you trouble. But both the devices will have problems. Thromboembolic, with web, I know it's 14%. With contour, I know it's about 14, 13, 14. That's a ballpark figure. Symptomatic is around 3 to 5%. So symptomatic is small, which is why I give perioperative antiplatelets. Because I know that I get thromboembolic. I do get thromboembolic with contour too, because I come down into the neck, okay? And you have a braided device, so I give it. But we have done so many webs, and we know that you get thromboembolic. Delayed recurrences, you're going to get both. Complete occlusion in both the technique, both the technology, I think it's around 60%. At least with contour, I know it's 60. Adequate occlusion with contour is around 85%. So why do I need to know this? When I tell patients, I have a figure to give them. And I think that's very important. When the surgeon asks, when we're debating, I have a figure, what my occlusion rate is. And then you can put that into practice according to what patient you're going to treat. Thank you. Anybody wants, do you want to see RTs as well? Am I in time?
Thanks, Tufail. So before you go to RTs, or you may not go to RTs, there are a couple of comments that I will make, which is for our geography. And that comment is about the sizing. You're very, very right in saying that if you undersize, then aneurysm is just going to come back. So what happened is, a few years ago, there was a euphoria of the fastest 100 contours that was happening in India. Very quickly, 100 and over 100 contours were deployed. And maybe quite some of them were undersized, because now, if you're doing follow-up, or if the patients are coming back to you, then there are quite a bit of recanalizations. And I think those were related to not sizing it properly, undersizing the device. Number two, the second point that you made was, whenever possible, if the aneurysm is sizable, whenever possible, jail another microcatheter and put coils. I think that was not done at all in the initial, those first few hundred cases here. And now we are wiser, but those cases have been done already. And that is another reason why it is not the device, but it is just that we did not know enough. We just went ahead and deployed devices right, left, and center. The second point that I will make is about the neck stents. You hardly showed any cases about neck stent. So because of the happy euphoria on contour, we have deployed in India quite a bit of neck stents also. Personally, numbers are not large, but personally, the neck stents are always with coils. So the anterior circulation neck stents have done much better than, say, the basilar top neck stents. I mean, we have done 2 or 3 basilar top neck stents. All of them have recurred badly. So any comment on that?
Yeah. I mean, there is a learning curve with everything. And, what you're describing, I have been always lucky to start early, so I have more screw-ups than many people. And I totally get that, what you're saying. If it's undersized, you're going to get into trouble. Now we know that 9 millimeter up contour is a problem, but we've been through that learning curve for web also. We are 12 years, or 2012 I started web. So I know now when not to web. I know now when not to contour or how to contour. You are absolutely correct about neck stent. Again, now neck stent, I have the largest follow-up in neck stent. We just recently analyzed our 2-year follow-up data and next stent, but I coil completely as if I'm coiling. Now I have had recurrences. The basilar is a very difficult, basilar top is a very difficult place for us to get complete occlusion in many techniques. So I think when it's a large aneurysm, unless you flow divert or stent it, if it's a large aneurysm with neck stent, if it is still neck stent is not sitting on the wall, don't put it. And what happens there, and I coil completely with neck stent, okay? With contour, if it's again, if it is undersized, you got a contour which is say 14 millimeter. The largest contour is 14 millimeter. You can only treat up to 10 millimeter. So it's never going to sit on the wall. Don't put it, okay? It will look beautiful when you finish it. But I can tell you in 6 months' time, it will be in the aneurysm. Now, does it matter when it's an acute one? I don't think it does, because you protect it and you can come back and flow divert it. So I've had recurrences in basilar, and and initially the whole euphoria about single technique, single device, I think it's a misconception. I don't think we should think about taking a device and just putting it. We need to understand the pathology of some of these aneurysms. The disease is in the wall. Despite the best size, still, like Webb does, and I know we're going to have the same problem with RTs, even if you size properly, even if it looks perfect, you will still have some recurrences because the disease is such that the wall is diseased. And the surgeons have been knowing this for years. And if you flow divert, all of them will do well. But the complication rate of flow diverter in a posterior circulation is quite high. So I think you are in an acute, you are not going to put a flow diverter. You can Webb or contour a coil, bring the patient back and treat it. And I think that's quite a reasonable approach.
So Tufel, you mentioned about criticality of sizing. Now there are a lot of youngsters here, and sadly, even among seniors of us, I don't think we have gotten over a learning curve. You know, you have to do quite a few. These are costly devices. So can you, very short time, can you say what are the precautions to be taken, sizing of Webb or contour? I mean, any message you have?
So if it's more than 10 millimeter, okay, don't use Webb, don't use contour. 9, 10, 11 size, once you got that level, your recurrence rates are very high. Acute, yes, no problem. Same with contour. Once it goes to about 8, 9, 10 millimeter aneurysm and a 14 millimeter will work, use coils. Sizing for Webb, my technique is, and I've been doing it for years now, I'll do the 2 planes. I will add, I don't need the chart, I do the 2 planes, I add it up, divide it by 2, plus 1, and then I'll decide the height. That height decision will depend on my access, depend on whether it's old patient, but I try to fill as much as you can. With contour, the rule is 2 millimeters on either side. So if you got a neck which is say 5, I want to go 6, 7, 8, 9, I need a 9. But then if it is height is enough, it's okay. But the height is not enough, then I might go for a 7. The thing is, if the aneurysm is bigger, if it is more than 9 with contour, if I'm using contour, I will use coils. You don't use coils, I'll tell you what, in 2 years, you're going to get those recurrences because I've seen them. Some of them, especially basilar top, I think it's notorious and we should be struggling with that.
So Vincent, what about you sizing these devices? I know you could do quite a intrasaccular device, and I think you have a different approach altogether.
Yes.
Right?
The difference rely in the sizing technique. We are also doing a lot of intrasaccular treatment in Montpellier. For example, out of the 400 aneurysms we are doing per year, 100 is intrasaccular per year. So we are, and we were the first user in France. I mean, the third generation, so it's a long time we're using intrasaccular in Montpellier. And we make up our mind that the sizing was a key point. And the flowcharts provided by the manufacturer is highly, in my view, cannot cover the complexity of the shape of the aneurysms. Even if you take AP view, lateral view, I mean, you are missing the complexity of the shape. So it's a good approach to embed. But Tufel is sizing well because he has 15 years of experience in the field and so he finds a good size. But if you're not
have 15 years of experience, I mean, it could be difficult to size well. And the problem is that we don't have time, but I can show you, just published an article that is being accepted in the Genius, that the sizing, improper sizing is a risk factor for compaction. And what is amazing is that the mechanical characteristic, that is a compression, mechanical apposition to the device to the wall, that you can only sort out with simulation, is an independent risk factor for recurrence. So what we are doing is that we are sending the 3D anatomy in simulation software. I will illustrate you in a few minutes a case, just an example of how we are doing in a daily fashion in Montpellier and in other centers right now in the world. So we are putting the 3D into the machine, and we have the 3D representation of the sac. Then we are selecting the wave according to parameters, the parent artery bulging, the apposition, but also now the compression, especially with the artist. Now we have the compression parameters, so we see how much intense is the force of apposition of the implant to the wall. So then I just look. I do not anymore, since the last 7 years, I never did anymore any 2D measurement on angio for sizing and intrasaccular, just on the computer. And then I select according that. And then the rate of change web per procedure is 1.02, meaning that we almost never change the web during the procedure. And I do the same now with the contour. I size with the software. So I think for me, I have to declare, to disclose that I have a conflict of interest because I'm co-founder of Sin and Size, so to be clear. But out of that, I truly believe it's the next step. That's why we work on that, but actually it's the next step. We will size properly, and the more complex are the implant, the more need you have to size. The coils, we were not really in trouble because you can put like 4 different sizes of coil. Sometimes it's enough to pack the thing and just continue coiling. So there was no really need for sizing. But now you are doing with complex things, flow diversion, contour, artists, etc., and more complex, and then you need to size. So for me, it's computer driven.
So Tufail mentioned he does his measurements himself and takes a size, but then needs a lot of experience.
Vipul.
And
sorry, do you want to ask my technique of sizing?
And I'm just summarizing. And Vincent mentioned he used softwares to size, and now Uday, he has a smile on his face.
Yeah. So
Uday, how do you size?
A very, very simple technique of measurement. We just ask our microvention guy, his name is Sundar. So, the size is his. If it doesn't go, the next device is on him. It's
so
very simple. We don't have...
And Uday said something very practical, and we don't have software, we don't have the experience. So industry has to use the experience of more experienced operators to get us the size, and so that we are not responsible for wasting a device. And last thing, I want to use a costly device and have a recurrence in a short while. So which is a challenge. So, but I think intrasaccular devices are here to stay. And the challenge is getting over the learning curve in our circumstances, because even now in my department, rupture aneurysm, coiling is a very powerful, simple, straightforward and much cheaper technique, and major block is actually expenses. And then since because we are not using that many, we get reluctant to use more. But I think they are here to stay. The technology is getting better. More are coming into the system. So all of us need to get over the learning curve. That's all I can. Just last question to Tufail. You showed a case like a reverse pointing ACOM, your microcatheter hitting the wall, and then delivering a device. And I find that very uncomfortable at times. I've done it. So how do you manipulate in that circumstance? And you showed it very well, that you push out the device and then it repositions itself. Just go over it in 1 minute or 2 minutes.
Yeah, so...
when funnily pointing microcatheter, how do you get the device right into the position, whether it's web or contour?
Yeah, so I think web is very difficult in that location now. What happens is that you are, even with the VR goes on one side of the device, of the aneurysm, and you try to unsheath, you'll end up being outside and it's difficult to position. What I do sometimes when I'm using web is once it's soft, you start ensheathing it, but once it is soft, you can use the device to get deeper into the aneurysm and then unsheath it again. But you need a little bit of a height in that to play with the web. With contour, what happens sometimes, contour is not a problem touching the wall, but in those eccentric aneurysms, contour doesn't open very nicely because it remains eccentrically open and it doesn't open. What I have recently learned, and I think intrasaccular technology is getting better, and I did a case exactly what you're describing. I couldn't get a web, I couldn't get a contour, but RTs just moved in. Because the way RTs behave, it's softer. And it conforms a little bit more better. So it had the beauty about web, but the softness of the contour. And it mixed them both together to get yourself in those forward pointing, eccentric anterior ACOM aneurysms. So I think when and this is the important thing when you know intrasaccular, because I can look at an aneurysm now and I can tell I'm not going to get here into it with the web. So I think that experience is important, but it's a very difficult thing to translate that into what everybody else, because if you don't do much, then you are in trouble.
And sometimes people think, okay, it's putting a microwave delivery device, but there are techniques to it. You need good angiographic system to see it's touching the wall or you're turning around this thing, and whether newer device will be easier to use in that situation. Just last question, how much bulge into the parent vessel you want and why do you want it?
So the bulge in the parent vessel with contour or RTs I wanted is because I think you have to disrupt the flow in this terminal ICA or basilar termination. Why we are successful with Y stenting or T stenting is because the flow is disrupted into the aneurysm. If you believe Shivan talks about this pivotal point at the neck of the aneurysm. I don't know whether you've heard of him. And he always talks about the pivot point at the neck of the aneurysm, why you should disrupt the flow. And I think I want contour very low because I can disrupt the flow. I'm not worried about giving antiplatelets, and I'm not worried about coming down into the neck of the aneurysm. So you use contour, please come down in the neck, construct a Y stenting, but through the aneurysm. That is the philosophy.
Yeah. All right, great. Thanks a lot, Tufel, and let's give him a hand. I mean, it's a long talk he has taken and prepared. He has been there for 3 days, very, very busy. I think now Vincent is going to present some interesting cases of intrasaccular devices, some technical issues or technical innovations. So.
Okay, I have one short presentation and one small movie of 2 minutes to illustrate. Yes. So yes, the intrasaccular devices are extremely powerful, and I think it's really part of the future of what we will do, because it is simple, it is fast, it is very safe, and the future probably. Yes. And probably the future is reproducibility, safety, speed for the treatment we have. The time of the pioneer spending 2 hours, 3 hours in a case is probably over. The young generation, the one that want to treat aneurysms to prevent bleeding risk, need to detect populational risk and to make safe and quick treatment below 0.1% of complication risk, below 1%. And if you foresee the future like that, you see that intrasaccular is the good way to go, because it's a straightforward procedure. There's a little bit more preparation in terms of sizing, etc. But after, it's a very short and safe procedure. So, but there is some non-indication. And you will see people will tell you, do you think it is an intrasaccular case or not? Can you raise your hand? Intrasaccular case, yes or not? Yes or not? Do you think you can cure these aneurysms when they're intrasaccular?
Ruptured or not?
Unruptured. Do you think you can cure it with intrasaccular?
I would still use intrasaccular if it's unruptured.
Would you?
Yeah, even with the
because
small
look,
bubble.
there is a blebs at the neck.
Still.
Okay. But most of the people would consider this not a a good case of intrasaccular because you will let something at the net, kind of patient will not be cured. And this is interesting because you can also target the positioning when you have room, when you have space in the parent artery. You can go at the neck, and you can close the neck plus the aneurysms. You can bulging, especially in the T of the carotid, for example, or a wide MCA as well. So this is the follow-up at 12 months. You see there is an artifact on the proximal pusher, but you see that the web is inside the T, a little bit like a wide stenting with some coil there. So it's cured by that. Another example of a difficult case, so 55 years old woman, no family history. She has a 5.5 pericallosal aneurysms embedding in a trifurcation. It's an azygos ACA. And she has another 3 millimeter aneurysms. So to access these aneurysms, you have to go here and to go here. Here there is an artery here, a callosomarginal artery here, another artery here with this. She was proposed surgery in 2 different centers, flow diverter in another center, and she came, that kind of patient that already had 3 opinions, when she comes to see you, she will never be treated because she never wants to be treated anyway. But this time, showing them that we can maybe do intrasaccular here, she was convinced to do the treatment. So this is 180 degrees. So normally it's not a good case for intrasaccular because you have to already lateral aneurysms are not a piece of cake, but 180 could not be easy. But here you do sizing simulation. We'll show you how. And you have a G catheter shaped that will go in the aneurysms, and we will unsheath the device. It will be under constraint, so it doesn't look good now because it's not detached, but the beauty of the simulation is that you can anticipate the final shape and when you release the constraint. So we'll detach the web and then we'll go for a simple coiling here. So this is the XPR CT. You see the web that is 180 degree position. And you see the follow-up here, angiographic follow-up, MRI follow-up at 1 year. You see, and she's cured by the device. So just to show you that there is tremendous possibility when you get used to the device to enlarge the indication rate. Let me show you now the short video I wanted to show regarding the simulation. If I can go here. Yes, it's here. It's here. And here, if I can put this full screen, yes. Just, yes. So this is a woman. She's 55 years old, and she has epilepsy. And when we are looking at the epilepsy crisis, she has this MC aneurysms with a swelling on the aneurysm. She did a fainting in the week. She had this MRI in a private clinic, and we saw that she had a brain swelling around the aneurysms. What is this? Yes. So you see the aneurysms. So it's a pre-rupture aneurysms. There is no thrombose in the sac. And she has a big MCA dysplasia that is about to rupture. So it's a fissurary syndrome. She has no partial thrombosis on the T2 stars. And this is the 3D anatomy. You see the complexity. There is a dysplasic aneurysms about to rupture with the edema. And you have another aneurysms here. There's a nice PCOM, the nice PCOM, but there is a P1 here. And there is nice ICA. First step, we are defining the working incidence thanks to the 3D and to the machine, understanding this barrel view of the parent vessel and the vessel we need to size. And then I go to the computer. And the computer, I try to think twice what I will do. Can I do slide over this? The first one is too short, there is no enough anchoring. I select another one. This one proposed me the nice anchoring without covering the ophthalmic. If I compress a little bit, I have my target landing zone. But I need to control the bleeding risk in this patient, and I could do an intrasaccular. But intrasaccular will help me also to follow the pathway to the MCA. I try a contour, not enough anchor with the highest contour. A web by 11, it will impair and block the branch. So I will not use this one. Then I test a contour here. I do the simulation. And the anchoring is a little bit too little. Maybe it could have been a good choice. I don't know. I did not select the contour because the anchorage was not enough. I took a web by 10 to just get the nice position there and do my redirection. And once you have spent like 15 to 20 minutes on the computer, then I'm just executing the plan. There is no thing, oh, it's the wrong side, bad side. No. I just put the stand, I open the web, I don't do damage reflection. I put the wire, I push with the wire to get in the MCA. I push the 027 in the MCA. I have my target landing, I start the Cangrelor because it was the pre-rupture case. I have my target landing zone that is matching the simulation. So once I'm in my target landing zone distally, I know that I will end in the good position. So now I just have to concentrate on my technique. I'm kissing with the web. In order at the end, on the control, I have a big difference in size between this and this. So it may have a fish mouthing, so I simulate an atlas stent in order to prevent fish mouthing evolution here. I put an atlas stent, pipeline voltage, and 1 hour and 20 minutes to perform this. This is the final DSRN. And if you measure the time, I mean, strategy, sizing, maybe I thought maybe 25 minutes around to see what I was doing. But the execution time in the patient was like 15 minutes in manipulating in the patient. So that's another way of doing, but I think the future is working on the digital twin inside the numerical space. And then you go shortly to execute the plan in the patient. And here in this tool, Intrasaccular is extremely powerful, okay, because you can test them and you can have the good size, almost I would say 90% of the case. Thank you.
Thank you. Just one question is for sidewall. I mean, I know that it's a difficult proposition for an intrasaccular device, especially web. You don't use a balloon to deflect?
No. I think the spirit of intrasaccular is to be easy and straightforward. If you need to put 2 balloons to put intrasaccular, then I do a coiling. So, and if you understand how it's working, you have to bend you can bend your macro like a G shape. And now the 017, for example, the web is so soft that it's following the curve. And if you succeed to, even if it's the microcatheter is blocked against the wall, when you open the device, because of the self-expansion, the device is recovering the central line of the main axis of the aneurysm. And then you unsheath, and you are under tension, so you understand that the web maybe will not be open, but you trust the simulation. You know that if it's like that, it will open, and then you detach, and boom, it's bumping, in the good. So you have to trust also your simulation. But it's really doable. I do plenty of lateral.
So that's a question now, Vincent and Tufel. How many times do you guys curve your microcatheter for intrasaccular device placement?
I mean, if it's not, if it's a sidewall, or even you saw the case, it's 180 degrees, not sidewall, it's reverse position, then I use a G shape.
And Tufel, how many times do you curve your microcatheter? Like even for a bifurcation aneurysm for saccular device, do you curve your micro at times, or it's always straight?
I think curving is good. I'm a bit lazy, so I don't curve and I get into trouble, and then I bring it out and I curve if I have to. So I try not to, but I totally get. I'm waiting for Bendit to be available, and I think once Bendit comes on the market, then I think all these problems of curving.
So basically you're saying you like to get into trouble, then get out of it, right?
Yeah, it's a habit from my med school. So so I can't change myself. I've just gone into a different way of getting into trouble. But I think if you all got a PCOM, I think it's good to shape, and it works.
I'm lazy as you, but I take a catheter for those aneurysms that is already shaped, pre-shaped.
Yeah, but you have 3 fellows and you got 5 people. I'm 2 people, no fellows often. So I just want to get in and out, and I sometimes
basic message is yes, at times actually for sidewall one shapes and maybe for some bifurcations one may use a shape. I mean, yeah.
Yes, it's rare. It's really rare.
Yeah,
I have to
yeah.
fail. When I say I'm take a G-shaped catheter, it's a pre-shaped. I don't use the boiler. I just take the catheter like another one.
No, you forgot the message. Uday likes, Tufail likes a bit of trouble and then get out of it.
I like stress.
Pre-shape is no fun.
Okay.
All right? For him.
I think it's important, like with all our juniors and all starting the job, the intervention neuroradiology is basically open neurosurgery coming into the lab. You just have the same disease, same problem, same stress.
So
and that's
on a lighter note, our previous generation, we got into this field to be stressed out and we don't like it.
We love stress.
Very simple procedure is not fun, right? So anyway, this was a great session. And thanks a lot to Tufail and Vincent for all the effort they have made. And Rajiv and Uday has been there for a very long while. But next is something which I would like to hear. Dr. Uday is going to talk about giant basilar occlusion and what he did with them. You know, I mean, all of us have become fond of flow diverters. Can you get a stock on by the time I can? Flow diverters and stents in these cases, but we know they don't work so well. And the past, a lot of parent vessel occlusion, other approaches have been used. But sadly, including myself, we haven't done too many of them. And you get very tentative if you think you want to do it. And I think Uday is one of the most experienced in this field. And I'm personally very keen to hear his case and learn something from it. Yeah.
Who is continuing? It's me again?
Okay, so you see, Rajiv, basically you have neurosurgeon stamina. So that's why you could carry on there. Thanks a lot. And Arvind, can you join? I mean, we have, for a while, we have few short sessions, that's it.
Can you open my presentation, please? Don't sit here. No, wait. Perfect. Now, where's Vipul? Okay. So what I told you and what you described elaborately, this is not what I want to talk about. It's not about giant fusiform basilar trunk aneurysms occlusions. So sorry to disappoint you. This is something which is very common, but not as exciting as what you said. So nevertheless, it is a very complex situation, and in all of them, it is complex. And we have treated all of them. Cannot say that all of the patients have done well, but that's the part of the life. So let's go to the case straight away. A couple of cases that I will share with you. They are giant aneurysms, but they are giant aneurysms on the top of the vessel. As in previous session, we spoke about, Tufail also said that they are really difficult aneurysms to treat and to cure. Maybe not so difficult to treat, but very difficult to cure. So the first one I'm going to show you is, this is a child, a very sick child, hydrocephalus because of compression by the aneurysm itself, and going on for quite some time, maybe from birth. So there is calcium on the wall, partial thrombosis, and giant aneurysm. And here you can see that the CT angiosis is quite good. The filling of the aneurysm is not as much as the partial thrombosis is. And this is the angiography. So when you look at it like this, whether it is 10 years ago, 15 years ago, or now, the challenges remain the same. And there are several approaches to it. And out of all these, maybe today all these things come to our mind. And what would you choose? I mean, you're here for a course, right? So it is not about the front row, but it is about all the rest of you. What would you look at that aneurysm again and look at the options that you have today? Anyone? Anyway, so I will tell you what we actually did, because going back to the pictures again, this is a 2-year-old kid. And if you could see here, and if you could see the date, it is 15 years ago. So 15 years ago, 2-year-old kid, we were not thinking of stents. We didn't have flow diverters. And we are not thinking of stents in a child back then. So those things go out of the window. Also, this was an open and closed case by a neurosurgeon. He opened it wanting to clip it. Giant aneurysm, basilar top, a lot of calcium. He couldn't do it, he closed it and got out. So now whatever has to be done by us. And so this is the message here, that you do the angiogram, the full angiogram, and find out that of course you will go inside and coil this aneurysm. That's the only choice you have. But when you look at the angiograms, you know that the anatomy is favorable here. What's the favorable part of the anatomy here? As you can see that the PICOMs are functional on both sides, plus it's a pediatric patient. So you don't have to worry too much about the reserve. The pediatric brain has fantastic reserve and the PICOMs are patent. And so this is what we have been doing for a very long time, that when the anatomy is favorable, when the aneurysm is large, you take the aneurysm with coils along with the basilar top. And this is what I wanted to show here. It doesn't look very exciting or very complex, but it's the simplest way of starting to treat a giant basilar top aneurysm. Previous session has shown us that it may not be the one-stop solution. You may have to come back, but this is a good way of beginning. That you started, anatomy favorable, you get the basilar top along with the aneurysm. This patient required revision of shunts later on in his life. That was 15 years ago. I just saw him a few months back on follow-up. He's not completely neurologically normal, but he is living pretty well and going to college as a 17-year-old young man. This is how we finished with. Completely believe in the collaterals, the circle of Willis, the PICOMs, and take the basilar top along with the aneurysm. This is what we did. And as I said, shunts, revision of shunts, but eventually doing well. Let's go to the second case after I have made the point. Second case looks very familiar. What's different here? It's an adult and it's a ruptured aneurysm. But the philosophy is exactly the same. What do we see here? Basilar top, large aneurysm. The left PCA is already not here. That means there is left PICOM, which is functional. So you have to save the right PCA, of course, and then you have to see, if you want to take the basilar top, then which are the arteries which are vital for saving. So we do, this is it, it's a large aneurysm, irregular and ruptured. So again, we did not think of putting in any of the stents or flow diverters here right away. Did not have intrasaccular devices back then. We navigate a balloon and did the balloon test occlusion, not for the PCA PICOM, of course. If the PCA is going to fill, we will see that, but especially for the superior cerebrus. And we saw that the picas were there, but it is not coming all the way back up to the origin or the peripontine segment of the skull. So we navigated the balloon now into the superior cerebellar. Of course, the PCA, this was the other PCA. One is filling antegrade, and this is the other PICOM, which is also functional on balloon inflation. Navigate the balloon into the skull, because that's the artery that we have to save. The collaterals to that from pica were not great. And take coil like nobody's business, take it along with the basilar top. And so again, we were happy. We have done it quite a few times now, and this is a good way of beginning. It looks great. Patient does very good recovery. Unfortunately, after this, she went home well and ignored our advice of follow-up. Just did not come for follow-up. Till she came for follow-up, which was 2 years later, giddiness, new symptoms, a new MR looking absolutely horrible. But this is what happens with a large basilar top aneurysm. It's expected. It's just that she did not follow up, so it comes as a surprise to the family, not to us. And now, of course, we know what is the thing to be done. We again go inside, put a lot of coils, And this time we went ahead and just put a flow diverter. So this is what it was. The pre, the post when we finished the first treatment, very bad recurrence, which are known in this geometry and anatomy. Then, of course, we have to go ahead and put a flow diverter, a little too long for my liking, but those were the days that we did not have all the sizes available. But luckily, no perforated infarctions. And for the hydrocephalus, the shunt was done before, and she also did very well over the years. Last case, which I'm going to show with exactly the same, these were a little older cases, which I wanted to show that this is not a new strategy that we use, and we believe in it, we use it quite often. Now, this was the third and the last case which I'm going to show. Ischemia in the thalamus, also small bleed, attempt and surgery, again one more time, open and close. Aneurysm is very large, and what do we see on a angiogram? It just goes and opens into a large basilar top aneurysm. By now, you know that there is not too much to think. Get the balloon test occlusion in a general anesthesia, not to see how the patient is doing, but whether the PCOMs are very good. And in her case as well, the same thing happened. If you look at it, then you don't know what to do. Initially, people or whoever came to me with a plan that 1 stent, 2 stents, Y stents, flow diverter, but you look at it, anatomy is favorable, we just get inside and take it with the basilar top. It's a large aneurysm, and this is, when the PCOMs are there, the basilar top is there, and it's right on the top of the basilar, no perforators right on the top. They generally come from the P1s. And here you can see both the PCOMs are very good. This is at the time of balloon test occlusion, and take it along with the basilar top. There's not going to be any follow-up on this because this was just done like 6 weeks ago, full recovery, patient home, and we are hoping that she actually comes for follow-up. So what's your advice here? This is what is done. Take it along with the basilar top. The advice is follow these patients up strictly. You have to follow them up because this is not the end. Patient has gone home happy. You have to tell them that please come to follow up on MR angio and then DSA within the first few months. If you do that, then it will be all okay. So what is the 3 things that you have maybe learned from these presentations that we have? Number 1, top of the artery large aneurysms are difficult to treat, especially basilar top giant large aneurysms. It's difficult. Accept it. Number 2, if the anatomy is in your favor, make it in the patient's favor. And take the aneurysm, at least as the first go, along with the basilar top, it works. No ischemias here, because you're not extending it up to the lateral perforators. Number 3 is the most important advice, is don't lose the patient. Call them up for strict follow-up, because as you saw in the second case, very bad recurrences are known. First one did well, second didn't, and third, we just did it 6 weeks ago, and so we are waiting. So far, everything good.
Thanks a lot today. I mean, I think I really agree. This is a very important talk to listen to. And Yatofel.
I think it's a great presentation, but I'm not sure I totally agree with you. I agree that basilar is bad. I totally agree your first case. It was a kid. It's a different disease. So I think basilar top occlusion was the best. And I think that really was the best treatment. And I think only because you have phenomenal years of experience, you could take that. The second case, I probably would have done it differently because you occlude the artery, but it's a wide neck aneurysm and it's an adult. It's going to come back because the coils are going to compact. So similarly to put an intrasaccular device, they're going to get compacted. So whatever you do, flow diversion was the treatment, which is what you landed up. And I also think that when you don't treat them early, basilar tip particularly, you somehow convert these saccular aneurysms into partially thrombosed aneurysm. And then sometimes I have found that you have missed the boat because you already got so much brainstem compression, you have become a partially thrombosed aneurysm, you got edema, and then you have significant neurological morbidity with your procedure because of preoperative, so you put a flow diverter. So I think my worry is that your third case is not very much different in terms of the intrinsic pathology of an adult wide neck complex basilar termination. So it's likely, like what, and you said is the right thing, you need a follow-up, because my worry is that this will probably recur and you're going to land up with a flow diverter. So I think you shouldn't wait too long. As soon as you see the flow coming in, you should probably put a flow diverter before it gets converted to a saccular, to a partially thrombosed aneurysm.
Yeah,
that's
Vincent.
my opinion.
Yeah, Vincent,
So
what's your opinion?
thank you very much for the presentation, and I have to say they have a 8-month kit to treat with a 3-centimeter aneurysms 2 days after I'm back home, and when I saw again your presentation, it gave me the force to occlude everything. That's what we will do. So thank you again for this presentation. Give us some hope. And the second thing is that in your very early presentation, when all the basilar locations were blinking, there was the one with the atherothrombotic one. And I did not see any case of that. And I would like to, I don't know, and would like to know why we do not have a case with atherothrombotic fusiform aneurysm, because I saw one in our presentation. Is it because all the patients are dying in whatever we are doing? Because it's a little bit the experience we have. So I would like to know if you have something special to teach us on this, or is there something...
No, it's also the same thing, because that's a completely different animal, as you know. It is not, this is different, it's dangerous.
Yes, it is different.
It is difficult, but the other one is almost impossible to treat and cure. So we have been doing for a long time, whatever which is best available today, we do. Which is like placing a long one, the biggest one.
So
like
you do medical? You do medical treatment, first line?
Yeah.
Okay, I think it's a very important message. You know why? Because it is rare. And everybody is trying to make a flow diverter first line because he succeeds to do some flow diverter in some location. This is fusiform, I will make a flow diverter. But I see the patient suffering for the lack of sharing the experience in between us. Me, I have 9 patients like that. 7 died after flow diversion. 7. And the 2 that are still alive, it was medical therapy, blood pressure control, anticoagulation. So I just worry that at each meeting, someone is coming with a telescopic flow diverter in atherothrombotic aneurysms, saying he lost the patient. Please, if you have this patient, please call one of the masters of India, ask an advice, but do not rush on treatment, because, I mean, those patients that we have killed, that we have worsened, many of us, they need to be useful at least for the other patients. And because it's rare, people are not sharing, and I see many meetings, someone that is discovering the disease is putting flow diverter telescopic and having a bad issue. So I think it's very important, something to debate on that. It is medical first line.
Yeah, I think that is very important. It's a completely topic maybe we haven't covered in this meeting about those bad basilar. But I think why Uday's talk is important is that in this era of let's deploy a flow diverter, let's go for a flow diverter, youngsters see this is an option. Keep in mind, these are not great aneurysms for anything, even after flow diverter. We don't know. Giant partially thrombosed basilar top, we have seen, Rene has shown us cases where they keep growing. I mean, so have an open mind to the technique which he has shown, which is simple, straightforward in a way. Decision making is the challenge here. So I think that is why very important to look at these techniques, because I don't think we have a great solution to these cases anyway. Best of technology. So thanks a lot, Uday. That's why I said I really wanted to hear this so that all of us gain some confidence in some situation, or you can consult Uday. He is ever there and take a right call for the patient. Thanks a lot.
Sure. Thank you.
Yes.
Dr. Uday, one comment.
Vincent, just one sentence about what you said. That's a different disease, but you know, you don't have to promise them the moon. You have to say that it's difficult, like if you leave them alone in years of time, they're going to go down, which is very difficult for him and the family, and they're going to die. Instead, if we can do something which is 25%, 30%, that is maybe 1 out of 3 or 4 patients okay to live for 10 years, then I think it is still reasonable.
Yeah, no right answers. Yes, a probability, and I think we can just tell the patient the probabilities. You know,
The problem is sometimes you are worsening them. It's not
Yes.
just you are refraining the disease to grow,
Absolutely.
it's just you are worsening them.
I'm sure in next meeting, we are going to have a session on this large fusiformal vertebro-basilar aneurysms as well. Is very important to discuss.
Yeah.
You know?
Atherosclerotic as well as
Other ones.
non-atherosclerotic.
It's a whole topic. We'll need an hour or two to discuss, I think.
Okay.
Definitely, and we know whom to call.
The
Thanks a lot, Uday.
The first case, what sir told is, it is definitely not flow related. It's a 2-year-old kid. It is a different disease, totally dysplastic.
It's different. When almost from the birth of the child, or very, very soon after birth, this must have happened. I don't know. We have had a few forceps deliveries, and it's a simplistic thinking that maybe the forceps caused something dissection in the basilar.
This case, you could actually sacrifice that, the top thing where the PCOMs. But when it happens in the basilar trunk, what options we have?
Yeah,
Which
I mean,
is
that's what
very,
we were talking. That maybe for the next meeting we can leave this, where we have actually sacrificed the basilar arteries, looking at favorable options. You know?
I think next time Uday's will be how to sacrifice basilar wear. All one can sacrifice basilar. Where are the perforators? We were having a discussion to fail. Vincent, he had this giant case. How to do a short segment basilar occlusion. I think all of us need to learn. You know, we have forgotten about
Dr.
performing.
Vipul, one should have a lion's heart.
Vipul, but the message was that he had good PCOMs, and that was very important. But if you don't have that PCOMs, like which Vincent's case doesn't have PCOMs, and that is a... Well, he's not going to make the PCOM, is he? He's going to be... He might develop the PCOMs in time.
No, but to fail, once you inflate the balloon, you'll be surprised that
Yes.
even a thready PCOM can take over entire PCM.
Oh no, I totally agree with that, yes.
You should teach us this. In a small PCOM is suffice in the stereo.
Okay, thanks for
It is just that, you know, in the era of stent and flow diverters, we are not thinking about these techniques. And I think it's very important because we, as we have discussed, even stents and flow diverters are not a perfect solution in some of these cases. So we should know, right? I mean,
I have seen a couple of cases, different countries where they have done this, and that's why it was when you were talking, I said just occlude it because I've seen this, that you occlude these are the basilar artery and you get away with it in these giant aneurysms because flow diversion is not a treatment because you'll end up with a bleed quite often. We know that they will rupture with the flow diversion.
no, thanks a lot, Uday, for these very, very tricky cases. And so we go on now and we are entering the session of stents and balloon. And Ajay, you are there. You are supposed to chair this session. Ajay was, no, you guys keep sitting. Not, okay, Rajiv, you can leave. You have been there for a while. Ajay is not there, so we just carry on. He was there. All right, so we are coming to, I know it's quite late in the day, so deliberately we catch some videos by our team, so we'll try to discuss as many as we can, and rest we will see maybe in the next meeting then, all right? So 38-year-old female patient with grade 3 SAH, and this is the aneurysm, all right? It's a very broad neck ACOM aneurysm. Let us show the other angles as well. It was multilobulated. Here you can see there's a lobule near the neck. I think, Vincent showed a case of an intrasaccular device with near the neck. This is the anatomy. This is like almost the down the barrel view. You can see the aneurysm is really involving the ACOM complex. So, what to do? I mean, will we do balloon assisted coiling, double balloon, stent, FD, 1 stent, 2 stents? Let me show the picture again. This is the one angle and this is the other one. Anyway, let's carry on. So, Vincent, you do.
Can you show me just
Again, let me go back.
Yeah.
This is the
ruptured?
bifurcation.
Ruptured?
Yeah?
It is ruptured?
Yeah, this is ruptured. And this is the.
We'll try with balloon and coil, yes.
Yeah, yeah. In fact, when I looked at it now, I said, okay, we can balloon and coil. and this is the other plane. There was near the neck lobule as well. And we decided to do stent-assisted coiling in these cases. Some of these cases, we know they will not come back for follow-up in our circumstances. So sometimes, if the bleed is not too bad, it will not need a shunt. And I'm pretty comfortable with stents in acute SH. FD is a different matter altogether. And so we went ahead with stent-assisted coiling because we had to be sure we get all those irregular lobules. With balloon, if I stop and can't get the lobules, there's some filling, then we are really, really stuck with it, what to do. So again, we always take triaxial. This is one plane. Here you can see what we are trying to do, multiple irregular lobules. So I was worried that if some residual filling, stent should take care, and there was near the neck lobule as well. So we thought maybe stent will be a safer choice here, or at least a long-term practical choice here. And so what we do usually, we use a single stent, but we use sort of shelving technique to open it up. And that's the coiling micro. I think it was phenom in this patient. In the other plane, we like to see two planes that is trying to point in the center of the aneurysm so that we can use long first coil. And sometimes, if not form a loop, we withdraw the microcatheter, form a loop, and then push the microcatheter in. And that's the, I think we are using baby Leo. We always force some coil loops in so that if the microcatheter moves, coiling microcatheter moves during stent delivery, it doesn't rupture. So we always like to get, and we want to use a long first coil to form a great cage. I think that is very, very important in these patients. And when we come here, this is where we push the both stent microcatheter to expand the stent a lot, as you can see it here. And so we have pushed the micro, and suddenly you can see the stent overexpanded there. And that is very important to really what we call a shelving technique. But when you are doing this, your guiding should be very stable. So under your junior or your other hand should be on guiding, pushing it forward. That's the only way you can build up force to overexpand the stent in that area, so that we can try to cover most of the neck by a single device. So now you can see we have created a surface where we have got a good, nice first coil which is hugging all the walls, which is very, very important. Long first coil to us is becoming very, very important. Two views hugging the walls, otherwise one is in trouble. And you can see we use multiple small coils. They are going to different lobules. We keep increasing the pressure, decreasing, and enter all those lobules. To us, that is very important rupture. We didn't know from which lobule it had ruptured. So we try to coil. As there's some coil coming there overlapping the stent, doesn't matter. That is where stent is open. So we have re-entered the lower part now. So this is what we do with stent. Sometimes we reshape micro, resheath, enter different parts, and we try to coil the various parts, at least some coils into these lobules for sure, before we stop. And in the other plane, we can see still there is some filling of two of these lobules, and then we try more coils at the base to pack it tight. And that was the reason I used a stent, because I wasn't sure with the balloon I'll be able to get it that hard, and I wanted some progressive thrombosis after the procedure. And now there is some stasis in that lobule. We withdrew the microcatheter, finish the deployment. As usual, we are loaded with Procedural preoperatively. Some filling of the aneurysm at the base, but we were hopeful as the heparin will go off, it will thrombose further. If these lobules were not there, maybe it would have been balloon and coil. Okay, that was my worry here. Because of those, we thought, and near the neck lobule, we thought maybe stent will be a better choice. As you can see, the drain was already in such cases, so that there is no issue of CSF drainage. All the vessels well filling. But so what do we see in this image? Even in spite of Procedural, what we are seeing, something small clot formation, and this was surprising. Usually we don't get it. Maybe shelving compressed the stent a lot, becoming like a mini flow diverter in that area. Usually we don't see, we do shelving technique a lot, but we know acute SCH is thrombogenic situation. And that's the reason I would absolutely hate to use a flow diverter in acute SCH in a bifurcation aneurysm in acute situation, even with stent. But there was no flow change, no change. We gave some injectable agents. We did a check angiogram next day as well. The small clot remained, but no flow change, no issues, and we just let it be. But you can see next day, the lobules have by and large thrombosed, and we were quite comfortable about it. Again, as usual, we extubate with controlled blood pressure in this, and we continue with our antiplatelet agents. So we love to do balloons. I mean, maybe 90-95% of aneurysms in our acute assay we do with balloons, but in specific situation where I could coil this aneurysm with balloon, but I was worried about the small lobules which were near the base, and if I don't get coils in, then I was worried that whether, we'll be stuck with it. One may argue, but here we have loaded with antiplatelets, so I mean, maybe it would have worked, and we opted for stent, but we saw in acute situation, even with antiplatelets, sometimes you can get clot formation and issues, and even with stent, it's just not place a stent and coil, we have to reposition the micro to try to get different parts of the aneurysm here, and ultimately it was fine, although there was clot formation, but patient remained well, so.
Double balloon was option?
Double balloon was absolutely an option. I mean, I can't say no to it. We have done double balloons in the past, and it's an option. But as I said, in this case, the lobules were near the base, and I was looking at progressive thrombosis. Whether it was the right choice, I don't know. If clinically there was a complication of this clot formation, I would have said, come on, in the past I would have done with a balloon, and I would have done with a balloon. So it's up for debate. We don't know the right answer. I mean, Vincent,
what we know is that if you need truly during the rupture case to use a stent, it's doable. The safety is there, especially if you have no ventricular shunt. I mean, the literature, it's reported that the safety is pretty high, especially if you know to monitor the antiplatelet therapy again. So the key of this is having the tool to perfectly monitor the platelet inhibition rate. That's why here, typically in this case, we are doing it. I have cases I've showed during the course here, but I cannot show it again. But where it's really dysplasic, we go for stent and coil, despite there is a grade 4 with an hematoma in the Sylvian fissure. And we just use the cangrelor, monitoring the PY12 inhibitor rate up to 50%, so not 100%. And then we do the stent and coil with a brain hematoma in the patient.
Yeah, so we don't have waste. Most of our hospitals, I don't know any hospital really reliably doing platelet function testing in these patients. So we are just loading and doing them.
Yeah, but this is the future. You will have it, I'm sure, because we need to master the pharmacology very well. And what do we need to control the platelet function? So at one point, I'm sure it will be everywhere. And we should demand for it. We should demand for tight control of platelet aggregation. It's a very good example.
Yeah, I absolutely agree. And as I said, this case was meant to show, number one, shelving technique. Number one, as we discussed yesterday in the slice program, sometimes near the neck lobules. I mean, okay, we may argue in acute assays whether we should have done it near the neck lobules. Maybe if you can't coil them, just a stent placement, British stent may be useful. Balloon remains the primary choice in our hands. We don't use that of saccular device, primary, but sometimes when they're near the neck more, this aneurysm was very irregular and you are not sure you will get it. Maybe stent-assisted coiling, but stent-assisted coiling, you have to pack it very hard. Like I showed you, we use new roadmaps, blank roadmap to see where the coil is going, and it's just not placing the coils and relying on, we try to pack it as much as possible. We even reposition the microcatheter to pack the whole base very, very hard to be sure. And lastly, whatever you may do, thromboembolic complications are more in acute condition, I mean, rather than a simple thing. So we have to be very, and look for the clot formation even in these kind of cases very well. Coming to another acute situation, let us come to this. This is 44-year-old female and acute subarachnoid hemorrhage, and that's the aneurysm. What do you say? You remember you showed in slice and you placed a flow diverter from A1 to A2? Remember? You had irregular ACOM aneurysm like this, so.
I think the problem, yes, in slice it was different. The case was a little bit different. But the problem we know if we post a flow diverter A1, A2 is that you have a contralateral A1, A2 and it's exactly in the middle. So you may expect the flow still going into the aneurysms if you check the right.
Yes.
So yes, it's not exactly the same case.
Yeah, you're right. That had a much wider ACOM, and here it looks from the left A1, the jet of the of the blood will go into this ACOM aneurysm. So Ajay, since you are fresh after your tea and coffee, we expect a more vibrant answer from you
right
while
now.
we are tired.
So the options are not very much like from left, the right A1 to the left A2 stent, and then coil the aneurysm.
Perfect.
Yeah, stent assisted coiling.
Thank you.
Across.
We will do what you say. All right? Yeah. So anyway, we did what Ajay was. Problem is how to catheterize this aneurysm, and I mean, there is nothing there. I mean, you place the micro, there is nothing left. So what we call is, I mean, we never try to catheterize such aneurysms when very, very small. This is a blister-like, but to me it's a sacral aneurysm. I mean, it's a classical location. Again, a thick clot, hydrocephalus, so you have to get a drain in before you want to do. You want to have your neurosurgical consultation beforehand, so we got a EVD done. We keep the drain on a little bit so it doesn't get blocked off by blood, and then we go ahead with the procedure. So you do a bilateral puncture in these patients because otherwise, so what I do in these cases is the coiling micro, I will take into the right A1. I don't try to catheterize. I mean, it can jump around, rupture or everything. And that's the stent micro I took into the left A2 as Ajay suggested just now. And then the coiling, I think, now this is the coiling micro which we have taken into the right A1. So I've never tried to catheterize this aneurysm. So we have done quite a few of such cases. So then we have deployed a baby Leo, and once we have deployed it partially, I drop it down. Okay, so this is another plane. So what we do is we deploy the stent partially, it's partially open at the neck of the aneurysm, and we drop that microcatheter over the stent. So we never catheterizing. Once it drop over the stent, it is pointing into the aneurysm. So from that is where we deploy the coil. So just to show you from the other plane, see we are withdrawing it and let it drop over the stent there. And then we take a new roadmap, because always you can imagine with the stent, everything, even a millimeter change in the position of the artery, you may rupture. So we are very open to changing a new roadmap. So we are very, very sure where exactly a microcatheter is. And then we try to place a very small coil. See, I'm trying to place a small coil, but it wasn't going in. And then we managed to push it in. And this is the other plane. So from outside, maybe this was 1.5 into 2, I don't exactly remember. From outside the aneurysm, very, very slowly, you try to place in a partially open stent a coil. And we let and reduce the tension of the microcatheter, let it come back if it has to. It's okay. Even a small coil tip projects, we are very comfortable. It's okay. Stent will sort of push it against the wall of the aneurysm. You can see microcatheter is out of the aneurysm, it's just around the stent. I had a difficulty putting the last part in, I let it be there. You take a run, and in these cases, as Vincent was discussing yesterday, we were discussing, you don't want to pack these aneurysms tight. We just want some loops there to promote thrombosis. Even a British stent is like a flow diverter in a small vessel. And then we detach the coil, bring it out, and then we finish the deployment of a stent. So you can see the coil tip is a bit out, it's okay. Rather than trying to push it in and rupturing the aneurysm can be more tricky, and then it's fine. So these are blister-like, but they are not blister aneurysms. To us, in acute STH condition, flow diverter is not an option. And one can do this technique, and what we call as microcatheter resting over the stent technique to coil very, very small aneurysms. Take your time. You can see some coil tip is here in the ACOM, but the stent is pushing it against the wall. It doesn't matter. Small coil tips like this. There is some residual filling there. It doesn't matter. They almost never bleed again. As the heparin goes off, again you extubate them with very controlled blood pressure. That is very important. You don't want the spike happening at the time of the extubation, and then we let them be. All right, so at least we haven't caused flow change. We have a patency of the ACOM region, which is very useful if this patient goes into vasospasm. So even very small bifurcation, blister-like, they are not blister aneurysms. I still feel, okay, this is slightly more, cumbersome than doing a flow diverter placement, but probably these are the right solution for these patients. And even in the era of flow diverters, we have to be comfortable with stent-assisted coiling in this situation. So, Etiology.
One stent is there. Can you please
other balloon in other branch because coiling is definitely a risky job. So can you place one stent and
Okay,
balloon
left
in
A1
one?
I thought was too small to place a balloon. And even if you place a coil there was such a broad neck thing, I think coil could have run away.
But just to prevent the rupture, or to backup plan is a rupture because placing the coil is
Okay,
really
you know
risky.
what? You are absolutely right, okay? 15, 20 years back, I have placed coils, all right? I even placed a 2-in-1 GDC coil, broken them, but come on. It was, I can't do it anymore in spite of everything. And this is too small, and it was like a pyramid there. Coil stability would have been very, very, you saw, even this 1.5x2 coil wouldn't go in completely. I've left the tip hanging out, but with the stent, I'm opposing to the wall. And there is always a residual filling. With stent, I'm comfortable, it will go away. But stent is not changing the flow dynamics, it's quite safe. And stented segment will not even go into vasospasm. So, yes, long time back, when we didn't have great stents, I have tried to place coils in these, and I did. But in the current era, I would use a stent.
Here, in addition, the aneurysms is very small, is looking up, and we know risk factor for peroperative rupture is small aneurysms and balloon-assisted. So I think the risk of a balloon-assisted attempt would have been quite high. The flow diverter is 8% complication in A1, A2, and here, to my mind, it's not a good option because the aneurysm is not an A1, A2, it's on the ACOM completely. So it's not sure that it has solved the problem. So I think what you did is very good. And what is interesting is that it allows you to accept to have coil in the artery. So that I think is very smart because you are not in the obligation to finish the coil, where the last loop, it's the last loop that is perforating the aneurysms. The last push, when the pusher arrives and the coil is a little bit more straight than the first loop that are very soft. So that's extremely good, I think, the way you did it.
So in these cases, we deploy a coil very slowly. You can take a couple of minutes. Every time you are trying to get a feel, if you reduce the tension microcatheter too much, everything will come back. But if you keep too much tension, you may rupture. So you deploy a little bit, get a feel of it, breathe easy, then deploy a bit more, breathe easy. And when you know you've got some loops there, a tip coming out, and with a stent there is not a problem. At that stage, I was comfortable microcatheter backing out. Another important point is be sure you have detached the coil before trying to withdraw. Last thing is, it has not detached and you try to withdraw, it comes out, it detaches there, you are in big time trouble. So in these cases, like in India, sometimes we previously used detachment system. I don't care. I use a new one, I detach it 2-3 times. I'm absolutely sure it has detached, and then only I pull out the pusher. So that is another important point. Last thing you want is coming it out. So we take care of the detachment. So each step we take a time. Each step you take a time. You place the microcatheter there, withdraw, you take a run. Is it pointing there, not pointing there? Is all right? Do we need to shape the micro? So I kept the microcatheter a bit shaped. Sometimes we give it a reverse shape to make it point there. Partially deploy it, stent, and take your time and deploy the coil over a few minutes. It's all right. It's not just pushing it in, so that you're very sure about the feel of the coil, the way it's going. Okay. Of course, biplane is very useful to see whether in 2 planes the coil is going into the aneurysm or not. But I guess I've done in the past in single plane as well. But yes, biplane is high resolution imaging is very useful. Take a new road map is very useful. Like a tip hanging out is very useful. It's all right. Okay.
So, but Vipul sir, if the aneurysm were even smaller, which we encounter many a times, and anatomy is like this, then how to go about, because this is a very difficult situation.
If it is even smaller, I will just deploy the stent and let it be.
Maybe stent or flow diverter?
No, you see, I wouldn't like to trap the right A2 in acute stage with a flow diverter. All right.
Yes.
Maybe I can use LV Zevo. Maybe it will have a little bit more flow diverter effect than Babylio.
Okay.
It has got smaller holes, right? More wires. Use something like that.
Yeah.
If in any situation you do end up using a flow diverter, I will oversize the flow diverter.
Yeah.
There are situations where we use flow diverter in acute stage, then we oversize it, so you're converting into something in between a stent and a flow diverter, so that you don't cause, because this is acute SH, right? There may be vasospasm. What patient may tolerate in your procedure may not tolerate after 5 days.
But this kind of anatomy is very much common in our practice, and
So
whenever it comes, it is
even maybe
difficult.
just placing even a smaller than this, just maybe a stent will suffice. That's it, no coil. Maybe, you know. Okay, let's go on to another situation, which is, all right, let us go over this case. Let us go ahead. It's a longish video, I think. All right, another patient, 66-year-old, had multiple aneurysms actually. She had an ACOM and bilateral MCA. We had treated the ACOM aneurysm before. We thought most likely distal ACA1, that was most likely the rupture, but we were not sure. And right MCA was also treated with flow diverter assisted coiling this patient, and this is the left MCA aneurysm. And we'll just show you the picture. This is the 2D picture, and this is the 3D. Now, something like this. You see in this angle, I mean, more of lower divisional, very broad-based, very sessile. Let us show you in other angles as well. How does it look like? Something like this. So, how to treat? Ajay, we are all tired. You are fresh.
This is ruptured, not ruptured.
There was a diffuse bleed. Truthfully, I felt most likely the distal ACI had ruptured, but it was diffuse blood. So we had to treat all three, but we staged it. We didn't treat it. She had come in late evening, and that evening we just went and coiled the distal ACI aneurysm. But I wasn't sure that this hasn't bled. I couldn't say because blood was everywhere.
There was no acute bleed, no, of this one. The
By
bleed
the time,
was in the previous setting.
by the time we treated it, it was like a week or 10 days after the bleed, all right? But we decided that since there's a small probability this one has bled, so we just went ahead with this one also, right?
Yeah.
But at late evening when she had come, we just treated the distal AC, as you can see, because to me that explained the clot there and bilateral bleed, not the MCS, but yeah.
So either...
So let us treat it this unruptured.
Yeah. Either Y stenting and coiling or single stent and just jack that stent against the neck. Shelving of the stent in the inferior division and the coiling.
Dr. Rahul is there, he's a keen neurosurgeon.
Or you can have nowadays you can have contour plus stent. That
right.
can also be.
Rahul, and then we come to contour and stent. Okay, so, Rahul, now look at this view. This is almost like down the barrel view. And I will show that later on as well. 1 second, sorry. All right, something like this. Now, in this angle, Rahul, if you see, the aneurysm is almost like it's involving the whole circumference of the MCA, or at least 80% circumference. So, by keeping, can you reconstruct it completely?
Yeah, definitely we can reconstruct it, because if it is an unruptured one, there are not so much of adhesions. We can block the MCA for some time, and we can even put multiple clips. So this can be very nicely reconstructed.
Yeah, I've seen a lot of my colleagues, Dr. Rahul is also very experienced, they do reconstruct these aneurysms. We should know that option. Of course, since we are discussing, I didn't do that, but still it's an option. And Vincent, how would you treat this one?
For me, it would be an oversized atlas plus coil in the inferior branch. When you oversize the atlas to 4 mm, 4.5, it's just an unsheath maneuver. And you have the complete, so you can protect two branches with just a simple maneuver, and then you just coil.
All right, so yeah, I thought about that, a single stent, whether atlas or anything else, but I was just worried. It is so shallow. Once I've deployed a stent, how many coils will I be able to place in it?
Okay, you do in simulation, you size the atlas, and you see the size that is allowing you to have enough closing of the neck at or against the superior branch. It's very easy to do. Just have, yeah.
All right, that's a very...
It's not a difficult aneurysm in my view with one stent and coil. I don't think so.
All right, and here you can see this is the down the barrel view as we like to create, and we were discussing in the slides course as well. This tells us what all is involved and what all we want to coil or how we want to reconstruct. So we decided to use a baby Leo, but I was not sure I will be able to get a complete packing in. So we decided to use a balloon in the upper branch as well, what we call as the hybrid technique. So that I didn't want to shelf it initially. I wanted to partially deploy it so that I can get a coil into all parts of the aneurysm. That was my worry. If I shelf it, it's too shallow. There will not be enough space for good coiling. Atlas is a great stent, and we have seen a lot of progressive thrombosis with Atlas as well, and changes the angle as well. So we use an Eclipse 12 in the upper branch. I think we use Synchro and Headway for delivery of the stent. I think now, well, so this was the strategy. Partially deployed stent here, balloon here, so we can get a dense packing in and we can reconstruct. Having a partially deployed stent also means that I can reposition the micro, which to me becomes very important in such a shallow aneurysm if need be. And in the end, complete the deployment like this, which is what I think Vincent meant by Atlas. Atlas will come on like this anyway by itself, yeah. But I just wanted to be sure I get the coiling part done and I end like this, so yeah. I mean, so this is what we did. So here we use 2 axes. We want to have 3 systems in because one guiding we really want high up to deliver the stent properly. All right. This was a working projection in one plane. So we just place, I think, balloon in the upper branch. Let me see if I can make it slightly faster. Eclipse 12. And we, as I mentioned, we use this kind of pigtail shape on this synchro a lot to catheterized arteries coming at an angle at a bifurcation. We found this kind of shape very useful. So it's very convenient. And that's the headway microcatheter, and that's super curved synchro, which really helps to hook these arteries. And then you just turn it around, and once you are there, then you can keep going in. So whether for flow diverters, we really love to lose this shape in synchro wire. And then this was the shape we give to the micro, so it points downwards, it doesn't hit the wall or of the aneurysm, and so that will help us in the coiling part. So just to show you how, yeah, we wanted pointing like this because stent is going to push it up. So we wanted pointing downwards to get the coiling in. And I think we have used a long first coil. Again, I think in this aneurysm, first coil should have to go around everywhere for us to have a long-term good occlusion. And this is again a Babylio, 2.5 by 30. We use longer length because in shelving you lose length a lot in the end. All right. So I deployed it partially, didn't try to shelf now, so there's enough space for the coil to go around. Then you form some coil loops, and lower division we are not worried about because stent is there. We don't mind bit of overlap because we know coils has to come on side and inflate the balloon. Now we know we are absolutely secure. We are sort of creating, at this point, like creating a bifurcation there, all right? So the stent is not fully open. We are not hyper expanded the stent and partially deployed stent only so that coils can go all around. And now I will make it faster. Then we can coil. We are not worried about here. We know they have to come on the side for us to get a cure in the end, long term, because the aneurysm is involving the side wall. And you can see microcatheter can back off. That is what I find convenient with this technique. With 2 stents or complete deployed stents, microcatheter you cannot reposition. Here we can get the micro come back, come in. You see it's come back, come out, doesn't matter. We can push it back in. So I'm very comfortable that I'm not creating too much tension in the aneurysm. And another plane you see that the end hole view which we are creating, the coils are all around the MCA, which is how we wanted the first coil to be. Yeah, something like that from the initial plan. If we are not doing that, might as well send it to surgery, you know. And then we always take a sort of a new blank roadmap to know where the second coil is going. We find that technique very useful. And you can see my micro is almost out, it doesn't matter. We push it in again, we place multiple small coils. I will just go ahead, we keep going in, and we can allow the microcatheter to paintbrush. In between, we can even deflate the balloon because now we are comfortable about the stability of the coil mass, one after another. Small coils in as many as possible. Now we are quite sure we have done it well. These coil loops are on the side of the stent, and that is how we wanted it actually in this case. From the down and barrel view, we knew that aneurysm is almost fusiformal here. And now we take out the balloon, and now we do the shelving. Now we press those coils badly in and cover the whole of the neck. So at this stage, now we have pushed it, the stent, hyper-expanded, that coils get compressed, okay? And we have covered the upper part of the neck as well now with the shelving technique. But if I had done it initially, I wasn't sure I could have gotten such a packing. That was the only thing which was worrying in my head. And then we finished the delivery. Of course, okay, we did some massaging with these. I can go over fast. This was the end result. We have a follow-up. Of course, you do a CT scan on the table. So the whole idea was that by using this, we avoid two stents. It gives us flexibility of microcatheter repositioning. We can avoid shelving so that there is enough space for us, and microcatheter can paint brush, and we can reshape, re-enter, and then in the end we shelf to create a good neck coverage as well. This is what we call as hybrid technique. Somehow I'm very fond of it in complex bifurcation aneurysms. And so comments, different options, etc., etc.
No.
For me, you are my friend, so I can tell you, I think it's too many devices in one artery, and it's a good technique in your hands, but for me it's not the future of neurointervention. It's not that. It's not the future. The future intervention will be oversimplification. Here, I mean, we take lots of things, you know, to control the aneurysms, but it's the reproducibility is difficult. There is one stent, one balloon, one micro. You need to control. So, in my view, could be. And if we have the things in 3D to make simulation, I will show you on the simulation. Probably only one stent expanded in the inferior branch with the coiling. If it doesn't match, you can cross the laser cut stent to go to the superior branch at worst, and it could be maybe less material because you only have two microcatheter into the vessel during just the time of the stenting. Just after you have one, and if you need, you can put another one. And the other thing could be to test intrasaccular. If you have an intrasaccular that is a little bit too much that it can bulge in the parent artery, you can see it in advance on the simulation, and you can select the branch that could be in danger. You go for intrasaccular, you deploy the intrasaccular, you see the result. If it's perfect, you detach. If not, you have prepared your microcatheter in the branch in danger, and then you stent and intrasaccular. But me, in my center, we will never do that. Never do that because the vision we have is simplification, oversimplification, reproducibility. And even it's a beauty of art, and again, congratulations, because it's a very nice case. So, I think truly this is not what we should push, this is not what we should strategize for the next patient. Think extremely simple, reproducible. That's why we need to fight in this direction.
Oh, okay. So what Vincent is saying, sometimes we can show very fancy techniques, but are they replicable? Can our fellows do it? Can everybody do it? Or can everybody have the same protocol? And I have to agree with him, right? Okay, I've got many experienced people.
The surgeon is in the room, huh? So it was so, you know, and he said it's just easy. So yeah, that's what we should find something that to answer him. You know what? For us, it's easier. It's even easier.
I agree. Like using the Atlas stent here, you don't have to manipulate to open it up, and definitely. Atlas, one advantage which we have seen is over the time it will change the angle of the artery much more than a braided stent. The issue here is hemodynamic. It's hitting the wall and turning. The angle of the artery is such an acute angle. Atlas will straighten it much, and we have also seen a lot of progressive thrombosis with Atlas stent. All right. So what Vincent is saying, just placing one stent and some coils with Atlas on follow-up, it would have been gone anyway, which is much simpler than what we did. Okay, a lot of preparation, great video, yeah. And intrasaccular, I wasn't confident. It was just too fusiformal. Even if managed to place whether what in the long term will be, I was a little low, but yes, and we can't waste a device. You know, with us, problem is we have to show that it will work. Maybe with modern, newer intrasaccular device, they'll get better and better, and we'll be more sure that we can get it right. But this is what I did, and maybe not in this case, but some cases it's really beneficial when we want to avoid 2 stents. If you think you want to place a stent, you don't have 2 stents, then we find it very useful, and I think slightly safer than crisscrossing stents and everything. Even as compared to a T-stenting, it gives me flexibility to reposition micro here, there, get a good packing in. Have we done so many to say this is a better outcomes? We can't say that. I mean, there are a few cases like this where we try so much. Yeah.
The result is excellent and will be excellent because it's a braided stent plus a very nice packing, so the result will be excellent. But not just, I use this case to express the vision of the specialty and where we should push, the specialty, what's the direction, especially also for the young. So the things is that, René Chapeau will be so happy to see this case. It's exactly the case. But I'm fighting a lot with René because where we are speaking about different aneurysms, he's finding all the needs for 2 balloon, 3 balloon, and we're solving, we're doing 400 aneurysms every year. In 2 years, we are treating 800 aneurysms in my center. So since I started, I've seen I never had the need to do that, in last 15 years. And my patient, hopefully, they go also probably as well as yours, the same. So my thing is we should fight to find a way to make simplification in our treatment because it's the safety, it's the reproducibility, it's the expansion of the technique, it's the mass treatment also a window because if you are very, very safe and reproducible, you can detect population at risk in the future. Because what we are doing here, we are treating, this case is rupture, but we are treating unruptured cases based on a probabilistic understanding, but we are not reducing the rate of bleeding each year. Each year there's the same number of patients that will bleed from aneurysms in India, in France, and USA. It doesn't change. It doesn't change because we don't have any strategy of detection in population and risk of aneurysms. But if you want to change the fate of aneurysms in the population, that is the ruptured case that are killing people, that means you need to go for detection in population and risk. If you want to detect population and risk, and if you want to treat in a probabilistic fashion, that means that you need to offer a very safe treatment, much safer than the natural history in the population. That means that we all need to work on something that
okay. Now, Vincent, here I'll say something. I feel very comfortable with this. Now, you mentioned about safety. It's actually, to me, more peaceful than using single stent and coil because when I start, I know I'll be able to coil. And in between the procedure, okay, maybe this was small. I could have shown some more videos of bigger aneurysm. And I know I will never increase the tension in the aneurysm when I'm coiling. I know I can reposition the microcatheter. And on dumbbell antiplatelets, even 3, and you realize the coiling doesn't take much time here. Once it's completely secured and we have got so much more space to coil, it's a very quick coiling in these cases. So yes, it looks dramatic, but to me it's more peaceful than doing a single stent and coil because it is giving me a lot of flexibility in the procedure. And I can reposition micro, I can reduce the tension, I can come out, I can go back in. Yes, I agree with you.
So next slide, we print this model and we do it in live in 2 different rooms. Okay?
Done.
Okay.
Done. Absolutely done. Thanks a lot. So, Arvind.
Do you always jail the catheter? And I think the residents should know the difference between the jailing of a catheter while coiling and going through the stent and coiling
So with braided, I always like to jail. It's too painful trying to catheterize such aneurysm through the stent later on. It's so convenient to jail, but your microcatheter should be pointing towards the center of the aneurysm and you should factor in when you deploy the stent, the microcatheter will move a bit. That's why I made sure it's pointing downwards so that when it moves a bit, it's still absolutely in the center, number 1. Number 2, we always form a loop of the coil on the microcatheter while jailing so that when the stent moves the microcatheter, it doesn't hit the wall or cause injury to the wall, particularly in ruptured aneurysm. That is very important. So we love to jail. Yes, there have been situations with baby Leo that after jailing is not working out, we complete the deployment and we go through the stent as well, braided stent. But yes, crossing through an Atlas stent is very, very convenient, much more convenient than crossing through a braided stent like baby Leo or even Elvis Evo. So yes, in those it's more of an option to go through the stent. But as I said, in favor of Atlas, number 1, it has got a lot of, even literature shows and we have seen progressive thrombosis. Number 2, it will change the angle of the artery and follow up a lot. which changes the hemodynamics quite a bit and is very easy standard stent to use. What Vincent was making a point, he has a true point. Suppose my fellow calls me up, trained 1 year back, I have to do this aneurysm. Am I going to tell him to do this technique? That's the point he's making. He's saying you have got a very good exotic technique, but is it replicable by everyone in training? Maybe I'll tell him just deploy an atlas, get few coils in, it will thrombose, it should be all right, let it be. That's the point he's making, and he has a real point there, So, but here we are discussing techniques. Maybe in this case you can get away with atlas. There are many situations. I find it much more useful than placing Y stents. I think still we have seen literature, more thromboembolic complication issues. And this gives me a lot of flexibility in coiling. I know I can get much dense packing. Once you deploy 2 stents, you are fixed. Okay, so I like this.
I think that's the reason you had not completely deployed the stent.
Yes.
One reason here in this particular case, the balloon was there on the other vessel. That's why the stent was not completely deployed. The second reason is, I think, that the maneuverability of the coiling catheter will be more when the stents are partially deployed.
Yes, sir. So here I know I'm never going to increase the tension in the microcatheter, come back, come in, paintbrush. So for me it's comforting. What Vincent is saying, should everybody do? Should every youngster do? What's making a point that we should have techniques which are replicable by everyone? What I wanted to show, I'm not saying please everybody does this, but it's an option in situations, and how to do it, what flexibility it offers, we should know as an option. That's all. All right. And that is why I deliberately took a neurosurgical opinion before I started.
No, I would have sent to the neurosurgeon. Our neurosurgeons are good. Clip.
Rahul, I took opinion, but he does neurointervention as well. So he can't be too much in favor of neurosurgery. I know if he goes too much towards surgical side, I can bring him back towards intervention. All right. So it was strategic. Okay. Let's go on to the next case. All right. Again, 65-year-old ruptured aneurysm. No opposite A1. So, faculty has been talking a lot, but not much from the audience. So from the audience, will somebody propose? How will they treat this case? Anyone? Rahul, again. Trilobulated ACOM, no opposite A1, 65-year-old, well preserved. Sorry? Double microcatheter. Well, here my brain worked a bit different. Arvind?
I do with the balloon-assisted coiling.
Yeah. Ajay?
That's it.
Balloon assisted coiling with backup of stent later on.
Trilochan?
Balloon.
I will start probably to coil the sac, understand where the loops, in which direction are bulging the loops, is it in the right or the left. So it's like called a palpation of the aneurysms. You just coil it and you see what is the direction, the preferential direction of the bulging.
Yeah.
And then I will select my stent and I will add a stent to block this.
Absolutely, absolutely, Vincent. This is what we did. We thought where each lobule is projecting. I realized if I deploy a stent to recatheterize, re-sheath stent, re-enter will be tricky. Neck is not too bad. Sometimes when you coil one lobule, you can create neck, right? And 3 lobules need different angles of packing. So we thought balloon will work very well. And as I said, whatever stent we show, more than 90-95% of cases we do with balloon-assisted coiling. And so we plan this case with balloon planning, but then we plan a lot that which plane, which lobule are we going to do first, and what shape of the microcatheter we'll need for each lobule. And because these are friable, acutely ruptured aneurysm, and so we sort of formed a strategy that shaped the micro differently for each lobule, having the balloon there. And as I said, even if it looks broad neck at times, when you coil 1 or 2 lobules, coils are bulging out, we create a neck for the third one as well. All right? You can see the cavernous is pretty warped, so sometimes, and we know it's a tricky case, small lobules ruptured, Sometimes one may like to take guiding across that cavernous thing to have a lot of one-to-one movement with the microcatheter. And let me see where, even I don't remember exactly where we ended up placing the guiding catheter in this patient. And in this case, yes. So I thought this is going to be a longish case, 3 lobules. So usually we will place, but I thought here, let us go up so that we can quickly go in and go out of these lobules. We don't want to be in this aneurysm for too long as well. I mean, it's an old lady. So then we created angle for the first lobule, which we want to catheterize, and what angle, the inferior, I think we did the inferior pointing lobule first. So we decided catheter shape for different one. In our mind, we label as superior lobule, lateral lobule, inferior lobule, so that we are communicating with my team. We use a Scepter SC in this case. We do like double lumen balloon in small arteries. And this is the shape we decided for the first one. We give a lot of complex shape. My colleague Dr. Rashnavas made this video, and he will shape them like this. We give a perpendicular shape so that we don't have to catheterize. Our plan, we never like to catheterize such lobules with a wire. Most of the patients, 95% of cases, we just catheterize with the shape. So we shaped it such so that it's pointing that towards that inferior lobule. He give it a perpendicular shape in this case. And just with a gentle wire massage, we move in 2 planes. We are looking at which lobule we are entering, and we started to do that one first. All right. If you see, I haven't even inflated the balloon. It doesn't matter. We only inflate the balloon when we need to. Otherwise, play around. From the lobule, the coils are coming a little bit into the base. Let us see what did we do then. And okay, we take run. Are we comfortable with this? We are comfortable with this, I guess. We are calling that inferiorly pointing lobule, as we called it in our head. So I will sit with my tech, make all those angles, right? This is the angle for this, this is the angle for this. You do a lot of preparation before you move in. And then, of course, as I said, we were very fond of this, at least in the flip system, the blank roadmap shows where the coils are going very, very well, where the microcatheter tip is. And even balloon, when we inflate, you can see it's partial inflation. You don't need a dense balloon inflation. Now, once we have done this, we thought anterior lobule, as we call, we gave it a J shape. I think the eye points to that, what we call is the anterior lobule, and we reshaped a micro, and then we entered that part. And from the base itself, we started coiling that part. So it's peacefully done. You take your time. And as you start coiling, we increase the heparin a bit. Well, major issue in these cases, acute SH. And then for this lobule, we do a reverse shape microcatheter. We shaped it like this so that it points up. We don't have to catheterize. Also, we don't have to use a wire there. And then see, it is pointing by itself with this reverse shape. It is pointing by itself there. We take out the wire, and then coil was going here. So we can inflate the balloon a shade, and with some loops also you can catheterize. And then if need be, we can inflate the balloon. So you see, we have created the neck. Once you have coiled this much, the neck of this lobule has become actually smaller. Again, a partial inflation, soft inflation of the balloon, so that still microcatheter can move around. These are ruptured aneurysm. You don't want to have a very strong inflation there. And again, you start coiling these part. One coil, and then one coil is in, then some small coils at the base. Again, you can see at the base now, the base we are coiling among all this coil mesh. It's very important to have a feel of the coil, that you're not pushing the coil against too much resistance in this small ruptured aneurysm. And so we managed to get all the 3 lobules. So then you take different angiogram, different angles, they're truly thrombosed or not. The challenge, why they're truly thrombosed or not, because one of the issues is, if there's partial filling left, and when you do such packing in small arteries, thromboembolism can happen. Then you want to give injectable interpolated agents. If there's some filling left and you give injectable, then it becomes a dangerous situation. You know, you will not have progressive thrombosis. You may actually recanalize the aneurysm a bit. So we really like to be sure that all the lobules are thrombosed. So we know if you have to give more drug and heparin, now it's safe. So at this stage, we just increase the heparin because we want to avoid the interpolated agents if possible. So in aneurysms, our heparin level, we keep increasing. At this stage, we want our ACT more than 250 for sure. Of course, we check all the vessels. And then when you do such coiling in small arteries, we watch them for half an hour for any clot formation. And still, in front of no clot formation, they can form clot, small artery, very broad neck aneurysm. So we did give aspirin to this patient post-operatively to prevent thromboembolic problems and carry it on. So as I said, balloon-assisted coiling is a very powerful technique. We love it in acute subarachnoid hemorrhage. One has to, as Professor Vincent mentioned, where each lobule, how you're going to shape, how you're going to point. We like to catheterize them without wire in all these small aneurysm patients. Balloon need not be always be overinflated. It's partial inflation, no inflation. All of this is important. And we change our micro. You don't use the same micro because they lose their integrity. Be open to using a new micro catheter to get a perfect shape in. Like we use a simple J, we use perpendicular shape and reverse shape for the 3 lobules in this patient.
So in this case, the magic was not only the balloon, but the different shape and yogasana of your microcatheter, different yogasana, I'm saying, different shapes.
Yogasana, yes.
So that was seriously impressive. Those
as you say,
hyper shapes.
Yeah, I just wanted to show to a lot of youngsters that balloon coiling is good, but we have to shape the micro. We need not catheterize the wire in acutely ruptured small aneurysms, and with multiple shape we can catheterize them. And if you are patient, even broad neck aneurysms, you can coil, keep coiling, and slowly you create a neck. First 2 lobules create a neck for the 3rd lobule, and one can do all of that. So balloon coiling just remain a very, very powerful technique in acute cases. I mean, and that is all the message which we wanted to give.
Yeah, because if the shape is good, the catheter is going to be in the center of the aneurysm, and the coiling will be very much easy, and it is very much stable, we can see.
Can I ask one question? Yeah. Excuse me?
No micro will take 3 shapes and remain fine. So you have to use a new micro in these kind of situations. One may try, but at least 2 micros one would need. Once you have shaped them perpendicular shape, it will never take a perfect reverse shape, all right? So be open to using a new micro in the procedure when you're reshaping and re-entering. Yeah. How we decide? Okay, suppose, look at this aneurysm. If I use, we know any superior pointing ACOM usually will need reverse shape. Microcatheter will point down, you want it to go up. I can go back to this previous case. So we see from the parent vessel and what angle the aneurysm is rising, right? And in our mind we do. I know some Japanese said they can create 3D models and that itself predict which shape we work in our mind, all right? So we know ACOM superiorly pointing aneurysm will usually need a reverse shape. Inferiorly pointing usually is a J. And eccentric pointing lobule, we give a perpendicular shape. So you look at the parent vessel and angle of the lobule, and then you imagine how the routine microcatheter will go. Sometimes if you're very confused, give J shape, try to catheterize, and once the microcatheter, the way it's pointing towards the aneurysm, you know what secondary shape you need to give. You bring it out, give it that second shape, and then send it in. All right? It's a whole section. We have lots of videos showing different shapes of micro, how to catheterize. We don't have time for it. But yes, I think shaping is very important. As I said, 95% of cases, we never wire in ruptured aneurysms. We just use the shape to enter. Only ICA bifurcation aneurysms, you have to wire. A1, ACA posteriorly pointing, you have to wire a bit to catheterize. So there are very few aneurysms in particular location that we need to wire them a bit. Otherwise, most of the aneurysms, you can enter them just by the shape. And build with torque of the Traxxas wire. Traxxas wire is great to give torque. We love headway microcatheter, but they take these complex shapes and remain stable pretty well. Yeah.
So while removing the microcatheter, any threat to the coil mass, which is too much of shaped, bent too much?
What about the coil mass?
While removing the catheter, which is too much shape.
Okay, that's very important question. Not the shape, but yes, removing the microcans, and these are not as very soft coil, they can pull back the coil loops a bit. So while removing, we always do is we'll inflate the balloon, we'll use the Traxxas wire, and clear the tip of the micro and then withdraw it very slowly and usually with balloon inflation. Okay, a Traxxas has 3 centimeter tip. When the dense part is aligned with the proximal marker on the microcatheter, you know the tip is by and large clear, and slowly under balloon inflation will withdraw the microcatheter, because soft coils, loose coils at the base, sometimes loops can come out with the microcatheter. It's an important point which you raised. We always do this. We never withdraw just like that.
So just to add to the taking out of microcatheter, as Dr. Vipul is telling, with the help of Traxxas, the 3 centimeter, What we are doing, the last coil pusher wire we are using for that, because pusher wire is also having a marker, 3 centimeter marker, and when that marker is ahead of the 3 centimeter this thing, then the coil is pushed, and it is.
I used
this
to
is the
use
way.
that, but a long time back it happened that one of the coils, it was detached, but detachment still stuck to the micro. The pusher wire is thin, it still cleared the tip, but the coil detachment was still stuck with the micro and it came out. So we started using a thicker wire for this purpose. So you are right, that's one of the ways to do it.
What we do, we take at least more than 50% of the pusher wire outside, because many a time there is microfilament which might be in contact of the mechanism, the detachment mechanism. So after taking out 50% at least, then slowly go back with that, because if some microfibril it has come into this microcatheter tip, it can be pushed again.
Yeah, once we had a problem, so we just started using a thicker wire, and the wire will not come out of the micro. So you see, pusher, when you are aligning with the proximal marker of the microcatheter, the pusher wire is outside the microcatheter tip. All right? So, but yes, wire, you are using a stiffer wire. One may say that it is just safer to use the coil pusher for it, but once or twice, in spite of that, we had a problem. So we started using the Traxxas wire we love, just to the tip of the micro, and slowly withdraw, but balloon inflation is the key. Keep the balloon inflated in that process, all right? So I think maybe we have time just to discuss one small case before we end. What do you guys say?
You are the boss.
Huh?
Yeah.
You are the boss.
I am the boss. The audience are the boss. Yeah. Yes. Okay. I thought, all right, let's come to another small ruptured aneurysm. I mean, we want to discuss them because these are all of us see them a lot. These are major practice. So something like this, how would you treat? You can again go back. Small ACOM.
Intrasaccular.
Ah, yes, you are absolutely right. Intrasaccular will be wonderful here. And so, which one would you use, web or contour?
Web, yeah, because it is O17, so you can go very distal, easy, and it has the shape, so.
Perfect, perfect. Yeah, I mean, yes, it does look like a great case for web. I mean, the problem in India is, I think the problem with us, because it's more costly than coiling, and because we end up doing coiling, none of us have done that many webs. None of the 100 webs in this country, so, and that becomes a challenge. So, and Ajay, coiling?
Balloon assisted.
Yeah. In fact, as soon as this picture came in, Ajay was like, okay, simple. Done. Yeah. So, nothing complex about this case, just maybe we want to show some simple things. Balloon placement. You'll use a balloon or not?
For these narrow neck and when the aspect ratio of aneurysm is good, so we do simple coiling just to save on the money. The balloon is there on shelf, so if I need it, that is by secondary intention, but in such aneurysms, just a simple coiling, microcatheter and coils, that's it.
Great. I mean, you are right. I mean, we use balloon because I feel the challenge is not coiling. Challenge is to pack it in a way at the neck that don't come back. Again, as I said, number one, Indian patient may not follow up, or in follow-up, you have to do a stent and coil. The cost issues are there. So to me, the problem of balloon-assisted coiling is not the coiling part, it's trying to reconstruct, so the chances of recurrences are as low as possible. And
especially this tubular,
sorry?
Especially tubular aneurysms, the coiling packing density may not be optimum if the balloons are not used.
Yeah, and another thing is, if you go back, if you see in this plane, I'm sorry, we are going ahead. Let me see. Yeah, when they are superiorly pointing, you know, when the inferiorly pointing microcatheter points very well, and you can pack them hard. When they're superiorly pointing, microcatheter tends to back out at times, and then you're stuck with it, right? So I really wanted to pack it at the neck pretty hard, and as I said, most of these cases nowadays we just use balloon because it is so convenient, and very few cases, there is severe spasm or something like that, that we'll do without a balloon. All right? Another thing which I would like to show, okay, so the challenge here is to take the balloon safely in an angulated artery. As I showed, we're just trying to show. I always use the needle to shape the synchro. We form that pigtail shape, which we are very fond of. And we sort of rotate my finger around it to give it a very, very tight pigtail-like shape, which I find very useful to catheterize. Then after that, it's not a problem. And in these cases, we like to use, when there's a sharp angle, we like to use double lumen balloons. And as you see, with that shape, it's not so easy, and we send the wire very distally so that balloon goes in without much trouble. So we tend to take a wire very distally, and then you just withdraw the wire, and the balloon is in place. After that, at times we take a repeat road map, as I mentioned, because, and in this case, again, it was superiorly pointing, so we'll give a reverse shape, because routine inferiorly pointing aneurysm you can do with a J. Here we'll give a reverse shape. Just to show you here, 1 second, see, okay, what happened here? Can somebody, something, 1 second. Guys, can you help? Okay, you see whenever I'm touching, let us go back. Somebody has asked about the shape, so let me go here, here, here. If you see here now, how the microcatheter is pointing superiorly in this angle, and the wire shows the shape of the microcatheter. In this plane also, you can see it's pointing towards the neck, so we don't really enter the aneurysm. When it's pointing like this from the neck, we know we can peacefully coil it from there. Sizing of the coil is very important. The first coil, you want to come up to the neck. And in this case, we use a long coil. In spite of that, it kept going in. As you mentioned, tubular aneurysms, this can be a problem at times. So I'm coiling practically from the neck, and we haven't inflated the balloon at this point of time. Okay, anyway, once balloon is there, so when the catheter is trying to back out, then we inflate the balloon a bit to put in the last part of the coil there. And more coils at the neck. We know with balloon in place, we wanted to pack the neck very, very well. Problem in India, repeat treatment is the cost. Small neck is left. And then we decided to place more coil at the neck. But the coil should sort of integrate it with the previous coil. You can't have loose coils loops there, okay? And what we are doing here, there was a small projection near the neck here, and I really wanted to get it. So I was okay with, again, some small tip remaining outside, but I wanted to get that part of the neck around here. You can see it was shaped like this. So we managed to place one more coil, little bit tip hanging out. I thought I can live with it, because now we can safely give her aspirin or anything and get this shape in the end. So give us the best chance that there is no recurrence. Small tip remained out. I was okay, I detached it. But rather than taking out that coil, because to me, that shape was very, very important in trying to prevent a recurrence. Only follow-up will tell us how well the patient does. So I don't think there is anything further. So when a tip like this is out, we watch it for a while. But small coil tips usually don't cause any thromboembolism. We just gave more heparin and aspirin, and the patient remained fine. So just to say, we love balloons for this reason, because it's not the coiling part. You have to get a dense packing in. Number two, in Indian patients, we have to coil the neck as well as possible. We can't have this, will bring back the patient. Most patients will not come back. I mean, and we have to try to have a dense packing, not just some coil loops in. Balloons, they're very useful. The shape of the microcatheter is very useful. Most of these cases, we just coil them from the neck, small ones. And whenever catheter starts to back out, you can inflate the balloon, make it stable. And small tips hanging out, will live with that rather than underpacking, and we know patient down the line will need a repeat treatment, which gets complicated mainly because of financial issues. Yeah.
Actually, that small tip that was there in the end of the procedure, I think we need not bother too much about that. We have to put on the antiplatelets, which I usually follow in almost every case in the ACOMs. We put the aspirin, one to prevent the thromboembolism, and I have a feeling that when you put the patient on aspirin, there is a hypothesis that delayed cerebral ischemia happens due to the microthrombi. Aspirin prevents that. So I have seen that after putting the patients on this, the incidence of the delayed cerebral ischemia is less. I am not telling it is completely ruled out, but it is less.
Raj Srinivas, where is Raj?
So it's my practice, almost every case I put the patient on aspirin.
Yeah, that is useful when you are doing such kind of packing near the neck. Even if coil tube is not hanging out, clotting can happen. So number one, same thing, we increase the heparin, we watch for any clotting, and after extubation, even if you don't have a right to give them aspirin and give it for a few weeks, and that usually suffices. Yeah, Raj, can you come over? Yeah. I think we have some more cases, but it's almost 6 p.m. I think we have to end now. Everybody's tired. So one thing which I want to invite Raj Srinivas. So come over. So Raj Srinivas, he was trained stroke neurologist, joined me in Medanta, was trained in neurointervention, and we have worked together for now I think 11 or 12 years. In fact, majority of the intervention he does. I think this case was done by him only, this last ACOM. So he's very good. He has made all those videos. So I think I really want to give a big hand. He has made this meeting possible. And he's one of those self-effacing guys who doesn't want to be prominent. I didn't invite him to do lamp ceremony, but he will not come himself. But he's a terrific interventionist, human being, and a very good doctor. I really trust him. And I think 60-70% of cases which we showed were actually done by him, and all the videos were made by him. So without him, this meeting wouldn't have been possible. So I'm really thankful to him for all the effort he has made. Yeah.
Thanks, Raj.
I think, thanks a lot. So I think it has been a long day, and and it's almost 6, and I think we should end. I'm really thankful there are so many people sitting at this late.
Thank you, Vipul, for the Congress.
Thanks a lot, Vincent, and everybody. And Tufail, again, 4 days, continuous hard work. Vincent, a lot of effort. And I'm so thankful to Vincent to organize that slice training in the country. I was so keen on something like that for so long. So to me, this whole thing, slice followed by this, is a dream come true. The kind of meeting I have wanting to hold for a very long while. And I want to thank everybody. And our industrial partners, Medtronic, Stryker, both of them, they contributed to the slice training as well as this meeting. Then Bolt and Microvention and N-Vascular. Can we have the slide for the sponsors, please? I think everybody's tired. And even the Rapid AI and Hester Diagnostics and Philips and Abbott, they're all, and really thankful to Medtronic and Stryker for contributing for this slice program, all the devices and the backup you gave us. But even the rest of the industrial partners were very, very helpful in organizing this meeting. And I'm really thankful to all of them. And so let us give a hand to them. I don't know how many are in the hall. And look forward to organizing such programs more, and please give us feedback what we can do better. We have recorded these lectures. We are planning to put them on a site. We are going to collaborate with Vincent to build an online teaching platform as well. And so to us this is a start, but your feedback, we can do it better in future. Thank you.